Good evening, everyone. I am Sharna Kamal, host for today's event.
Good evening, everyone. Ramadan Kareem. I'm Palniappan Lakshmanan, co-host for today.
World Optometry Day is celebrated on 23rd March as a symbol of celebrating optometry as a profession. Let's go back to 1986 when Dr. G. Bart Holmes, former president of the American Optometric Association, took ownership of International Optometry and Optical League and transformed it into a dynamic organization committed to improving vision care standards all around the world.
Following that year, Dr. Holmes proposed to celebrate World Optometry Day as a way of raising the bar in optometric education at the global level by establishing this day as International Day for Optometry.
The Nobel Initiative started, the global movement started. But still, we have difficult time in explaining people what optometry is and what we really do. But we all know that we are part of a noble profession and always be proud what we are. Celebrate the gift of vision, a revolutionary step in gifting sight, isn't it?
So today we are celebrating World Optometry Day to take this noble initiative move forward towards a bright future for optometry fraternity. Proud to be an optometrist. We welcome you all for this OPTOVERSE3 Optometry Conference. We welcome you on this day. Let's take a pledge to examine every patient's eye with love, creating a small impact on others, revealing our true selves and our purpose for the needy as an optometrist. Happy World Optometry Day.
Happy World Optometry Day to all. Thank you everyone for joining this knowledge fest on the eve of World Optometry Day. We virtually welcome you all in Dubai.
Ladies and gentlemen, may I have your attention, please?
Thanks, team, for such extraordinary breathtaking welcome video. Welcome everyone in our virtual auditorium. Now, I'd like to call Dr. Omnia Hammam to inaugurate the third version of Optoverse. She is the senior glaucoma surgeon in Sheikh Shahbud Medical City and Zayed Military Hospital. She is also the head of scientific committee of Emirates Society of Ophthalmology. Over to you, ma'am.
Hi, good afternoon. I am really honored to open this meeting, and on behalf of the Emirates Society of Ophthalmology, we are endorsing this Optoverse for the second time. And the reason behind supporting the Optoverse and the optometrists, that we believe that ophthalmologists, they cannot move on without the optometrist committee. So one of our main goal starting this year is to have the working group of optometry which will lead it by Mr. Kamal as well. And we are putting all the support to the optometrists. I would like today to announce as well that we'll have even a sponsorship for them if they want to attend certain conferences from the society itself. I would like to next time that this meeting will be in person, not virtual. And hopefully next time that you can have also all the attendees coming to Abu Dhabi or to UAE in any one of our beautiful cities for an in-person optometry conference. Last year, this meeting actually exceeded the expectation, and we had a very positive feedback from all the optometrists. Plus that the maximum attendees as registered were in the OPTOVERSE meeting last year, and I think so it will be the same this year. Happy Ramadan Kareem, and happy Optometry Day. Thank you so much.
Thank you, Dr. Omnia. Thanks for your enormous support for our optometry profession. So let's move forward to today's scientific session. The first session is ocular dispensing, the art of prescribing. The word prescription is derived from Latin term prescriptus, made up of two Latin words. Pre means before and scriber meaning to write. Now I call Mrs. Devakani, Senior Optometrist from Sheikh Khalifa Medical City, Abu Dhabi, to moderate our first session. Over to you, Mrs. Devakani.
Thank you, Bala, for your warm introduction. Welcome, everyone. Ramadan Kareem. Wish you all a very happy World Optometry Day. I would like to invite Dr. Krishna Kumar for our first talk of this event to share his expertise on prescribing guidelines for refractive errors. Dr. Krishna Kumar, popularly known as KK, works for Shankara Nethralaya Eye Hospital, Chennai, as an advisor for the optometry services. Prior to this, he was heading the Optometry College, the famous elite school of optometry. And Dr. Krishna Kumar has initiated eye test at the doorsteps for the elderly group, which is very much welcomed by all the public. And he has got 35 pure publications and initiated 2 optometry books. Over to you, Dr. Krishna Kumar.
Thank you very much. First of all, I'll share the screen. That will be fine.
Yes, sir. Please.
Okay. Hope it's seen.
Yeah, we can see your slides.
I can hear me as well. Yes.
Yes, we can.
Thank you. Thank you very much. And outset, actually, once again, I also reverberate the day, a unique day for us, World Optometry Day. In India, I think it is also a great year for us. Last year and this year, I think a lot of initiative towards regulating optometry, practice and education is happening in a big way. Instantly, I was there in the ministry meeting, yesterday. We are re-looking into our syllabus, aligning with the competency. I think and it is a great day for us, as for all of us. At this juncture, I was really happy when I was invited to be part of this, reputed Optoverse. I understand it's the second Optoverse, a unique combination of both ophthalms and optometrists coming together with one goal of sharing the knowledge is indeed a great and noble thing. It's a hats off from my side. And my topic for today is guidelines of prescribing glasses. As we all well aware that today, I think whenever you go and look for the literature, there are a humongous amount of literature available talking in terms of guidelines of prescribing glasses, predominantly restricting to the prescribing art towards children. And since it is there available in the literature, you would have heard about this guidelines from different people, in different forums, and also since I understand majority of you are practicing optometrists and ophthalms, I don't think I'm not going to add if I'm going to repeat and show you the guideline. So I thought I would like to share some of my own experiences within the time permit available for us. I'll try to see whether I could cover 10 simple cases, and purposefully I'm not trying to give a full detail of each cases, but relevant informations for each of the cases and why I prescribe like that, so that you see that how these guidelines can sometimes go away from the routine guidelines per se. So that is the forefront, I think, which I want to share with each one of you. With this, I'd like to confirm that want of time, again, I'm not going to go beyond this 4 key condition, and I've added one more in relation to on how some of the treatment lead to some of the induced factor called myopia. Apart from that, I thought if there is some relevant question, we can take up during the discussion. I'll go to the first case. A patient with asymptomatic, who is a preschooler, was found to have +2 diopter sphere in both eyes at the end of the detailed eye examination. His vision was 6/9 N6 using the Leah symbol, and binocular vision were normal. I assume that this is one of the dilemma predominantly among the eye care professional who are in the beginning stage of their career, will do is to have whether I need to prescribe this +2 diopter sphere or not. The question which can be prescribed, no, need to be answered with big no, nothing need to be prescribed. What is the funda behind prescribing? One, all these guidelines insist that if a person has got of the age up to 2 or 3 years, since they are the preschoolers, since the need of thing is not very high and they do have adequate accommodation, probably they might not be an amblyogenic factor in this case. So therefore, we need not to prescribe. This is the funda behind why +2 diopter for preschoolers not to be prescribed. But moreover to that, I think demetropization aspect up to 7 years, we have to look closely. Prescribing it should not be a hampering factor for the demetropization is another school of thought. Irrespective of it, there are 2, 3 guidelines. Some guidelines say the cutoff is 3 diopters, up to +3 diopters, we need not to prescribe. Some guidelines lift up to +5 diopter or so. Irrespective which one you believe, keep the funda behind it, why we need to prescribe, why we should not prescribe. The one simple tip which I always suggest is, if you are doubtful about it, a simple way is to refer to the concerned expert and do the follow-up later. Or otherwise, try to follow a conventional approach of prescribing it, keeping in mind probably you might be disrupting the demetropization. So the first one is the better option predominantly. Some people, they try to suggest that why not you closely follow up to the extent of, instead of 6 months, you try to make them come 3 months, which I think with majority of time the complaints will not be too great among the parents to bring those children. So keeping that mind, a +2 diopter sphere with a preschooler, and there is no other binocular vision issues, and rest of the thing looks normal and there is no deviation, I think need not to hesitate not to prescribe. I think that first thing which I want to reiterate. We can go to the second case. In this case, an asymptomatic 6-year-old was found to have +0.5 diopter sphere. Kindly underline +0.5 diopter sphere and 6-year-old in both eyes at the end of the detailed examination. Parents were moderate myopes with no astigmatism and binocular function found to be normal. Now, again, the question comes, can we prescribe? I think many of you would have decided by this time. This is a clear-cut, direct case why we need to prescribe and solve. There is nothing that you're going to solve per se. The patient is having +0.5. Probably the patient is having 6/6 vision also. So why we need to do anything? The question is, itself has got a clue for it. Whether we need to prescribe fully, of course, partial doesn't have meaning. Whether we need not to prescribe, probably, which many of you would have no thought by this time. And I've added something to it, whether we need to do some counseling. Where from the story comes? The story comes that whenever I see any of these patients with around 6 years or up to 10 years, anywhere less 0.75, 0.5, around that case, and 0.25 around 9-10 years, plus 0.5, 0.25, then I always keep them very closely watched for the possibility they might be ending up around 12-13 years as fresh myopia or late onset myopia as described by experts. So the ideal thing in this case, keeping in mind there is a risk factor associated with 6-year-old having plus 0.75 and less, which probably around 12-13 years might being manifest as myopia is well, and there is an evidence adequately for us. So we have to keep in mind in this case, though we did not going to prescribe, but we have to insist that sometimes 6 months of follow-up or even yearly eye checkup will be appropriate. So keeping in mind there is a risk factor associated with child and there is a strong family history of myopia, why not you try to advise an outdoor activity? Probably you can go by this 1.5 hours or 2 hours has been done in few countries, or insist that allow the child to be to go and play in the outdoor, especially exposing him or her to the sunlight, and balance gadget usage. Again, I'm leaving to individual. The literature evidence doesn't carry much if you don't balance it with outdoor activity. The gadget usage is not a big risk factor as compared to less outdoor activities. Adequate illumination is another factor that you can account it for whenever you do the counseling. Since you are trying to see that there is a risk factor, this child might manifest as myopia later part, you always take a baseline biometry, which simply means take note of the anterior curvature cornea as well as the axial length, which is more than enough to start with. If you feel that you can't do any of these things, please don't hesitate, since you have a very good network with ophthalmologists, especially pediatric ophthalmologists, and people who practice myopia control are the one who can handle this better, or you can try to have teleconsultation. Today, I think they are trying to introduce the term these children probably we are dealing with not hyperopia, pre-myopes. So that is the reason. Second case, though I do agree, as all of you thought, we need not to prescribe, but as a guideline, try to keep that we have to try to have close watch of these children and also add some counseling tips. Hope I making some sense here. So we can go to the third case. This is slightly more interesting and we are open case. A child is definitely having moderate visual impairment in both eyes, which improves in pinhole, and the dry flash shows high hyperope of 4.5 or plus 5. Wet flash using the appropriate cycloplegic, because there is no scope for discussing about cycloplegic, I'm not getting into it. We know because based on the age and based on the deviations, binocular vision status, we always use the appropriate cycloplegics. And I also see it differs from clinic to clinic, hospital to hospital, country to country. So I leave it to individual decision making. As long as you feel that that drug which is actually maximizing it and bringing out the manifestation of the hyperopia, that will be the appropriate one. Of course, conditions apply that it should not lead to some of the adverse event. The acceptance in this case, because child was responding well, it was +5 with plus 5.5, though the vision didn't improve only one diopter. Underlined, there is an ESO deviation without and with glasses of this denominator, there is no ESO deviation. I'm not talking about accommodative esotropia. Again, I purposefully not to discuss about accommodative esotropia. I also come across very often in all the session. That's one case which has been discussed and enlightened adequately. This is a very simple hyperopic cases for the people who are beginners who have the dilemma. For one line, why we need to prescribe a 5 diopter. Some people, they as a novice, they might have this dilemma. I always say no, or whether since it's not improving, are we dealing with amblyopia and therefore we try to distract with any of the active therapy or passive therapy, which is the first way of the approach. So what is the gold standard that we have to follow, which predominantly experts do follow? No doubt, I think we have to give full correction, despite that it is improving. At that point of time, only one line. So the most appropriate method is give full correction, do follow up for after 2 months, or sometime 3 months in some people do follow. Forget about it. What is that you're going to see at the end of 2 months to see whether there is a visual acuity improvement to the maximum or not? If it is improving, then you have yearly check. Always ensure the ESO deviation being looked closely. And it seems that most of the time, if this doesn't improve, that is the time you have to have interaction with the concerned pediatric expert, or you can try to think about either passive therapy, go by the conventional occlusion therapy and see whether there is an improvement, or active therapy. In rare scenario, I've seen some of the experts try to combine with, especially depending upon the denominator they are dealing with, which in my experience is not worth an exercise that we need to do for children. So go by the first step of giving full correction, closely watch it, then try to see if it doesn't improve, combine it with passive therapy, or look for the reason why it is not improving, have a solid interaction with your pediatric ophthalmic experts, and then take a call. So that is the third story which I want to share. The key thing here is try to follow up, don't jump to the next exercising on the eye. The fourth case is very, very simple case. I think many of you would have seen a child, a 10-year-old, manifesting minus 1.25. I think definitely, even if there is no family history, we know that we have to prescribe. Many a time we will see that these are the patients, probably during the exam time, they will be manifesting as accommodative spasm 1, and it get relieved once you use the formite and then recheck, or after the exam, it will come back to the normal. But many a time it might be a simple true myopia, which always you're going to counter check with your cycloplegic correction, especially when you have the doubtful when it is onset is in the later period. So there is no family history of myopia. I think in this case, what we need to do, whether we need to prescribe, it looks like that we have to prescribe. Yes, I do agree that we have to prescribe. So one of the key things is don't try to do an undercorrection. Though there is only a few anecdotal evidences we do have an undercorrection, both are actually more harmful. But usually I've seen that most of the forums talking about in terms of myopia, they say, please avoid undercorrection. Now there is few school thoughts have started coming up. Why not? Why we should not do the undercorrection? Because there is no adequate evidence of so. But as of now, the practice is do full correction, don't do the undercorrection, or actually ensure that optimization of whatever you're going to give. Ensure full-time wear. Again, in this case, keeping in mind, it might be an induced factor, keeping in mind this child probably can have the progression, even if there is no family history. I also go with the same points which we discussed in the last case of plus 0.5 6-year-old. In a 10-year-old with a manifesting myopia, I also go with the thing. The reason why I'm reiterating this many a time is, as optometrists, I have never seen people prescribing, the interest in prescribing and dispensing glasses and not going beyond that unless and until the parents asking what else they can do. Most of the time, parents tend to ask what is the nutrition supplement they have to take, or they want to take the spinach or other carrot and so on, at least in Indian context. But we as an optometrist, being aware of it, I feel strongly, in addition to prescribing, always insist on some of the key aspect of outdoor activity, reduce gadget usage. You can also open it in a 10-year-old, explain the importance of it. Same thing as I told before, keep baseline biometry and have the yearly eye checkup. Now, the same case, after some time came, and that I'm sharing as a fifth case, with a minus 2.25 sphere exactly after a year. Rest of the parameters It looks fine, except that there are some changes in the axial length, and corneal curvature looks relatively no steeper, but that not big significant variation. But a 0.1 diopter of jump, I think it is not showing much of the variation technically. So rest of the finding looks normal in this case. So what we need to do, it looks like it jumped from 1.25 to 2.25. Is there any yardstick that we have to keep in mind? This is the time, I think, instead of just jumping and prescribing glasses and leave the child to come again the next year, that today I think yardstick you should keep slightly or think more than that. This is the time you have to talk with the parents related to how this increase in myopia has happened. Probably it is the time there is an alternative approaches are available, both in terms of pharmaceutical means wherein you have to take do co-management with the ophthalmologist, and the optical means. Today there are companies who have come out with some proven evidences. Some evidences of orthokeratology is also there. Still, I'm a strong believer of pharmaceutical and optical as far as the evidences in these cases. But I also seen some of the evidences from orthokeratology group wherein they are showing strong evidences for powers like this. I think I'll leave it to you. The key point here is referring to the myopia control and counseling about the myopia control. If you do yourself or ensure to connect them with people who are venturing into it, will be a great add-on dollar to the patients and the parents at this juncture. Again, as an optometrist who doesn't have this facility, many a time we don't try to do this referral part of it, which according to me is part and parcel of the guideline. At the end, we want to do good to the patients who have come to you. So ensure, again, rest of the stories are same, no outdoor activity, reduce gadget. In this case, usual yardstick experts try to climb it. If there is a jump of around in a year 0.5 and more, in some places 0.75, you can keep 0.75 and more, then try to see that is defined as the progressive myopia in that context, especially when you're going to deal with the children. Now, the question many a time people tend to ask, if I'm going to extrapolate to a teenage person of 16 years or 17 years, whether this is going to work or not. The evidence is not strong, but the evidences by interacting with experts in India who are dealing with myopia control, they are showing that there is a strong evidence of atropine working in even relatively elder patient. And whether there will be rebound effect after stopping, again, I think that should be left to the elders. So it is very, very important that we have to keep in mind whenever you're dealing with simple myopia, especially with the era of myopia control, don't miss out this opportunity as part of your guideline. So it is very, very important. We might be dealing with pseudomyopia. We might be dealing with accommodative spasm in this age group. Once you're ruled out and if you're very confirmed about your finding, after doing appropriate techniques like cycloplegia and ensure that there is a real progression, and if you have adequate biometric evidences as well, then I think that is the time you can always think about myopia control in appropriate way. Please don't try to jump in all the cases. I think you have to look for some evidences before you try to jump. The next, probably it is not the case. I will try to shell out some of the tips that related to the astigmatism. Once again, there are challenges around this area. Whether the low withdrawal astigmatism, and even if that is an asymptomatic, we need to give the correction. 80 to 90% of the time, it doesn't going to serve any purpose. Unlike if you see a low against the rule, I've seen that predominantly it is not only helping the person for distance, but also it helps in terms of the near perception. So kindly look into this two rules and try to see if it is worth a while to follow it. High with the rule, I think there is no dilemma among people that we have to go for correction. The question comes that with high astigmatism, whether we need to prescribe it fully or whether we can prescribe partially, need to be decided by whether there is an amblyogenic factor, especially in children. If it's going to be adult, whether we need to prescribe it or not. I think many a time I've seen in adult, we can go not to prescribe fully, they don't accept. I'm talking about adult in this case. When I saw a 25-year-old, when he first time he was in life, he's been diagnosed to have minus 2.5 diopter, whether I need to prescribe the minus 2.5 or not. So I usually tend to do not to give full correction when the person doesn't appreciate with and without in his day-to-day life. Until then, he started appreciating only in the clinic there is a clarity of vision with the new glasses. Then I try to go the spherical equivalent technique, where I try to do the partial cylindrical correction and help the patient. And slowly within 6 months to 1 year period, the patient will tend to accept full correction as well. Oblique astigmatism, it's another big area. I think in the era where we still talk about digital eye strain, more near work and related story, I've seen people with symptomatic or asymptomatic. I've seen people give correction. It works in some cases. Sometimes I've never tried to give oblique astigmatism without symptom, but I've seen many people try to do that one together. So I leave it to each individual. Oblique astigmatism, always try to go by the individual response in terms of the symptoms and then try to give correction. Of course, if there is a vision benefit, don't hesitate to provide it. High spherical with low astigmatism. Many a time low astigmatism, when I say if there is up to 1 diopter, think 100 times whether that astigmatism is adding to his vision clarity. If it doesn't, you try to show whether you can add it to the spherical part of it. Maybe you can take the half of it and try to add to the thing. A lot of good the patient will make. These are some simple tips. Probably many of you follow it, but I thought it might add value if I reiterate. So as I told, first time detected astigmatism in middle ages, you can apply the spherical equivalent technique. I missed the word equivalent here, so that will be easier in terms of adaptation. But keep in this case, though I'm going to talk on pseudophakic later, pseudophakic people with eye astigmatism, sometimes surprises might happen for reasons. And today we are not seeing that much with the toric lenses and other thing, but sometimes some surprises we might face. And if there's some reason surgeon is not taking up for replacing, or surgeon is not taking up for some reason, then in this case, even if you up to 6 diopters, I've seen the adaptation is faster. I don't know, many of you would have seen these cases, but many a time I've seen surprised that adult in post-operative period, in the class appointment time, they tend to accept these things. But again, I think individual experience can put hold there. The sixth case, which I want to share, is in terms of a 2-year-old, which is more in terms of educating many of the optometrists. Sometime when we are going to sit in optical showroom, and when you come across a child of 2-year-old, which sometime might end up undergone IOL implant, recently for reason they didn't go to the optal, and optal also would have not prescribed, or would have prescribed for some reason the patient come here, and you found that the child is having +5 diopter objective refraction. And the dilemma, usually we have been taught that, as I told, up to 5 diopter, in some cases, it's an amblyogenic factor irrespective. In this case, already the child would have been a deprivation amblyogenic aspect was there. In addition to that, now refractive should not be a component. So naturally, we need to prescribe. But we have to have in mind that this was purposefully intended, a target for a 2-year-old. I think if you go and look into residual, refraction in these cases, depending upon the age at which start is maybe 2 years. I understand there is a session on IOL. Maybe you can discuss that during the time. But what we have to keep in mind as an optometrist, you expect residual accommodation, residual refraction in child who underwent IOL implant until 10 years of age. Maybe around 10, 11 years, they will try to put the target of plano IOL. But the target will be plano residual refraction. But you have to keep in mind, in this case, since it's amblyogenic factor, that you don't get surprised and waste the time of referring and wondering. If at all you want to have a clarification, you can call that surgeon and find out whether you can go ahead with the prescription or not. There is a dilemma in this case also, if it's going to be anisometropia, how to handle. I think the same situation like any other anisometropia, you have to handle in this case. So yes, keep in mind, this is also amblyogenic. Try to follow closely up to 7-8 years. It would have become plano. And that is where we try to explain the symmetropization. That is the justification the surgeons would have given you why they have targeted the residual refraction of +5. Since a want of time, not going to get into the detail, please, I thought this will be one of the key tips when we are sitting away from the hospital or even in the hospital in a different department, we might miss the story. The seventh case, again, very simple. Yeah.
Dr. KK, sorry to interrupt.
Yeah.
You have another 5 minutes to wind up?
Yeah, I think I can find it.
Okay,
At 62, it's already time. I'm taking extra time.
Little bit. It's fine, Dr. KK. Take maximum up to 10 minutes now.
Or else what I can do is I can take that as a discussion, so I don't want to interrupt. So I will go to the final slide.
Okay.
That will be fine. So I'm sorry that way.
Thank you. Thanks a lot.
Okay, that's fine. I don't know. So I think I want to reiterate, keep in mind, do not rock the boat in children with hyperope. As I told in first case, do not miss the boat in children with low hyperope. Probably you're dealing with myopia in future. Do it correctly, fully in amblyogenic risk, high hyperope with ESO. Do prescribe fully and counsel in low myopia and if it is going to be progressive nature, by appropriately referring. Do not forget residual refraction as part of any IOL, and therefore if there is an amblyogenic, purposeful amblyogenic purposeful residual refraction. Do not dock the boat, which I want to share, but I will do it unnecessarily in elders with which I know that extend their depth of focus lenses are coming into the market. Try to not to disturb. There you always interact with the consultant, surgeons, and decide. Do not fall into the trap of multifocal elders, especially I'm not talking about IOL, just bifocals and falls is one of the risk factors in elders. Do not hesitate to give low plus for accommodative microfluctuations. Some of the good positive stories were there. I think you can always keep in mind, though I'm not a great believer of blue cut lenses, but there are in cases, do see for sudden onset myopia and migraine, especially when they use topiramate as one of it. I think these are the key points that I want to share with you. Sorry for the extended time. I think we can take up few questions during the discussion. Thank you once again.
Thank you, Dr. KK. That was a very, very informative session. And the cases were very good. We come across cases like this every day. So it will be a very good guidelines for all our optometrists here. Now, I would like to invite Mr. Arnab Banerjee.
Yeah, am I audible, ma'am?
Yes, yeah. Mr. Arnab Banerjee will be here for the second talk, and he is going to share his experience in methodology of prescribing prisms. He is currently heading the Department of Optometry at NSHM Knowledge Campus, Kolkata. Prior to this, he was serving as an assistant professor at Brainware University. He holds master's degree in optometry and his areas of interest are orthoptics and vision therapy. Over to you, Mr. Arnab.
Thank you, ma'am. I will just share my screen.
Yes, please.
Is my screen having full screen, ma'am?
You got to put it on the slide share, please.
Yes.
Are you able to do that on slide share?
Yes.
Oh, okay. Yeah, now it's fine. Thank you.
Really grateful to the team for having me today in this celebration of World Optometry Day. So today what we are going to see the very basics of how you are going to prescribe prisms. What are the different methods of prescribing prisms in different cases. We are not going into very details because due to the constraint of the time. So as you know, as we move about, we know what is a prisms, right? It is a triangular structure with when the light passes through the prisms, the object or the light moves towards the base and the image of the object moves towards the apex. And by definition, so if a light passes through one diopter prism, there will be a shift of that of an object which is passing, whose light is passing from the prism. There will be a shift of 1 centimeter if that object is kept at a distance of 1 meter. So that is by definition. So we know 1 degree is equal to 2 prisms diopter. So that is what we are all, which is a very basic thing. And one prism diopter, so to be accurate, it's actually 0.57 degrees. So we have got 2 types of prisms. We have got round prisms and we have got Fresnel prisms. So round prisms can be made into the glasses, and Fresnel prism, it can be pasted over the glasses. So you can see the structures of the round and the Fresnel prism over here. So round prisms, they can be made into the spectacles. And what are the advantages? So suppose if there is a non-paralytic squint and the amount of deviation is 12 prisms, you can split the prisms of like 6 between the 2 eyes. So you can split it so that the one side doesn't become too heavy, and there is a symmetry of vision. But as it causes a very minimal blurring of vision, because it is inside the glass, there are no cylindrical apertures, like just like as that of the Fresnel prisms, which are made up of lots of small prisms. But so that causes a minimal blurring of vision, and it is easier to clean. You can very easily clean the lenses. But when you are prescribing it in the glasses, you cannot prescribe more than 6 prism diopter. So you have to prescribe 6 prism diopter in each eye. So that makes a 12. Though I have seen some of the glasses which have made around, means they have made 10 prisms in one side, but that is not a very useful or not a very convenient method to prescribe prisms. But another disadvantage is that when you are prescribing these round prisms, it makes the lenses very heavy. Now we'll come to the Fresnel prisms. So the Fresnel prisms, you can pound it from 5 prism diopter to 40 prism diopter. So suppose if a patient comes to your clinic who has got a more than 12 prism diopter, suppose the patient had a requirement of 20 prism diopter, then you have to go for a Fresnel prism. Also in cases of paralytic squint, suppose you have a measurement of 12 prism diopter, but the patient is much more comfortable if you place 12 prism diopter in one eye, then you splitting up between 2 eyes. So in those cases also, you have to give a Fresnel prism. So anything above 6 prism diopter or maybe 7 prism diopter, you have to opt for a Fresnel prism. And it is easier to stick and remove, but it is difficult to clean. And as the prisms amount increases, so if you are given some 15 prisms, if you have given 20 prisms and one person you have given 25 prisms, so 25 prisms, the person who is wearing 25 prisms will have a will have a blurred vision than the person who is wearing 15 prisms. So with the increase in magnitude, the blurring of vision increases. So this is the structure of a Fresnel prism, where one side there is a base. So the base will be written over here, and there will be a 20 prism over written on what is the amount of prisms. So if you have got a Fresnel prism where the base is not written, so you can look at an object through that prism, and you will see that the image of the object is shifted to one side. So when the side where the image is shifted, the opposite side is the base. So that is an example to how you can find a base if the base is not written. And this is a prism trial set. So you can use. So you can use prisms in strabismus. You can use as a field expander. Not we can say we can expand the field, but we can bring the objects which is in the non-seen area into seen area. And you can eliminate the abnormal head posture. So for strabismus, you have got 2 types of prisms. You have got exercising prisms, and one you have got relieving prisms. So suppose this is an ISO deviation, and you want to find out how much is the ISO deviation. So you place 10 prisms, you do a cover test, you see there is still remnant, some ISO deviation is there. You place 20 prisms and you do a cover test, and you see it is perfectly neutralized. That means 20 is the amount of deviation, so which is the relieving prisms. But now the same case, suppose in the ISO, the patient, you want to make the eye straight. So you want to push the eye from its ISO position to this primary position. In that case, it will be reverse. So for an ESO patient in exercise in prism, you have to place base in prisms, and for an EXO patient, for exercising to make the eyes in the primary position, you have to place base out prisms. So it is just the reverse as that of the relieving prisms. Now for phoria, we follow, for especially for exophoria, we follow the Short's criteria. Now this comes up when you are a little bit confused, like which point you should start. So suppose a patient comes with a 20 prism exophoria, and you want to give prisms for this case. So which prisms you should start? So then you should measure its positive fusional vergence. So positive fusional vergence has got 3 points, which is blur, break, and recovery. So 12 is the blur point, break where there is a total depletion of the fusional reserve, and 14 is the recovery. So put it in this formula, and you will find that how much amount of prism that patient may require to get this to get a orthophoric position or to get relief of the symptoms. So for a 15 PD exophoria who has got a near PFV of 12, 16 and 14, you may need to start with 6 prism diopter. If you see that the patient is able to maintain the fusion with 6 prism diopter, then it's all right. But if you find that, okay, no, the patient is not able to maintain fusion with 6 prism diopter, then you may need to increase. So till 12, you can split it between the eyes because it's a non-paralytic squint. But in cases of paralytic squint, you might need to give the full correction. It depends upon the paralysis, but in majority of the cases, you might need to give a full prism correction. But some orthoptists or some optometrists do not prefer to give prisms more than 20 because there will be a very much blurring of vision. As a result, it will act as an occlusion. So many a times, means when the other experts which I have spoken to, they do not give prisms more than 20 or max 25. But somehow we have also prescribed till 30, 35. But you should always prescribe prisms which is very minimum and which causes less blurring of vision. So this is for exophoria. Now what is for esophoria? So suppose the patient comes with an 8 prism esophoria and you measure the patient's negative fusional vergence, which is the divergence, and it comes at around blur is no, there is no blur for this example, 4 is the break and 2 is the recovery. So you put it in this formula and then you can start, you get a 3 prism base out. So you can equally divide, you can divide 1.5, 1.5 in between 2 eyes or 2, 2 in 2 eyes to see what is the fusional status. And then you need to go further if the fusion is not maintained. Now this is the 2 examples, the above 2 examples was for horizontal deviation. So what happens in cases of mixed deviation? Suppose there are 2 deviations, horizontal also vertical. So here lies the Pythagorean theorem which determines the power, in which if you have found this example has got a 15 prism base out and a 10 prism base up. So you do the square of both this, you add it, do the square root and you find 18. So you should start with around 18. So again 18, if you are giving 18 prisms in Fresnel's, you need to give Fresnel because it won't come within the glasses. But in Fresnel's, you won't have 18 with you, you will have 10, 15 and 20. So you can start with 15 and see what is the fusional status. So that is how you can find out the power or the point where you should start with. And this is the formula where it will help you to find out the degree. So V by H is equal to 0.66 degrees and you get a tan inverse of 0.66, which is 33 degrees. So if you are doing an 18 prism, if you are placing a 15 prism, in this case you start with 15 prism, you have to place it at 30 degrees. So that is how you can find out the axis and the power in case of deviation which are both horizontal and vertical. So this is also the chart. So in case if you don't remember the formula, you have the chart. So you can see there is a 15 prisms and this is the 10 prisms. So if you calculate both, means if you could find out the meeting point, you see it comes around 30 degrees. So this also gives a very good estimation about what should be the axis of the prism when you are giving it in an oblique manner. So this is the rotation guide. So when you are prescribing it, this will be useful in when you are prescribing the prisms. Suppose this is for the left eye. So when you are placing the left eye, suppose you are placing for an XO with some vertical deviation. So you have placed it around in the trial frame, it is showing 30 degree in the left eye. But originally, when you see in the rotation guide, it is 210 degrees. So you have to be very careful. Like if you are prescribing, say, 15 prism base in and base down at 210. So this rotation guide should be there with you. When you are prescribing the prisms, you should be very careful about the angles, because here the 30 degree symbolizes that it is a base out, it is not base in, but you need to give base in. So you should be very careful while prescribing the prisms, because it varies, means the degree will vary with the orientation of the eye. So when you are applying Fresnel prism, you find the base, you align the base with the lenses, and you first outline, you make an outline where is the frame, what is the frame size, and then you cut the prisms slightly smaller than the line and clean the lenses, test the lenses, remove the water and dry. So this is how you should go. You should start putting the Fresnel prism. We have a video in which we have done a patient who has a vertical deviation as well as a horizontal deviation. So here you can see on the EOM, the right eye is not going down. So there is a depression limitation. So we check the EOM seems to be fine. So we have to place the prism, because it is a paralytic or a restrictive squint, you have to place the prism before the right eye. So we place the right eye with the glasses, we do the cover test, and we found that still there is a movement, and we asked for the patient's response. We slightly rotate it and we did the cover test again, and we see if the movement, if there is no movement and the patient is also responding, yes, there is no double vision, it is a single one, then you can start cutting the prisms. So then you can, so this is how it looks like, the Fresnel prisms. And here you can see that the base is in the down, here is the base. So we cut the prisms, and it has to be like exactly with the frame, otherwise it will pop out. Means if you keep just a little bit also, if it is not aligning with the frame or with the lens in the frame, then it will come out after a few days. So you place the lens, you cut it, you can see we have cut all the sides, and now but we have to still make it finer adjustments. So we are here now making the finer adjustments, and so the remnant which is there, which is a little bit popping out of the frame, we are also cutting those so that it doesn't it remains stick on the lenses, and then we clean the surface both the lens, because after you have cut there will be debris. So we have cleaned the lens surface of both the lens and the prism. We pour warm water, a mild warm water, not very much, like it should not be boiling water. We put a slight mild warm water, and you should press it, and you should keep the bubbles out. So this is how you can paste a Fresnel prism over the lenses. So this is just a video, and this is the end product. So you can see it is done neatly, and there are no edges which has come out from the sides. So this is how you should cut it, and you should paste it on the frame of the lens. So now comes the binocular prisms, where you can use an EOF prism. So this we are using in cases where there is any scotoma. So suppose there is a homonymous hemianopia. So this is a right side homonymous hemianopia, where the patient is not seeing the whatever object kept in the right side. So we put a prism. So you start with hemianopy glasses. So those are large aperture frames which can where you can place the prisms. We have a picture after this slide. So you can place, and you can see whether there is a shift of the images. So the aim is to whatever object is lying in this patient's non-seen area, it should come within the patient's seen area. But generally, if it is like not full homonymous hemianopia, it is slightly some damages has been there. So in those cases, you can place still 6 prism, and it will work very fine. But if it is like complete hemianopia, then you have to place a little bit of larger prisms where you are in 35 to 40 prisms. So each eye, so this is the base, and this is, sorry ma'am?
You have another 5 minutes to finish.
Oh, yeah. I will finish, ma'am. Don't worry. So, yeah, we will place prisms in this side. The base will be this. So, whatever objects lying in this area, the patient will be able to see in front of the eye. So, obviously, this needs certain adjustment. The patient needs practice at home. We said you practice at home, and then you should go outside of the house. You should not go directly outside of the house with these prisms. And it is generally prescribed 2 mm away from the pupillary zone. So in cases of abnormal, so this is the hemianopy glasses I was talking about. So in this process also we place the yacht prisms, and for that the base should be kept towards the face turn. So in this patient, the base should be at the face turn. So left eye should have a base out, and the right eye should have a base in. And you can, for this hemianopy glasses, always try within 6 prism diopter. Because if it is more than, if you are giving more than 6 prism diopter, you have to give Fresnel prism in those cases. And if you put 2 Fresnel prisms in both the eyes, then it will have a difficult, the patient will have difficult to see, or the patient will have a very hazy vision. So this kind of prisms are also helpful in nystagmus. So this was all about the prescribing prisms, where we use the prisms in strabismus. You can use the prisms in seeing, bring in the non-seeing areas, objects lying in the non-seeing areas or hemianopic areas to seeing areas, and we can also look for the correct the abnormal head posture. There are other use of the prisms where you can prescribe the prisms even in cases of autistic cases, or even the patient who have a walking difficulty, who walks with the toe up. So those cases you can put the prism base down, but we have today, for the time constraint, I am not included in this. So again, I would like to thank for giving me the opportunity, and I like to wish everyone a very happy World Optometry Day. So thank you, ma'am.
Thank you, Mr. Anna.
Thank you, Mr. Arnab Banerjee, for that insightful talk. Now I would like to call Mrs. Devakani for our next talk. She is going to talk on low vision aid practice and dispensing in the primary eye care. Mrs. Devakani graduated from Elite School of Optometry, Shankar Nethralaya Eye Hospital, India, and currently working at Sheikh Khalifa Medical City, Abu Dhabi. She has completed a master's in optometry and currently pursuing PhD. She is an expert in contact lens and low vision services. She is also a member of Emirates Society of Ophthalmology and associate member in British Dispensing Optician and World Optometry Council. Over to you, Mrs. Devakani.
Thank you, Bala, again. Can you see my slides? Am I audible?
Yes, you are audible. Just carry on.
Yeah, and slides, you can see my slides also?
Yes, we can see. You can make the slides to please.
Okay, I'll put it as a slideshow. Good evening all again. Okay, today my talk will be on low vision practice and dispensing in primary care. So low vision has a different definitions, like not correctable with the glasses, contact lenses, surgery, or medicines. And if the vision impacts our daily life, we label it as a low vision. And this type of vision does not include complete blindness, because there is still some sight and it can be sometimes be restored with a good help of visual aids. Although there are several definitions for low vision and blindness, the most frequently used definition is stated by WHO, which states that a person with a low vision is one who has impairment of visual functioning in the better eye, even of treatment, and or standard refractive correction, and has visual acuity of less than 618 to light perception, or a visual field less than 10 degrees from the point of fixation, who uses or is potentially able to use vision for planning and for execution of tasks. As per WHO, Vision impairment is a global term that includes individuals with low vision and blindness. So based on the levels of the vision loss, they have graded vision impairment as grade 1 to grade 5. And this tabular column shows a classification of the visual acuity ranges, categories, and the visual impairment. 0 is mild or no visual impairment, where the vision is better than or equal to 6/18. And grade 1 is moderate visual impairment, worse than 6/18 or better than 6/60. Grade 2 is severe visual impairment, worse than 6/60 or better than 3/60. And grade 3 to grade 5 is a blindness. The ICD-11, International Classification of Diseases 11, classifies vision impairment further into two groups as distance vision impairment and near vision impairment. Distance vision impairment, they were categorized as 4, like mild, moderate, severe, and blindness. Mild falls into like visual acuity worse than 612 to 18, moderate 618 to 660, severe 660 to 360, and blindness anything worse than 3/60. And near vision if the acuity is worse than N6 at 40 centimeter. And as per the WHO, the visual impairment is an important health problem in both developed and developing countries. The estimated number of visually impaired people worldwide is 285 million, with 39 million being blind and 246 having low vision. According to WHO, an International Agency for Prevention of Blindness Vision report in 2019, 2.2 billion have a vision impairment or blindness. Among these, 1 billion have a vision impairment that could have been prevented or it has to be addressed. So this 1 billion people includes those with a moderate or severe distance vision impairment and blindness due to unaddressed refractive error and cataract. And other causes will be age-related macular degeneration, glaucoma, diabetic retinopathy. And some of the causes in children will be albinism, optic neuropathy, trauma, and congenital malformations. In young adults, it will be late onset congenital disorders, eye refractive errors, ocular injuries. So who is at the risk of having low vision? Anyone can be affected. Because of the age-related disorders like macular degeneration and glaucoma, low vision is more common in adults over 45 and more common in adults over 75. For example, 1 in 6 adults over age 45 has low vision and 1 in 4 over age 75 has low vision too. Leading causes of visual impairment, uncorrected refractive error and cataract plays a vital role. And role of optometrists is to restore the lost vision. So after comprehensive eye examination, optometrists can, if they come across a low vision patients, they can do the low vision assessments. I'm not going to go through the assessment steps. I'll just tell you how to choose the optical magnifiers. And there are two most common low vision devices which we come across in our, which we all have in our clinics. They are magnifiers for seeing objects close at hand and telescopes for seeing objects far away. There is a large range of optical magnifiers in different magnification strengths and sizes, and this depends on what reading type is required. And low vision, it's just not one person who can solve the problem of the patient. It depends, like it is a multidisciplinary teamwork. We get a referral from the ophthalmologist and it goes to optometrist. Optometrist does a low vision assessment, and from there they'll take the call where to refer, whether to a rehabilitation specialist, occupational therapist, or to the physiotherapist. So the assessment involves determining the best corrected visual acuity for near and distance, and determine the visual acuity that patient requires, what is his requirement, calculate the magnification needed to achieve. There's a simple way to calculate this. The magnification is given by the inverse of the visual acuity in reverse of the distance visual acuity. For example, if the vision is 20/200, this can be reversed at 20/100, and this gives a 10 diopters. So this will be the starting point for the near vision magnification. So here in this example, if you see, like when you calculate the magnification for near, it's patient's near acuity by the target visual acuity. For example, if the patient reads N24 and he wants to read a newspaper, here the small tabular column shows N point. N8 will be the newspaper print. So you have to simply divide N24 by N8. And for reading fluency, use a target print size goal as a 3 lines smaller or 2 times the required magnification. In this example, it is 24/8, which is 3 magnification. And for fluency, make this as a 6 magnifier, so that you'll be able to achieve the print what he was requesting. And similarly, for the distance, it's a best corrected distance visual acuity by the needed visual acuity. So acuity demand in the classroom, for example, if you're treating a kid, his demand will be like around 6/12. So if he's having a 20/63, if he's sitting in the front, keep 2 lines in reserve, that is 20/40. And so the target acuity will be 20/40. So again, the same example, 20/200. He wants to see blackboard. In this case, a blackboard denominator will be 20/40, 5 times magnifier. So you're starting telescopes for the distance. You can start with the 5x telescope. Let's have a look at some of the magnifiers which we all, like most of the clinics will have, and these are commonly prescribed in our clinical practice. These are hand magnifiers, bar magnifiers, dome magnifiers, fixed hand magnifiers, and spectacle binoculars. The advantages being with the hand magnifiers, they are flexible working distance and posture, self-illumination is possible, large range of magnification is available, they're compact and portable. Disadvantages being cannot be used for prolonged reading, requires a steady answer. So difficult to search and find the target for high-powered magnifiers. High magnifiers have a low field of view. So whenever you're prescribing any magnifiers, instruct the patients how to use a magnifier, like reading material placed on a flat inclined surface. Find the correct focal length by placing the magnifier directly on the page and moving it towards you until the letters appear big and bold without distortion. Stand magnifiers, almost same like our hand magnifier. The only disadvantage being is it needs a flat surface, and it's difficult on some surfaces, not easily usable on all the surfaces, cosmetically unappealing. And it's also difficult for people with the postural problems. Must set device as a precise focal length from the reading material. Pocket magnifier, as the name indicates, they are constructed to be carried around in the pocket. It has a wide range of magnification. It's portable and self-illumination is possible. The only disadvantage is the lesser field of view as the magnification increases. Spectacle magnifiers are the best one to start with. So the spectacle magnifiers can, this gives a binocularity is possible with the spectacle magnifiers. So try eye addition, and this can be prescribed for both eyes equally up to about 12 diopters. And for the, we need to also prescribe basin prisms as per the amount of plus lenses you're prescribing for reading. Dome magnifiers and bar magnifiers, these are also given in some instances where close reading is recommended for the kids. Fresnel sheets, they are used to magnify the image. Plastic sheet with the concentric grooves. Higher magnifications are not possible as they cause distortion. They are thin, lightweight, pocket size or page size, and they have a good light gathering properties. So this is a column which summarizes like what are the magnifiers available with the different magnification. So once we arrive at the magnification, we can have a quick look at the tabular column and choose a specific magnifier and try it on the patient. The commonly prescribed telescopes in the low vision clinics are handheld telescopes, clip-on telescopes, bioptics, contact lens telescopes, and the monocular telescopes. These are some of the another important, easy ones to prescribe is the contact lens telescopes. This can be successfully used when the magnification for distance is required is only less than 2x. These are the other examples of the spectacle, spectacle mounted telescopes. So points to be remembered when you're prescribing the any optical device. You can pair the optical device with the non-optical device when needed. Always use a spectacle correction before using a magnifier. Add the near correction to the spectacle magnifier. Do not dispense any of the low vision devices without giving proper training and making the patients understand about the do's and don'ts. If needed, conduct another training session. Let it be more than once, or it can be like 2 or 3 times also. And handheld magnifiers are important tool in low vision students' toolbox. These are the instructions, we have seen some instructions on for the magnifiers, and these are some of the instructions when you dispense a telescope. You got to instruct the patients how to localize, focus, to spot the object, then slowly trace and track. So it will be easy for them to spot the object easily when they look through the telescopes. So again, a lot can be done when the patients comes to your clinic, when we empathize with them. So with the help of the assistive devices and technology, even a person with a profound visual impairment can be successfully rehabilitated. Use simple and easy methods to begin with. Aim for near to give as much magnification that gets patients to N5 so that he'll be able to read the print which he was requesting or expecting to read. So these are some of the websites where you can share with your patients. Some of them are have a free access, and some will be have a little bit of a payment, but they will these have a very good softwares. These are my references. Thank you for listening. Happy World Optometry Day again.
You can start reading the poll, Kenny.
Wait, I didn't get the poll here. Okay, so please stay tuned for the poll questions. There are some interesting poll questions here.
You can read from your mobile.
Yeah. Okay, fine. So the first question is, you are about to write the post-operative spectacle prescription for a cataract surgery patient with a macular degeneration. The best choice for the reading ad for the patient with a 20/70 best corrected visual acuity would be +3, +3.5, and +7. Second question is, power of the prism mostly depends upon media on which it is kept, angle, thickness, or all. And your third question is, image formed by a prism is virtual, erect, displaced towards its apex, inverted, real, displaced towards apex, virtual, inverted, displaced towards apex, then real, erect, displaced towards apex. And your next question is, the normal resolution visual acuity level of 6/6 is attained at the age of 6, 3, 4, and 8. And the last question is, the change in stimuli perception from scotopic vision condition to photopic vision condition is best explained by Purkinje shift, photochromatic interval, visual adaptation, biphasic threshold. And yeah, there's one more last question. Contrast sensitivity peaks at 2 degrees, 3 cycles per degree, 3.5 cycles per degree, and 4 cycles per degree. I would like to invite Dr. Krishna Kumar and Mr. Arnab Banerjee for the panel discussions, please.
Yeah. Am I audible, ma'am? Hello.
Yeah.
Okay. Okay. Actually, I've got a very bad bandwidth. Sorry for that. Yes, sir.
Okay. So I have
So what are the first questions?
Yeah. I'll just read out some questions. Are you able to see some questions from there?
No, ma'am.
No. Okay. So I have one interesting question for Dr. Krishna Kumar. Dr. KK, you had said about the prescribing spherical equivalent. So is that with a mixed astigmatism, or should we also follow that in myopic astigmatism? We can't hear you, Dr. KK.
Yeah, I think that is where actually literatures talk about. I was insisting on, whenever you see high astigmatism and whenever you suspect that the patient will not take up fully,
yeah,
I always feel that we should not push the high cylinder and insist the patient will adapt to it.
Okay.
I think the olden days, probably in 90s, we used to have a concept called leaf room, wherein whenever we prescribe, especially we try to prescribe, I think I'm very comfortable to use oblique astigmatism with the rule or against the rule. The kind of distortion the patient is going to appreciate is well demonstrated with the leaf room technique. Today, I think we don't have those kind of approaches. So therefore, I always feel that the experience counts whenever you suspect the patient's adaptation is a challenge. Then don't try to jump with full cylinder, especially when you're dealing with late picked cases in astigmatism. And the second thing which I was insisting in terms of children, children also, depending upon the astigmatism, usually it is understood they will get adapt fastly than the others. So I've seen many a time they do prescribe fully. It's going to be with the rule or against the rule astigmatism. So the question on mixed astigmatism or other thing is actually doesn't come into my approach towards whenever you deal with astigmatism, unless and until someone else has got a different view on that.
Thank you, Dr. KK. Let me put one question to Mr. Adnan.
Yes,
Mr. Adnan, you spoke about Fresnel prisms. There's a question from one of the participants. You said like we can cut the Fresnel prisms. Like, is there any particular way where we cut, or the method how to do it? Because we have seen the prisms are round, and you have shown the two corners. So should we keep something in our mind before cutting the prism?
Yes, means after the main thing, when you are placing a Fresnel prism, it is easy in cases of horizontal prisms. You can keep it at 180 degree or maybe at 90 degree and you can cut it. But if it's an oblique prisms, so if you have to tape that angle of 40 degree, and if during the cutting, if you are when you are just placing the prisms, you place at a different angle, and you have cut it and you have tested, you cannot change after that because it is already in the shape of the lenses. So what I do, it may vary with different practitioners. I generally paste it before and I place it on the patient's eye. I made sure that whatever angle I have kept, the patient is seen at a single. Then I take it out. I keep it pressed so that it doesn't move here and there. Then with that, you have seen in the video with the prism is pressed, means I have pressed it with my hand and I'm cutting the prisms so that the angle doesn't move. Also, I don't cut it at fully, like means all at once I don't cut it. I keep it a little bit bigger so that if I need to make certain adjustments, I can do that. Because if you cut it all at, means just at a single glance, if you cut it fully at the shape of the lenses, and if there are some adjustments required, you cannot do that. So I keep it. I didn't ask the patient to wear. I asked him whether still there is a single vision. The patient says yes, still there is a single vision. Then I proceed further. So this is means what I used to do when I used to be in Shantan and Saleh. So that I used to follow that procedure. And after you have cut it, make sure that there are no edges which is out of the frame. It should be inside the lens. So some practitioners, what they do, they take out the lens and then they cut with the shape of the lens. But I don't generally pop out the lens because in my experience, I've seen 2-3 cases where the lenses was broken. So I keep it on the frame intact and I do it as per the lens. And I see it very carefully that the edges should not go outside the frame. So that if you just dispense it in with the prism with the edges outside the frame, the patient will come back after say 2 months or 1 month that the prism is it is coming off very frequently. So that's there. So that is one thing which I found.
Thank you very much, Mr. Annap. Dr. KK, in connection with the same question, are we not overcorrecting the myope when we are doing the spherical equivalent?
Okay, in this case, I think, I don't know. That is not an overcorrection, especially in this case. So whenever we talk about overcorrecting myopia, we are talking in terms of children, we are talking in terms of eye strain. Whenever we talk about the adaptation and spherical equivalent, we talk in terms of late age group. I don't think there is a question of thing. When you go back to circle of least confusion, I think we are trying to look at is trying to help the patient to get adapt to it. And as I told you, we might moving towards their full correction because spherical equivalent is an intermediary. It is not the end.
Sure. Okay. Thank you very much to both of you. For the want of time, I think we need to wind up the session 1. And I would like to hand over the session to host. Thank you to both of you.
Thank you very much.
Thank you. It's an honor for me. Thank you.
Thank you, Devakani. That was a wonderful session indeed. Thank you all the panelists for your insightful talk. Now we'll move forward towards the next session, the back to basics. Do you know what is the symbol of optometrist? It's the retinoscope, which is the most essential and basic tool for any optometrist in day-to-day practice. It's based on Foucault's principle. It states that examiners should stimulate infinity at the working distance to obtain the refractive error. So let's start our second session of today's evening, Back to Basics. I call upon Ms. Tapaswi Joshi to moderate our next session, Back to Basics. She is a senior optometrist in Rivoli Eye Zone. She is also a core committee member of UIOF. Over to you, Ms. Tapaswi.
Good evening, everyone, and a very happy World Optometry Day to all. Moving to our first speaker of this session, Mr. Rajiv Nair. He is a chief optometrist with over 29 years of experience in clinical optometry at the Eye Foundation Group of Super Specialty Eye Hospitals in Southern India. He is also leading a team of over 150 optometrists. He is going to enlighten us on the topic refraction in challenging situation. Over to you, Mr. Rajiv.
Presentation. Thank you so much. For the introduction, and first of all, I take this opportunity to thank the organizers of OPTOVERSE in organizing such an event on World Optometry Day, and wishing you all a very happy World Optometry Day before I start my presentations. Am I audible and my slides are visible?
Yes.
Yes, it is.
Yeah, thank you. So we'll go ahead. So my topic is interested to me today is refraction in challenging situations. And refraction issue, if you keep, when you do a refraction, we have many challenges. Like any refraction is a challenging refraction. I don't say that there are particular refraction which is only challenging. Any refraction is challenging because there are so many points which we need to understand or take care when we go ahead and do a refraction. So the first thing is a cooperation. When we talk about a refraction, the cooperation of the patient is one of the important factor which we need to look upon. And when you have a cooperative patient, the rest is assured that your task becomes very easy. Next point is the history. The history, you need to have a detailed or you should at least have a baseline history of the refractive history. What were they using before, whether they have been using glasses before or what kind of glasses they were using. So all these informations are important for you to go ahead and do a successful refraction. Accuracy is something which is a key of any refraction. Like we right from our education, we have been taught that we have to be accurate. We have to give the minimum minus and maximum plus. So this accuracy is something which you have to start right from your refraction. This accuracy is the key for your refraction right from checking the vision. Like, because every step is built upon the other. Like if you have a proper visual acuity testing, then it actually goes, you go to the next step where you do a retinoscopy, and then you go to next step to do a subjective refraction. So all these are connected. So one is going to the basement, that is the base of your refraction, that is the visual acuity goes wrong, everything else goes wrong. In the sense it goes wrong in the sense you will not be able to correlate one to one. So you'll end up in trouble. So accuracy is also an important factor. Lack of knowledge is another challenge you come across when you do a refraction. You need to have proper knowledge about what you are doing. You need to know the basic concepts of refraction. You need to know the basic concepts of refractive anomalies. You need to know the basic concepts of retinoscopy. You need to know the basic concepts of subjective refraction. So adequate knowledge is enough for you not to have any challenges in your refraction. Light is something which is very other important factor. Too much light or too less light, both will be a problem for you in doing a refraction. So you have too much light that will produce a lot of reflections which will affect your retinoscopy. If you have very low light, you have a dilated pupil. You have a pupil dilatation will be more, which will in turn lead to a lot of aberrations, and you will end up in getting a wrong power or a higher minus or whatever. So light is also a factor. Environment in which you are doing a refraction, you should have a proper refraction area where you have a proper lighting, where you need a proper distance at which you are checking the vision, and you should have all the instruments in place. So all these are very important for a good refraction to happen. Need of the patient is another important thing. So what does a patient actually come to you for? What does a patient need actually? So need of the patient is also an important factor, which is important when you talk about challenges in refraction. Good instruments, needless to say, the good instruments, you need a good retinoscope, you need a good vision chart, if you are doing a phoropter refraction, you need a good phoropter. All the instruments should be in place and should be in good condition. You should have good trial lenses, clean lenses, the lenses which are not rotating or giving you erroneous results. So if you look at all this, and one more thing is the challenge you face is an erratic reflex. If you come across some erratic reflex, you find there is some scissoring reflex, or you get the reflex is not clear, or the pupil is too small, myotic, or some reason where you get a reflex is not clear. So this is another challenge at which you can, which will actually affect your refraction. So the challenges, each word of challenge, you have something to talk about as far as your challenges in refraction are concerned. So are there some refractions which are more challenging? So as I said in the beginning, all refractions are challenging, right? All refractions are challenging. And if these points, the challenges, the points which I had mentioned earlier, all that has to be taken care. So keeping all this in mind, are there some refractions which are more challenging? So we will look at some refractions which are really challenging. In spite of having everything in place. Okay, in fact of having all those points which I was mentioning earlier, everything is in place. Still, you find it little difficult for a refraction. So we'll go through some cases where the refractions become very challenging. Keratoconus is something which all the optometrists, at some point or the other, you shine your retinoscope and you find a scissoring reflex, then you get to have your BP rising or your heartbeat more. So you need to know, you don't know where to stabilize, where to start, how to start, and what to do. So basically, all of you know that keratoconus is something which is called as which produces an irregular astigmatism due to a conical cornea. And this year, refractions were earlier when we were students, we were taught to do only a trial and error, and we didn't have anything in our hand except the Placido disc, where you see that distorted image, where we see that it's a keratoconus. So keratoconus is something which is very challenging refraction, where you getting a power onto the patient and making the patient comfortable. It's a task. There are various methods of doing a keratoconic eye, refracting keratoconic eye. One thing which will work well is the use of stenopic slit, and which is very simple, and which a simple instrument most of us are having in our trial set itself. So the stenopic slit can be put onto the trial frame, and patient ask the patient themselves to rotate it, and you will most probably, the patient will be able to land you. I would say the patient will help you to land in the correct axis. And BCVA, all of you know that best corrected visual acuity of keratoconus patient will depend on the extent of the cone. And of course, if you have access to a topography, then that makes things very easier for you. We have been, in our practice, we see, every day I come across 2 to 3 patients of keratoconus on a daily basis. So in my experience of refracting keratoconus patients, I have some tips for you to take home. This is a patient, you see a topography image, and this is a very early case of keratoconus. You can see an asymmetrical bow tie. Here, and this keratoconus is something which is very easy. In the sense, you have the keratoconus easy refraction. This is almost, that this keratoconus is easy to refract because it's quite a symmetrical cornea, and you get to get a good refraction here. This is another case of keratoconus, which is a fairly an advanced keratoconus, not too much, but still here also you can get a good refraction. You can see the axis, what is mentioned here. You can see the axis at 18 degree. But in these cases, what you need to know is you cannot exactly pinpoint that. You cannot go exactly with the topography axis. You cannot go exactly with the topography axis. So here what you have to do is, when you do a refraction, if the topography axis is showing something around 20, so what you need to do is this, you can try your axis, you can rotate your axis anywhere between 30 and 70. So you rotate your axis between 30 and 70, you are almost will be able to land up at your required axis. So this is one technique where you go with the topography axis for this kind of keratoconus, where it is slightly progressed form of keratoconus, but still this can be refracted, and patient can be brought to a visual acuity of 6/12 or more with this kind of picture. This is another form of keratoconus, which is a little more enlarged, which is a little more progressed. Here also, if you see the axis around 118, showing around 118 to 120. Here you can try your axis between 130 and you can go up to around 160 or 170, where up to 120 you can go and just try your axis, and most probably you will land up in the correct axis. There is one technique over the years I have seen that this works well. This is one keratoconus where you can see the cone is fairly centrally located, and then this kind of keratoconus is slightly difficult to stabilize with a cornea because almost a central cone. So most probably the getting a vision improved will be a little difficult, though you can give a try. So if in case, as all of us know, when the glasses don't work, of course, with any type of glasses, you give the vision, you get the best vision with contact lenses. That I don't have to tell you; it's needless to say. But this is because we try to improve the patient with glasses, is essentially to understand whether this patient will get better with any surgical procedures of like topo-guided correction, what we do for stabilizing and straightening the cornea. This is a case of pellucid marginal degeneration, and this is another case where you can try doing a refraction. It's a very high cylindrical. You can see up to around 7 diopters of astigmatism. Another case where you find it difficult to refracting, challenging to refraction is a pseudomyopia. Pseudomyopia, you come across patients with varying visual acuity and refraction, and here you find the patients are coming to you with symptoms of shorter duration. Psychological refraction is key to these patients because you will get you will get varying reflex, right? It goes from -1 to any range, or -2 or +2 or +3, or it just fluctuates. So where you get to know that there is a spasm of accommodation, and doing a psychological refraction will really help you to arrest the accommodative spasm, and then arrest, and you get to a exact, correct refractive value so that you can start the treatment. So these patients have to be put on a longer duration of cycloplegics, and which has to be eventually tapered and stopped with periodic and regular follow-up. So this is another case of another case where you find the refraction a little challenging. So here there are two take-home key messages. That is, whenever a patient comes to you with a symptoms of shorter duration, and you get a very varying reflex in your retinoscopy, then you are almost certain that you are dealing with a patient of pseudomyopia. Another case where another situation where you find the refraction a little challenging is a patient who malingers. So you have to identify the malingering. So anybody who comes to you who malingers, so it is an art. The that patient has mastered the art of malingering, and you should be mastering the art of breaking it. So it is a situation where both of you have to work in hand, the patient as well as you, to break that malingering. And at times you might have to give a placebo lenses where the patient is satisfied for some time, and then before parameters are well within the limits, you ensure that the retina is normal also. Post-LASIK is another situation where you find the refraction quite challenging. You all know that we are making the prolate cornea to oblate. In LASIK, what we do is the natural cornea, which is prolate, is become oblate. The cornea, the central cornea is flattened, and you get an oblate cornea. So you will find two different reflexes in these patients. Like you have a central reflex and a peripheral reflex, and you should always, when you refract this patient, you should be looking at the central reflex. Crispness of vision is something which is also to be noted in these cases. Like whenever there is whenever the refractive surgery has gone uneventful, normally the patient should, even if there is some residual error, patient should have good BCVA, like in the sense the vision should be very crisp. But if the refractive procedure was eventful, then you are less likely to get the crispness of vision, and of course that will be visible on the retina, on the cornea also. Topography is a key for these kind of patients. You should so definitely have a topography picture with you before you attempt to refract these patients. Pre-op visual acuity and pre-op power, pre-op central corneal thickness, all these need to be known when you are dealing with a post-refractive surgery or post-LASIK patient. If you don't have this information, then it would be better that you get those information before you give anything, before you talk to those patients, because it is very important that whatever you say, the patient takes it, and once you have this data with your hand, and then you refract the patient, then you talk to the patient, it will make sense. Subjective emphasis is more important here, because objective values, as you know, where you are refracting an oblate cornea, it is Somebody who is not talking, can you please keep mute? Okay. Yeah. Thank you. So subjective emphasis also should be given. Next, one more important condition where the refraction become difficult is the Marfan syndrome. So all of you have seen Marfan's, and you have a subluxated crystalline lens. And when you do these patients, what you look at, the most important thing what you look at is in the undilated condition, like when the patient is in undilated condition, whether the patient has exposure to more of aphakic portion or phakic portion. So you should be refracting this patient with the more available portion, the larger portion. Like if the phakic portion is larger, then you should try to give a refraction through the phakic portion. And if the phakic portion is larger, try to give a refraction, try to refract through the aphakic portion and give the correction. That is only going to help these patients. And mind it, and these patients has to be examined.
Sorry to interrupt, Mr. Rajiv. Yeah. We'll be having another 5 minutes.
Yeah. I'm almost
okay. Thank you.
I'm almost on time. Okay.
Thank you.
So this is the subluxated lens. You have you should make sure that you are always refracting through an undilated pupil. So, and most of these cases, some cases you may not be able to know that it is a subluxated lens because in a undilated pupil. But when you see that it's it's a subluxated pupil in the undilated pupil, always try to refract through the larger portion. Post multifocal lenses, patients who have undergone post multifocal lenses is another kind of patients. There are another set of patients where the refraction become a little challenging, because one problem with these patients it's not a problem, it's their expectation, is that they are highly demanding, because obviously they'll be demanding because they would have spent quite a lot of money on getting this lens implanted. And here, when you refract the patient, you should be looking at the functional vision. More than the 6x6 or N6, you should be looking at the functional vision, how the patient is able to function, or whether the patient has the multifocality, and the checking should always be done. It's better to be done binocularly rather than uniocularly, and this refraction becomes a little challenging provided. And nowadays things have become much better because you have much better lenses in place, so you get to get more the better vision in these patients now. Earlier days, when the multifocal was just invented, we had a very difficult time in refracting this patient. Now things are much better. Corneal graft is another condition where you have diffraction becomes a little tough and challenging. You should know whether it's an optical graft or a therapeutic graft. So depending on that, you have to plan your refraction. If it's a therapeutic graft, you don't have to do anything. Age and onset of the disease should be considered. You can expect a high myopic error and astigmatism because the donor cornea, it's normally a little steep, so you can expect a higher astigmatism and myopia. And you should also consider or take into account the effect of sutures when you refract these patients. So having all this in mind, once you have keep all these points in your mind when you do a refraction. So you have to meet. You have the challenge. Once you keep all these things in mind, you are actually meeting the challenge of meeting the patient's expectation. You are actually achieving the challenge of getting a good visual outcome, and you are achieving the challenge of your own getting your own satisfaction in giving the right treatment of the patient. Thank you so much for your attention.
Thank you so much, Mr. Rajiv, for the wonderful session. Moving forward, our next speaker for this session is Mr. Ranadev Banerjee. He is a senior optometrist and a philanthropic academico-clinical mentor, graduated from the All India Institute of Optometry Science. He has also enhanced his education in the field of pediatric optometry, contact lens practice, low vision management from India, Jordan, and Australia. He is also associated with Bangladesh Association for Optometry as an honorary advisor for international and professional affairs. Over to you, Mr. Ranade.
Thank you very much. Hope I am clearly audible.
Yes.
Great. So, a very good evening to everyone. And obviously, let's all celebrate a happy World Optometry Day today. So with that, my topic today would be psychology of vision, a basic understanding. Now, first of all, I would like to begin with Genesis chapter 1, verse 3, a religious text for the Christian community, which says, "And God said, let there be light. And then there was light." But I go one step ahead to say that it is the optometrist who said, "Let me refract the light and focus it on your fovea." And there was clear vision. That is what makes us optometrists complete eye care practitioners of the whole visual system. If we go ahead and ask everyone that, okay, so refraction becomes an integral part of our giving good vision to our clients, where does the image exactly go? And everyone would jump in immediately to talk about this entire visual pathway, how the light focuses on the retina and then it goes on to the brain, etc., etc. But my question still remains, where does the image go? People would again come in and talk about the different visual cortex, Brodmann's area 17, 18, 19, talk about what the brain does, etc., etc. But the question still remains, if no image goes to the brain, then how do we see? Because let us understand this thing. We do a wonderful job in placing the right lenses in front of the eye to achieve a perfect image, quote unquote image, on the retina. Whereas when we go back to our visual optics books, all of us probably would know very well that no image was ever formed in the retina. There are blur circles and iris discs. So what happens? How do we exactly see if no image is being created inside the eye and no image goes to the brain? So since we often fail to understand the process in depth, we tend to accept it and eventually we ignore it. Because we know that if we place the right lens in front of the eye and the patient starts seeing, who wants to have all those headaches of thinking how we see? But when asked, the reactions in most common places would become somewhat like this, as if not being able to answer the questions in the question paper in an examination. So let us dive deep into this and see what exactly happens. Now, there are two faculties, sensation and perception. We all know that eyes are the extension of the brain, and we generally don't see with the eyes, we see with the brain. So sensation is the bottom-up process by which our senses, like vision and others, relay outside stimuli inwards, while perception is the top-down approach in the way the brain organizes and interprets this information and puts them into context. This is like an unending infinity. So the brain takes in the sensation, creates perception, again sensations are created, perceptions are created, and so forth. Now, to go ahead with this, when we talk about sensation, there are certain things which are called absolute threshold of sensation, which is the minimum stimulation which is needed to register a particular stimulus around 50% of the time. And it definitely depends on the psychological state, the alertness, and expectation in the moment. For example, all this time when I have been talking over here, the image that you're seeing on the right side of the screen was visible, and probably all of you would have seen it. What do you see over there? It's a medieval picture where you see that some trickster, a magician, is trying to perform some kind of magic. Very simple. But if you notice closely now, after I say, you will see that this man who is staring up at the sky is actually stealing from the pocket of this gentleman who is bending forward. This image is known as the Conjurer and was drawn in the year around 1475 to 1480. Here, just through a painting, the person who painted it wanted to showcase that there are focus points of attention. So your brain would ignore certain stuffs and focus on certain other stuffs, whereas the entire information is always present. Now, signal detection theory is a model for predicting how and when a person will detect a weak stimuli, and it's particularly based on the context as well. And it can be further subdivided into sensory adaptation and different threshold. So we all know that the stars in the sky have different brightness, but when we look at the sky at a glance, all of them seems to be the same. And difference threshold is something like when we know clinically that we have upgraded someone's vision from 6.6 to 6.5, it's a great job done. But that particular person doesn't sense any difference when he goes outside. But you upgrade the vision from 660 to 612, even though the vision is subnormal, there's a significant boost in the vision that the patient faces. Now, Weber and Pechner are like great legendary people who have put these things into context, and they have put a formulation on this as well. But grossly, the cortex has specialized nerve cells, which are called feature detectors, which are responsible for detecting and analyzing certain specific features like shapes, angles, and movements. So we never get a comprehensive image coming to our retina or the brain at the same time. It's called parallel processing, where some types of cells may respond to certain specific type of stimuli only, like posture or movement or facial expression, etc. Think of seeing through a panel of glass cabins from one side, and so many different people are doing so many different jobs. Now, once all these things are superimposed, you get a comprehensive sense of vision. It's called visual processing or parallel processing, which simultaneously these faculties work together to process and analyze form, depth, motion, color, etc. So basically, your eyes are feeding in raw data, but it is your brain that's doing the entire work of perception. Now, if this thing goes for a toss, then you get to have this weird kind of sensations, and this could be nightmarish for any optometrist or ophthalmologist for that matter. Prosopagnosia. If the neurological disorder that impairs a person's ability to perceive and recognize faces. Now, this person who is suffering from this condition may have a flawless vision, 6x5 vision, N5 vision. He is able to see each and everything, but the moment he looks at anyone's face or even in a mirror to see his own face, what he sees is this blank shadow over there. Now, this has nothing got to do with the eye or the visual cortex. You see just one small element in the fusiform face area, occipital face area, or the superior temporal sulcus or the amalgata could get some problems, and this problem might come up. Other conditions of very similar nature are palinopsia, where there is a persistent recurrence of visual image after the stimulus has also been removed. Like people get to see shadow people walking behind one person who is walking all through. Or the same object being preserved in your visual imagery wherever you are going. Very simple to say, because of the shortness of time, I am not elaborating it, but just to give you a hang of it. You might see a cat somewhere sitting in a field, and then you go home, you find the same cat on your bed. You go to the washroom, you see the same cat sitting over there. You go to some other place, you see the same cat sitting over there, although no one else is being able to see the cat. Scary, isn't it? Likewise, you get to see a certain scene, and that scene starts replaying over and over again wherever you go. You can see a pattern, and then you can see those patterns spreading everywhere. Think about horror movies. It's exactly the same thing. And this just happens because of a small lesion in the brain towards the occipital cortex. There are other conditions like Charles-Bonnet syndrome, wherein people with low vision or sometimes clinical blindness, wherein the retina stops giving the sensory stimulus to the brain starts creating their own perceptual set, and they start firing up silent imagery, which could be extremely scary and sometimes very unnatural. People call it a portal to the parallel reality. You can see scary faces, you can see scary patterns, you can see unnatural things happening. You can also see certain very blissful imagery. And just highlighting a couple of such things, a person who might be sitting somewhere sees that someone is passing through a wall with a bicycle. Someone sitting in their room can see a tiger on their bed. You go to drink a cup of coffee, you see that your thumb starts growing and it takes the shape of a serpent and it's trying to, like bite you. All these weird things can happen, and nothing of this is of optical origin. So if you can see, psychology of vision becomes so very important to understand these situations and handle them. So there are some freaking facts. Over 60% of the brain is involved in vision in some way, and 90% information transmitted to your brain is of visual nature. Now, to understand the perceptual set, that how do we perceive, the psychological factors that determine how we perceive our environment depends on a variety of factors. The first one being context. Now, what context are we talking about? Like, for example, when we speak in English, okay, and we say gun, it means firearm, which could be pretty deadly. But let us just change the language. I come from West Bengal in India, and our native language happens to be Bengali. Now, if you say the same word gun in Bengali, who understands gun as song, when you're putting forth a statement, it gets that context and it thinks about songs. But for the other people, they think about firearm. So very different meanings. Homonyms, words with same spelling but with different meanings. let us say that we talk about, we drank a can of Coke. So you understand what can is, it's a container. And then if I say that Optoverse can celebrate World Optometry Day, so that can means something very different. So context becomes very important when we are trying to perceive something. Followed by that, culture. Every culture has different interpretation of stimuli. For example, if you shake hands very firmly, it's very admirable in United States and UK. But if you are looking towards the Southeast Asian countries where people are very soft-natured, a bone-crushing handshake is thought to be an offense. The OK sign, this, can be very offensive in parts of Germany and in parts of Turkey. Extremely offensive as showing the middle finger in US. So if you see from cultural perspective, whatever stimulus you are giving, the perceptual set completely changes. Then comes expectations, emotions, and motivations. Now, if you just look at the image in the upper line center, the first thought that might have come in your mind is it is a snake. And then probably you might have realized that it is a rope. The reason why you thought it is a snake is because of the adjacent image, which is of a bear, which is an animal. So your brain started thinking animal, and that rope simulated a snake. If you look at the middle row, the same actor, very famous actor, smiling, laughing, but in each of his smiles, the expression and the mental state that you are perceiving is very, very different. And then finally comes motivation. Now let us look into it from a different perspective as well. Another factor about this understanding is the figure-ground relationship. So if you look at the image on the left-hand side, on the black background, you might find a white gorilla and a white lioness. And on the white background, you might see a tree, two birds, and other things, and it keeps on flipping. So this concept has been used to develop different kinds of logos as well. Now, if you try to manipulate these things, this is just a faucet that you're seeing on a basin. But if I show you the face of this ice-age squirrel, and then I ask you to look at it again, probably you are seeing the face of the squirrel right now, and it doesn't go away because it's recorded in your memory. Now, cognition is our thoughts, perspectives, and expectations, that how our brain solves problems, and it can happen through the process of knowing, remembering, understanding, communicating, and learning, which gives us preferences, prejudices, fears, and intuitions. And it can be achieved by the process of trial and error, an algorithm, a specific pattern approach to it, or by heuristic that it's more between trial and error and algorithm. Now, concept is a mental grouping of similar objects, people, ideas, events, etc. And it creates a prototype. Like if I say bird, you don't think about a penguin or an ostrich. You think about a songbird, a small-sized bird with wings, good tone, etc. Now, if I tell you that it is Sheikh Mohammed, for example, and I show you this picture, whatever mental imagery you have about him comes true. So you agree with that. But if I show you this picture over here and tell you this is Sheikh Mohammed, you probably wouldn't agree with me. Although this is the picture of the Sheikh at his very young age. Now, this retaliation of the brain is called prejudice. Now, these are parts of psychology of vision. And that's what gives rises to a lot of cognitive illusions as well. Now, form perception, the way we understand things, happens through faculties like similarity, symmetry, proximity, continuity, and closure. Now, when we say similarity, we all get confusions about COQG in the Snellen's chart because all these things look similar. Symmetry. Now, if I ask you to read whatever is there, you will say it's A and T. Although I have just put half of the letter because it's symmetrical, it was overcome. Proximity. Without even a few letters, you can read this. When we talk about continuity, you can read from, or you can like speak out from 1 to 100 very fast. But if I ask you to do it on a reverse scale, you will face difficulties because your brain is not trained to do so. And while putting all these things together as closure, if you look at the picture on the right-hand side, you will immediately think of a Dalmatian, but it's just some blue patches on a white background, nothing more. Other things to be taken into consideration are depth perception, both with binocular cues and monocular cues, because it tells you a lot of stories about whatever you are seeing. Like this gentleman holding up the plane. It's not the case. It's just a mere illusion of depth perception. Motion perception happens in our day-to-day practice as well, of all the kinds. Lightings during different kinds of festivals and retinoscopy. So every type of motion to be detected, and based on that, you get some information, is also a major function of psychology of vision. And then finally, color perception. We all know about the trichromatic theory and Hering's opponent theory of color perception. But what happens? We talk about 50 shades of gray, but we all know that it doesn't exist. Human eyes can perceive only about 30 shades of gray and a million different hues. So if I ask you to look at the image on the left-hand side, it doesn't really give you much of an information. But let me put in colors and then you will see what we are talking about over here. So that's what color makes a difference of. Okay. And just see how the brain can be fooled by the color. So here we have two blocks with 9 patches in them. And if you look at both these pictures, both of these 9 patches look identical. Now let me start removing the filters one by one to show you in reality what these colors are. So first goes up the black overlay. Completely different, isn't it? Okay, you're still getting fooled. That was the actual color. Confused? This is the actual color we are talking about. So you see, just placing completely different sources can make your perception similar or very different. That's magic of optometry. And then we come up to the rule of thirds. I know that I'm almost out of time, but okay, let's try to just speed it up. So these pictures look beautiful, isn't it? Even if you don't like it, do say yes, because I have clicked them all. So yeah, they become attractive because there are certain points of attention which our brain leads our attentions to. Now, this is loosely related to the golden ratio, which is also called the fingerprint of God. It has a specific ratio, and it's called the golden ratio because everything in the entire whole wide universe has that exact same pattern. It's a repetitive pattern where this ratio of 1.618 is always getting repeated. And that's how our brain is pre-programmed instinctively to look at those colliding points over there. And then comes constancy. So irrespective of your form, color, depth, and other perceptual sets, you still get to identify things even if they don't exist in real life. For example, I'm sure none of you have seen a black or a green rose, but when you look at these images, you get to see a rose and then you train yourself, okay, there could be roses because the patterns are very similar. If you look at these images of the dogs, now all these dogs could be different, but they look similar. So even if you are not looking at the same image, understand every image is different, but then also you understand it is the same dog. And now putting all these things together in the perspective, that's how we see. So you see, here you are seeing form, you are seeing motion, you are seeing depth, you are seeing color, and you are getting this constancy. So you're seeing this cheetah is running up. But what you have not noticed is it is actually chasing a warthog, which is here down at the right corner of the screen. So again, you see your brain just played tricks on you. So to end up, I would definitely quote from the famous magician, David Copperfield, that when people say you can't do it, that it's impossible, never lose hope. Just because they couldn't doesn't mean you can't. And these are for future references, just in case if you want to get in touch with good luck, okay? Because good luck is always difficult to find, and he's available along the most difficult paths, right? So am I. So long live optometry. And again, have a wonderful World Optometry Day today. Thank you very much.
Thank you so much, Mr. Ranade, for your insights, and the pictures were really beautiful. So we all loved it. Let's move forward for our third speaker for this session, Ms. Niveta Iswaran. She's practicing optometrist for the past 8 years in Dubai and in India, currently working with Maghrabi Eye Hospital in Dubai. She's going to discuss with us on the topic lenses for different needs. Platform is all yours, Ms. Niveta.
Yeah. Hope you all hear me.
Yes.
Yeah, just a minute. So good evening to everyone. I'm going to discuss about lenses for different needs. This means a personalized prescription, how we are going to prescribe different types of lenses for different categories of patients. So this is a brief intro. Everyone know that the eyeglasses has invented in 13th century, and due to the advancements, now we have different categories of lenses due to the science and technology, lifestyle, quality, durability, and fashion. And this is a gross view of the eye.
Sorry to interrupt, Niveta. You have to do the screen sharing. We cannot see the slides.
Oh, I'm sorry. Actually, I have done.
Can you just try and do it again because we cannot see the slides.
Yeah.
Perfect. Yeah.
Yeah, you can.
Yes.
It's fine. So let me run through the gross view of the eye and the optics. We know that the ametropia can be corrected with the different types of lenses like concave, convex, bifocal or the trifocals, aspheric and the cylindrical lenses. Those are the basic methods of treating the ametropia. But due to the advanced lenses, now we have like more sophisticated techniques, which includes like anti-glare, anti-scratch, polarized, photochromatic and filters, etc. But what comes when we have the advanced technologies or these advancements, what happens to all the patients? The patients' expectations are also growing, right? Due to these advancements, they are expecting a high definition of vision, which will suit their lifestyle. So our role of optometrist is getting more challenging. Why? Why is it getting challenging? Because we know the optical advancements. Because we are in the field, we see like what all the advancements it is growing up in the field. And we know the eye anatomy because we have studied all these years for that. And we have experienced the visual complaints, what the patient is seeing and what are the demands they need. So all these has to be satisfied, and providing the patients with the dream vision they desire is our responsibility. So be proud to be an optometrist, and happy World Optometry Day to all the optometrists who are here with me. So let's see what all the visual demands in recent days. Reading glasses, telepathy and the myopia control glasses or the safety glasses. Actually, there are many visual demands in the market or with the people, but I'm going to concentrate on all these three with this slide because these are the major categories I feel. Reading glasses. So nowadays, when a patient refers to a reading glasses, they may be referring to any of the following. It can be for mobile, for computer, for laptop, for mobile and computer, for mobile and laptop. Oh God, it's really a lot, right? Because before, reading glasses means it's just a reading glasses which will be for around 35 to 45 centimeter. And sometimes we can calculate with the age or different formulas and you can just prescribe the glasses. But now, no. We have to keep all these in mind and prescribe the glasses. So how it can be prescribed? It can be prescribed either through single vision or bifocal or the trifocal lenses. So if it is single vision, if the patient is having a normal vision for distance and for near, they can be prescribed a single glasses or a separate glasses for reading. And if the patient is not using a computer, but in case if a patient is using a computer and prefers to have a separate glass for the near distance, I think he has to be refracted monocularly in front of the computer to have a customized prescription. Many, I think, like they are practicing or they are doing like decreasing like 0.75 diopter with the near ad or the near prescription and prescribing for the computer usage or the near task. But I think more than that, when you refract the patient before a computer desk, if the patient wants a single vision glasses or a separate glasses for the computer or the laptop, whatever task they are doing, so it will be more benefits or it will be more effective than the normal prescription, whatever we are calculating and giving. So let's see the bifocals. Bifocal nowadays, I think like almost half or 75% of the population, they are not wearing it. But if they are comfortable, please don't change it. And for the aged patients who have not tried the progressive glasses, for sure, like we have to keep the bifocals or the separate reading glasses rather than converting them to the progressive glasses. The progressives. So I'm not going to talk about the normal progressive glasses here, but I'm just going to talk about the reading or the intermediate category in the progressives. So the reading, if you see, like the progressive users, still they are not satisfied or happy with the progressive glasses when compared to the separate glasses. So especially for the computer users and book lovers are targeted by this complaint. So what is the solution? These patients will benefit from extended focus lenses, which will be satisfying all their needs. So let's see what are the extended focal lenses. These are actually called even as an office lenses or near focus lenses. The name itself says that there is an extended focus for the lens to see all the images clear. It's not like a single glass or a single focus lens, which we will give like 50 centimeter for a 2 diopter or a 2.5 diopter. So they are having like 3 types. It is coming as a reading lens, a computer lens, and a room lens. So the reading lenses have a range from 40 centimeter to 100 centimeter, and the computer from 40 centimeter to 200 centimeter, or the room lenses, which is from 40 centimeter to 400 centimeter. So these are the traditional progressive lenses, which everyone will know. And these are the extended focus lenses optics. So here, we are not focusing on the distance target itself because we are working for the near and the intermediate, right? And this is the near range progressive. This is for the books. And here, the near part is actually magnified or the zoomed out, or the visual field is very big when compared to the progressives, as you can see here in the diagram between the left and the right. And the intermediate is still in the focus, okay? Even though this is not as good as the near vision, but the intermediate has a wide range. When you go to the mid-range progressive, this is for the computer users, where the intermediate is targeted or focused very well when compared to the reading. So these are the lenses. As you see the book range, how the patients or the person sees here is a very good wild of vision, where all the computers users can be prescribed with these kind of lenses to have an good vision over their desk as well as the computer. And in the desk purpose, like in the computer usages, this lenses can be prescribed for the patients or the person who is dealing with the clients or the managers or the office use purposes, where like they can still have a very good vision in the desk as well as in the clients or the customers who they deal with. This is almost, the room is, the room lenses are also like a progressive glasses. So I don't think so like this will be more benefited because I have not heard of it, but still a book and the desk lenses are very good. I think like for reading glasses, the optometrists, whomever they are prescribing, they have to really think about giving these lenses or educating the patients about these lenses before prescribing and separate glasses. So let's move on to the therapeutic glass or the myopic control. There are a lot of things going on to control myopia. Half of the world is myopic now, but everyone knows that the myopia can be managed, not only corrected. Myopia is best managed early on to avoid long-term vision issues. So generally how the myopia is corrected is through the concave lenses and through the single vision. So if I'm going to tell about the myopia control, what happens is we were still giving like bifocal lenses or the progressive glasses for myopia control. But now, due to the advancements, there are lenses which will really control the myopia. So let's see what happens in the myopia control in the advancement. Myopia control spectacle lenses correct the visual defect on their entire surface using honeycomb-shaped segments area to slow down the myopia progression. So these are the myopia control lenses. As you see, in the center, it is cleared, and in the paracentral area is full of a circular rings. So where the defocus happens. So this is a defocus mechanism in which the myopia is getting controlled. Let me explain what happens in myopia. We know that the rays are focused in front of the retina, and we are prescribing a single vision glass to shift the focus from in front of the retina to retina. But everything we are talking about the central vision. What happens to the peripheral vision of myopia? So basically, all these multiple rays of light and goes towards the retina, the person is seeing very clearly in the center, there is a defocus in the peripheral retina. The defocus means they are actually meeting behind the retina. So let's see what is defocus means. Now, when they meet behind the retina, the signals that the eye is having, and it sends to brain in that the eye is shorter than it should be. It serves as a stimulus for the eye to grow longer or for myopia to increase. This peripheral defocus is called the hyperopic defocus. A hyperopic defocus is when the rays of light meet behind the retina. This new technology basically causes the peripheral rays of the light to focus in front of the retina, and they are called as the myopic defocus. Let me explain through the diagram. This is the myopic eye, which is not corrected, and the rays are falling in front of the retina. And when we are correcting, don't think this as a convex lens. This is a concave. It's just a single lens. Okay. And when we are correcting through the lens, we are just shifting the focus from in front to the retina. But we are talking about the central rays. Okay. See, what happens to the peripheral rays is it is going behind the retina. It is falling or the focusing behind the retina, where there is the blur or the defocus image. So this is the myopia control lenses. So what happens is the central rays just pass through the same way, but the peripheral rays, here is the concentric or the circular rings, which will make the rays focused on the retina, because there is an plus lenses or the hyperopic convex lenses, which will make the hyperopic way to fall on the retina, and all the images or all the rays are focused on the retina, so that the patient or the person doesn't feel that there is a defocus, and the brain is not having any signals that the axial length is still shorter and they don't need to grow. So this is called as the myopia control lenses, which is in the advancements. But still, what happens is many theory doesn't agree with this. There is still a controversy, but there is something which we can try and see on our patients who is agreeing, and let's control myopia together. Let's see something else called spectacle over contact lenses for the therapeutic lenses. So we have prescribed spectacles over the contact lenses traditionally for giving the reading glasses, like far distance for the contact lenses and near distance for the glasses, right? But it is not only for that, but in case of anisometropia, also we can correct the spectacles over contact lenses. Like the higher prescription can be given for the contact lenses, and the residual lower prescription for the other eye, it can be corrected through the contact lenses if it is not available in the contacts. Same thing, it can be given for the specialty contact lenses over in case if there is any kind of adjustment cannot be done, and a residual astigmatism. So let's see the last demand of the patient, like safety glasses. So safety glasses, everyone's are asking about safety glasses nowadays. The patients, even though they don't need any prescription glasses, they are asking about something I can wear for the safety purpose. So it's not only about blue filters, there are something else. Drive safe glasses, injury safe glasses, gadget safe glasses. So drive safe. Everyone are driving, and especially like the drivers, if you ask them like what all you need or what all you should not have, they will tell this: no reflections while driving, no squeezing of the eyes, no mirage effects during long drives, or dull visions. These all are corrected through different types of lenses in this advancements. So the polarized lenses will correct all the reflections, and the photogrammetric lenses will try to reduce the squeezing of the eyes. The polarized glasses still will not have the mirage effects during the long drives, and the tinted lenses will reduce the dull visions. We all know that the photochromatic lenses or the transition lenses will remain clear in the indoors and will get color change when you go to the outdoors. But in the market, there are availability of extra active transitions. Let's see what is that. These lenses are having like 10% tint even in the indoors, and they will be super dark at outdoors. So these glasses, it will be beneficial for few patients who is having a real sensitivity of eyes. So just to make you to understand, there are extra active transitions which you can prescribe for very few patients who are in demand of need of a tint indoors. So let's see who will benefit from all these safety glasses, which I have shown in the last slide. The photophobic patients or the albinism patients, the patients who have symptoms of glare, and especially during the post-surgeries of like LASIK or any kind of cataract surgeries. The aged people or the less having the less contrast, so they will be benefiting from the tints. Cataract patients who have a foggy vision, they will be benefiting from the tints as well. Glaucoma patients or the retinal patients who is having a very less contrast, they will also improve the from the tints. People who are interested in the sports will have a higher advantage with these glasses. But there are some persons who has to avoid these glasses, especially the pilots, because they will be using some kind of displays during their work. The polarized lenses will not benefit the pilots. And the retinitis pigmentosa patients who have a difficulty in the light and dark adaptations should not use gray or dark tinted lenses. And the indoor person who is always doing something indoors with the gadgets and something, they don't have to really concentrate buying on these safety glasses. Drivers who have more sophisticated or advanced cars, they generally have all these in the screens. So I don't think so like we have to advise for these drivers. So let's see about tints or the sports vision. So tints filters the lights in different ways. So these are really good. Although you may admire a certain tint, but it might not fit in a particular set. You like some color, but it will not fit you for your lifestyle. That's what I mean. So let's see which all the sports vision or the injury safe lenses. So there are different tints like gray, yellow, orange, amber.
Sorry to interrupt you. Another 5 minutes for the session, please.
Yeah, thank you. So let's see, like all these tints are having a different purpose and benefits. So depends on the tints, depends on the patient, we have to prescribe the glasses. So it's not like all the colors will suit for everyone. So especially for the glaucoma or the ARMD patients, yellow tints will be a good thing. And same thing, the cataract patients or the glaucoma patients who is having the less contracts will be benefited from amber or the brown lenses. The low vision patients and the retinal abnormalities patients who can be prescribed with the red filters, like the same thing, like if you have any kind of shooting or the pigeon shooting habit, you can be prescribed with the purple filter. Okay, so there is an advancement nowadays like a prism technology. So what is the prism technology is, there is a different type of prisms which have been inbuilt to the particular lifestyle what we have. For the golf, for the deep water or the seas, when the person is spending more time on the roads or cycling, if they are into the snow, this will be benefited. So let's see about the gadget safe. There are anti-fatigue lenses. So what are anti-fatigue lenses actually are? They have a small prescription, like small boost of power designed to lessen the eye strain by helping the eyes transition from far to near. These are actually an single focus lenses, but who comes under the category is not the presbyopic ones. You should be around 15 to 40 years of age, and you should be pre-presbyopic, and the problems have been fatigue, eye strain, or after the computer work. So what happens is there is a 0.5 to 1.25 diopter on the prescription glasses in the lower part, but it is not a progressive or bifocal lenses to have a line under it, but these are the single vision lenses which can be benefited. And the blue filters. So everyone know about the blue filters, but I will just quickly tell about the anatomy of it. There is a cycle which is going on in our body circle. So that is called a circadian rhythm. Okay. So when these melatonin sensors are telling, like it is sending the signals to our brain that we should sleep or we should not sleep. But when these blue filters are there, we tend to have a normal sleep. That is what the science is trying to say. And when these lenses are there, we will behave normally, that our eyes don't send any signals to our brain that we have to be active. That is what a blue filter is. Still, there are many theories says that this is not so effective, but at least we can try something. Our role. Customized prescription is not just refraction. Depending on the lifestyles of the patient, their visual need demands changes. So what I am trying to say here is, this is just a refraction. We have prescribed a patient, okay? But all our optometrists, what we need to do is, please use this remarks column to say something. Like what all the things what I was telling is, you can use the tint here, if you can use the extended focus lenses, or you can this remarks can be a temporary prescription, or like you can put like more contrast should be given, something something should be written here, because optometrists are there everywhere. We are working in the hospital as well as in the opticals. But what happens is, in the opticals, of course, the patient is not being advised or like the person who oversees this prescription, they don't know about the real disease what the patient is having. It cannot be simply a myopic or a hyperopic patient. They can be having a glaucoma, they can be having some kind of retinitis pigmentosa, they can be having an corneal problem, but it is not mentioned in the prescription. But if the optometrist who is in the hospital prescribing the glasses, if he writes a single vision or a bifocal, the person who is selling the refraction or glasses, they need to follow it. So please use the remark column, and there are many advanced lenses. Please use those things to prescribe the patient to make them to satisfy. And happy World Optometry Day. Thank you.
Thank you, Ms. Niveta, for the wonderful session. Before we move ahead to the panel discussion, I would request you all to answer some of the poll questions. I cannot see here. The ability of a light wave from a laser to form interference fringes with another wave from the same beam separated in time is a measure of its temporal coherence, spatial coherence, polarization, directionality. The change in stimuli perception from scotopic vision condition to photopic vision condition is best explained by Purkinje's shift, photochromatic interval, visual adaptation, biphasic threshold. Contrast sensitivity peaks at cycles per degree, 2 cycles per degree, 3 cycles per degree, 3.5 cycles per degree, 4 cycles by degree. Power of prism mostly depends on media in which it is kept, angle, thickness, or all of them. You're about to write the post-operative spectacle prescription for a cataract surgery patient with macular degeneration. The best choice for a reading ad for the patient with 20/70 best corrected vision is going to be +3 diopter, +3.5 diopter, +7, +3.5x magnifier. Image formed by a prism is virtual, erect, displaced towards it, inverted, real, displaced towards apex, virtual, inverted, displaced towards real, erect, displaced towards apex. The normal resolution visual acuity level of 6/6 is attained at the age of 6 years, 3 years, 4 years, or 8 years. Find out the correct tube length of a Galilean telescope whose objective and an eyepiece are of 40 and 20 diopters respectively. Welcome everyone to the panel discussion. So my first question would be for Mr. Ranadev Banerjee. It was a wonderful session.
Thank you.
And I would like to ask you a question, which is going to be how it is easy to, like, does a patient have a feeling of getting handicapped to the correction associated with the symptoms, what you said?
You meant those psychological symptoms
Yes,
which were presented,
yes.
right? Okay, see, now some of these cases have something to do with lesions. Now, when we talk about lesions in the brain, then definitely they have their own level of treatment. And it depends on the extent of treatment that can be offered and it can be managed. Now, aside to the medical management of these cases, there are optometric solutions through different kind of specific filter type of lenses, and at the same time, something called a cognitive behavioral therapy, which is ideally a hypnotherapy sort of a thing, where you use the faculties of visual psychology to motivate the brain and give them certain sparks of understanding so that the brain can start guiding itself what to see and how to see. And thereby, since brain is one of the most neuroplastic organs in the human body, there are rewiring which happens, and a lot of these things may get corrected at the same time. Easy to do if you understand how the brain thinks.
Thank you so much for the answer. My another question would be for Mr. Raji. How about considering a peripheral refraction before doing a LASIK surgery? You're mute.
Now, how does it help doing a peripheral refraction, and how is it going to help you doing a peripheral refraction?
Maybe for the myopia progression after the LASIK?
No, see, myopia progression has nothing to do. We are dealing with patient above 18 years, 20 years. I mean, there's no question of myopia progression after doing a LASIK surgery.
Or you can say a myopia regression, actually.
No, regression has various other factors. It's not because of the peripheral defocus or the other myopia progression signs. This is regression is because of various other reasons. So this really doesn't help you.
Okay, thank you so much. Thank you. My another question would be for Ms. Niveta. So what can be the multiple coverts? Like, how do you consider the lens corridors or a lens design and their and the prescription when it comes especially for the office lenses? So how would you like to move ahead in that case, like considering the corridors and the design and the prescription? You're mute.
Okay. These extended focus lenses, they are happy with the normal prescriptions. So in case of like higher prescriptions and higher astigmatism, actually they benefit a lot from the variable focuses, because in the normal progressives, the higher numbers or the higher astigmatism patients, they feel more discomforts during the distortions. They have like more distortions on the sides, right, due to the visual field. But in case when we are focusing on this extended focus, as the visual range is more for reading or for the computers, they are having a good benefits when compared to the general prescriptions, like very normal numbers.
Thank you so much, speakers, for giving your valuable time. We shall move forward with our next session, and I will hand it over to Mr. Host.
Thank you, Tapashwi, for moderating. That was an awesome presentation with a lot of take-home messages. I hope people are taking note of it. Let's quickly move on to our next session, binocular vision. The term binocular comes from two Latin words. Bini means double, and oculus meaning eye. This concept has been discussed since the time of Aristotle, that is from 384 to 322 BC. A clear invention of stereoscope by Wheatstone in 1832 helped in understanding it much easier. Now I would like to call Ms. Fahima, Senior Orthoptist from Sheikh Khalifa Medical City, Abu Dhabi, to moderate this session. She is also a co-chair in Emirates Society of Ophthalmology, Optometry Working Group. Over to you, Ms. Fahima.
Thank you, Vala, for the introduction, and happy World Optometry Day to all of you. I would like to call upon Dr. Raman Mehta to kick off this session. Dr. Raman is a pediatric ophthalmologist and neuro-ophthalmologist by training and has been working in the UAE for the last 6 years as a specialist ophthalmologist. He has 11 years of experience in pediatric ophthalmology and is currently working in Over to you, Dr. Raman. You're on mute.
Yeah, good evening, everybody. So I would like to share my So my slides are visible? Okay, so good evening, everybody, and thank you for this opportunity. UAE Indian Optometrist Forum, and a happy World Optometry Day to everybody. So these are my disclosures. I have no financial interest, and all the patients' pictures are taken for their videos are taken with their consent. So basically, if we are encountering a case of diplopia, we need to really differentiate whether it's a monocular diplopia or a binocular diplopia. Why anybody would say is why monocular diplopia? Because in my practice, I still get referred patients with diplopia, but actually they turn out to be monocular diplopia patients. So don't underestimate this, and it's always better to confirm whether it's a monocular diplopia and a binocular or a binocular diplopia. The simple test is basically to cover one eye. If the patient still complains of diplopia after covering one eye, then you may be thinking of something like a neurological cause like cerebral polyopia or palinopsia. And the way to differentiate this by using a pinhole. And if the patient, if the patient's diplopia gets monocular diplopia still is persisting with that, then most probably it's mostly like a neurological cause only, and that patient needs to be investigated and referred to a physician. Binocular diplopia is basically a breakdown of your binocular fusional ability. So the basic question when you should be assessing when you are encountering a patient of binocular diplopia is horizontal, vertical, oblique, or torsional. Does it change with the gazes in head position? Is it worse for distance or near viewing? Is there any variability or fatigability? Is it onset gradual or acute? And there are any other histories of like history of strabismus, amblyopia, loss of vision. Each of these questions will give you a clue to the diagnosis and to the management of binocular diplopia. So all these questions need to be asked. So my presentation will be like a case-based presentation. So we will be overgoing around 4 to 5 cases to see the different kind of cases which we get and how we can manage them. So one thing which we need to tell always for the management of diplopia is that our main goal is to have a resolution of diplopia in the primary position, and that is considered to be a successful treatment. And the other thing which we'd like is basically to have no diplopia in the down gaze, because that addresses the functionality for reading. Also, you can address the patient's expectations for treatment. And while you are managing the diplopia, one thing which needs to be taken care of is the cost factor for the patient. Which is the thing patient can afford, and what is good for the patient. So this is our first case. It's a 22-year-old male. He has come for second opinion about his diplopia, which is intermittent and lasts a few seconds. He has been using glasses for last 1 year, and he had applied for a commercial pilot license and got rejected. So he had his best corrected visual acuities with the cylindrical correction and myopia in the left eye also. And on Hirschberg test, he's actually ortho. On cover test, you basically found an exophoria for distance and near, but it's more for the near. So basically, if you see the prism bar cover test, we found around 8 prism diopter exo for distance and around 12 prisms for the near. And these were his fusional amplitudes. And as it shows, basically the fusional amplitudes for near for convergence are diminished compared to the normal. So this is basically a case of convergence insufficiency. And so the options which were given to the patient were fusional exercises, prisms, and the last option is surgery if none of these things works. So this patient basically opted for fusional exercises. So convergence sufficiency basically is a horizontal diplopia that manifests with prolonged near vision work. And the patient will most time complain of sore or tired eyes or letters or words that run together or appear double. After a brief period of rest, the symptoms he may be relieved, but then symptoms may return again when he resumes his activities. Always ask for history of dry eyes, Parkinsonism, and uncorrected refractive error, and also the medications patient is using. Anticholinergic medications are known for precipitating convergence sufficiency. So all this has to be inquired in the history. The treatment is basically you need to treat the refractive error. You should basically slightly undercorrect the hyperopia or fully correct the myopia. And you can go for fusional exercises. I will not go into the details of fusional exercises because our next presenter is basically talking about vision therapy. And the third option is you can give him prisms, which is the least amount of base in prisms. Many of the convergence sufficiency patients actually are not comfortable for prisms because it's mainly for the near task they are having a problem. So they basically you need to give the least amount of base in prisms, and strabismus surgery is the last resort for these patients. Then our next case is basically an 18-year-old male who has been complaining of diplopia for distance for about 1 month. It started gradually only. He is basically having a refractive error in both eyes, for which he has not been using glasses for a long time. On cover test, you basically find an esotropia for distance and a flick ESO for near. So on a prism bar cover test, you basically find 12 prism diopters for base out for distance and a flick ESO for near. So what is the diagnosis? Is it a decompensated esophoria? Is it a divergence paresthesis? So whenever a patient of sudden onset of esotropia comes to me, I will always investigate the patient. So we did blood investigations, and we also went for an MRI brain with contrast in case we were missing out any neurological lesion. The MRI brain with contrast came out to be normal. So the patient was prescribed prisms in both eyes for about 4 prism base out in both eyes. And with that, he had no diplopia glasses. Prism adaptation test was also done for him. So how would you image a patient of sudden onset of diplopia if it's a non-resolving palsy? Worsening palsy after 1 month, the patient has associated neurological signs, or you see papilledema on fundus examination, or you have a doses associated with diplopia. So these are the conditions where basically you would image a patient for looking for a neurological cause. So this brings us to the treatment of prisms and treatment of diplopia. Arnab has already spoken about the mechanics of the prism. I will just give you a clinical view of the kind of prisms which can be prescribed and what is the basis of what is the criteria for prescribing prisms. So the prisms which can be prescribed for diplopia are 2 types: the ground prisms and the Fresnel prisms. So we are basically, since in this patient we gave grounded prisms, so we are talking about this. So the basic principle is that for horizontal diplopia, the minimum amount of prism that would make the patient diplopia free in the primary gaze is what is prescribed. Normally for horizontal deviation, you need to start with 50% of the amplitude of deviation, and that can be increased or decreased based on patient's response. The prism power is always to be split between 2 lenses, but in vertical diplopia, it is a possibility that you may need to give a full correction or 90% of the deviation. Only patients who are having congenital superior oblique palsies who have good fusional amplitudes are the ones who may require less prisms. But most of the other patients who have acquired palsies will require either a full correction or maybe around 90% to 80% of the correction. So this patient does not wear glasses. This is the story going for the last patient. He is not wearing glasses. He comes and there's a diplopia again. And this time the tropia has increased both for the distance and near for 18 prism base out. So that means it was a decompensated esophoria, which ultimately decomposes into a tropia. So at this time, we planned for both eyes medial rectus recession, and which was done. And ultimately, the patient had, after the surgery, had 5 base out prisms for distance and ortho for near, and he's diplopia free. But he's still not wearing glasses. So that brings to our third patient. It's a 48-year-old female. She had a history of road traffic accident 1 year back. There is blurring of vision in left eye after the road traffic accident. And she was also complaining of diplopia for last 1 year. She's a known diabetic. So our third patient, it's a 48-year-old female. She had a history of road traffic. I'm hearing my echo back actually. Okay, so visual acuity is 6.9 in the right eye and 6/18 in the left eye with glasses. There's a left eye RAPD, and color vision is also affected in the left eye. So this is what we did for the patient. So as you can see, her extraocular movements are full, and we could not understand how she was having diplopia. On the head tilt on the left side, there was a small L/R, right hypertropia, left hypertropia. And we did basically a diplopia charting and a Hess charting. The Hess charting looked quite okay, but in the diplopia charting, basically in the levo elevation, she was having separation of images. Now we have to understand that our primary goal is to make the patient diplopia free in primary and down gaze. So in such cases, basically a reassurance given to the patient, and you can also tell them to do to move their heads while looking at things. The other option is to basically give frosted glass in the temporal side, or sand, which are called as like sand blasted glasses, which can occlude the left side of the vision, by which the patient can avoid diplopia. So basically the ideal outcome for a patient with diplopia is binocular vision in all gazes, but that may not be attainable in all patients. especially in patients with restrictive strabismus. And sometimes the size of the deviation, the incompetence of the torsion make the binocularity impossible. So it's in these instances, the goal is basically to eliminate the second image to improve the patient's quality of life. So in such patients, you can use basically, if supposing you're not able to correct, you can use occlusion with pyrite patch or a Bangerter filter. So this is our third case. This is a 41-year-old female, complaints of diplopia, had history of inward deviation of eye 4 months back. There was history of jaundice and fever before the attack. Partial relief over the last 4 months. That means the esotropia has decreased. Visual acuity is 6/6 in both eyes, and rest of the neurological examination is normal. MRI imaging was done with contrast, that was normal. Systemic parameters are normal now. She has visual acuity of 6/6 in both eyes. EOMs are full. And then there is a left eye esotropia, which we checked with both fixing left and fixing right. And it turned out that there is no primary or secondary deviation. It's symmetrical with the both eyes. Diplopia charting and Hess charting was done, and the patient was given the options for prisms and surgery. The patient opted for prisms. So this is basically there's nothing in the patient. We just took a history of the patient, and basically we did a prism bar covers test just to check for the primary and secondary deviation. The purpose of the video is basically to tell you that all patients if you're prescribing prisms, it is important to check for primary and secondary deviation, because the amount of prisms which you are prescribing will dependent on, you have to prescribe the least amount of prisms for the primary deviation because on the non-dominant eye. And so once you have prescribed the prisms, it is basically time for the patient to be thrown out in the environment to see that she adapts to the prism. So I always make the patient sit outside for about 45 minutes to 1 hour and make her move around in the hospital, make her move around the stairs and see that she is comfortable. So if you see this patient, she was prescribed prism for around 20 prism base out, and she has basically a Fresnel prism on her glasses, and she's pretty satisfied. That's what the video tells, that she's very happy with the prism correction. So then now let's talk about the Fresnel prisms. I will not go into much detail because Arnab has already talked about this, but basically it's whenever you have a prism which is more than 12 prism diopters, it is better if it will not be possible to give ground-in prisms. So we basically go for Fresnel's prisms. And basically the Fresnel prisms also have their own problems. So the thing which we need to understand is on which spectacle should we put the prism. So for that makes us to have awareness about the primary and secondary deviation. So always we will prefer to put Fresnel prism over the eye with restriction or greater restriction if bilateral to correct the smaller primary deviation. Unless the patient has better vision in the non-dominant eye, in the restricted eye or the affected eye, in that case, we will go for the secondary deviation prism correction, because that is the eye the patient will be fixing with. But majority of the times, the affected eye also is not the dominant eye. So that's why we give it for the primary deviation. If the deviation is inconcomitant, Fresnel will not give you binocularity in all gazes, but it can give you binocularity in down gaze and in the primary gaze. The idea is to basically give the prisms which gives the largest field of binocular vision and corrects the patient most useful direction gaze should be used. So this brings us to our last case. It's a 66-year-old female. She complains of inward deviation of eyes 15 days preceded by headache and eye pain. She's a known hypertensive on medications, but the compliance with medication is poor. There is no complaint of diplopia and no anomalous head posture, even with having an inward deviation of the eye. So let's have a look at. So this is a patient with right eye esotropia, and as you can see that it's basically a abducens nerve palsy. Her primary deviation is around 50 prism diopters, and with fixing with the left eye, the deviation is around 60 prism diopters. Probably she's not having a diplopia because the eye is so inwardly divided that the image is so far off that she cannot appreciate the second image. And that is why she is not complaining of diplopia in her case. So we did the investigations. MRI with contrast was normal, and all systemic peripheral except for she is hypertensive. So how do we go about with these patients? So best would be to observe and review for 2 weeks. And if you find there is no improvement, you can go ahead with prisms, or you can go ahead with prisms with botulinum toxin. If you find that the improvement is happening, you can wait and watch for some more time, and then again you can decide to go for prisms and botulinum toxin. So other option, if the patient would be complaining of diplopia, would be to give something like occlusion, which is like a pirate patch, or the other option would be to give a thing called as Bangerter filter. Why some patients would be preferring this is because it allows some amount of light to come into the eye, and there you can be having some amount of peripheral fusion, though the central, it will create a central scotoma. So some patients may prefer this also. Many of the patients will be going for a complete total occlusion. So let's talk about botulinum toxin for the management of diplopia.
Sorry,
so
1 minute to go, please.
1 minute?
Yes, please.
Okay, so I'm going to skip about botulinum toxin. I will go very quickly over this. So basically, it was first described by Alan B. Scott in early 1980s, and it was finally approved by FDA in 1989. So it's basically the commonest method is to go by an EMG guided method, but you can go without EMG guide by feel also, or you can go under direct vision, or you can make a conjunctival incision, or you can give it the lacrimal cannula, or like me, you can just grasp it transconjunctivally and muscle with forces and bunch it up. So let's have a look at the way I go about it, giving the Botox injections. I don't have much experience of giving Botox injection for vertical deviations, but I have given a sufficient number of injections for mainly abducent nerve paresis, and it works beautifully in that. I have not had much complications also. Maybe I think 1 or 2 patients developed ptosis after my Botox injection, but the rest of the patients have done really well. So for vertical muscles and for horizontal strabismus of less than 20, you need to give around 1.25 to 2.5 units. And for between 20 to 50, you can get around 2.5 to 5 units in missile. And I would like to end this presentation by saying that basically diplopia, you need to differentiate whether it's a monocular or binocular diplopia. And that's by asking the patient to close one eye. Acute onset of binocular diplopia is a red flag and needs to be investigated. Prisms are very effective modality of treatment of diplopia, more effective for concomitant strabismus. Botulinum toxin can be used in paralytic strabismus and certain cases of restricted strabismus and can give temporary relief from diplopia. Diplopia management can be individualized as per patient requirements. So thank you for everybody. These are my references. And I would like to thank all the optometrists who have been in my journey, beginning from the guy who started with me in my solo practice in 2011-17. And finally, when I was working as a consultant pediatric ophthalmology, and now finally in UAE, where I have around 5 to 6 optometrists working for me and tolerating me daily. Thank you so much.
Thank you very much, Dr. Raman. Very insightful. I was nodding ahead with, passion at every point you were giving. So thank you very much. The next person I would like to call upon for the next session is Nikita Jacob. Nikita is Assistant Professor at Sankara College of Optometry and Consultant Optometrist at Sankara Eye Hospital. She won the Best Outgoing Student Award for the batch of 2018 to 2020, pursuing a fellowship in vision therapy from Association of Schools and Colleges of Optometry. Over to you, Nikita.
Thank you so much for that introduction. Is my presentation visible? Are you able to hear me?
Yes, all good. Go ahead.
Okay. Very good evening to one and all present here. It's my pleasure to be a part of OPTOVERSE 2023. To begin with, I would like to wish you all a happy World Optometry Day. So today I'll be talking about the principle of vision therapy and its effectiveness. Before we go into vision therapy, to speak about what vision is all about, I think already there were many speakers before me who spoke about what vision is all about. But just to give a glance about the vision, once again, before we get into vision therapy, vision is not something where the image is projected onto the retina and then we capture it and then we see it. It's not like that. But then vision is more to do with sensory motor process. In fact, in our day-to-day life, vision is something more than what we see, where Skeffington, he comprises vision as a combination of anti-gravity in understanding who am I and where am I in my visual space. Where do I stand in my visual space? Suppose if I have my visual space, so where do I stand? How far or how am I grounded? How is the gravity force that is according to which how should I balance my body? And it also speaks about centering in understanding where is it exactly. So where is the object that is there ahead of me? So where am I standing in understanding something we call as proprioception, in understanding where do I stand, where my hand, where is my feet, how do I organize a task, and in understanding all these things, I need to have a good coordination between my vestibular system, my eyes and ears. And the third thing is about identification, where we understand how is an other object away from us. How is an other object that is placed away from us in the visual space? So it is talking about the oculocentric and ecocentric position of the objects, wherein we try to understand how far is an object from me in my visual space. It mostly talks about my perceptual skills, visual perceptual skills is what is happening here, which is going to give me a lot of information about the magnocellular and parvocellular pathway in understanding about where am I and how far am I from other objects in my visual space. And in the end, it's about how do we describe it? What do we have to do? How do we have to describe the components that we are seeing, the details that we are seeing in our visual space? So Skeffington had already defined vision in this manner. If there is any problem with respect to our binocular vision, where each eye vision is fused, there is a sensory fusion and motor fusion which is happening in our eyes, where the sensory fusion happens at the level of visual cortex. When the sensory fusion fails, and then it goes ahead with the motor fusion, which is compromise using the fovea, where the fovea takes over, where there is a fusion, there is a break in the fusion, but then because of the motor fusion, there is a fusion that comes into the play. Now, when these sensory and motor fusion gives up, that is when the strength of that is where the strength of optometric practice lies. We can treat it, we can handle it, we can provide care and treatment to any person with the binocular vision disorders and perceptual disorders. So vision therapy helps in developing the visual abilities in order to achieve an optimal visual performance. In our day-to-day life, we experience and we are in contact with a lot of near activities. Not only now, even earlier also, people were engaged in a lot of near activities, which is socially compulsive to say, even as classroom environment, even as the time that we spend at studying, at monitors, at our mobile phones, everything is socially compulsive near vision task. Now, when we spend a lot of time at near vision, we have this stress point, which is focused more in front of our eyes. When I say stress point, it is a visual stress that's happening because the convergence is focused ahead in front rather than the accommodation, where accommodation is lagging behind in this condition. The accommodation is considered as not suited for extensive near work. There is autonomic dominance of accommodation, where there is a relaxation of accommodation, or there is lag in accommodation that we are seeing. This near point stress can cause discomfort, inefficiency, and avoiding the near work, and it can also cause some changes with respect to refraction, which is what we call as myopia. Today, the world is running behind myopia progression. We are talking about there is a lack of accommodation, there is this accommodation that is a main reason for myopia progression. Now, this is what is happening with myopia progression. When there is a convergence, there is a visual stress that's happening where the convergence is focused ahead, in front, or closer to the eyes as compared to accommodation. The accommodation gets into a lag of accommodation, and further it causes some skew in refraction going into the pseudomyopia and myopia progression. Now, what should we do for this? The procedures that we need to do in order to relax this visual stress is bring in the relaxation therapies. Now, when I say relaxation therapies, it's not only to your eyes, but unfortunately, the stress is not only to your vision, but also to your entire body. So now, when I say about relaxation therapy, with respect to vision, it is the basin fusional vergence, building the basin fusional vergence, that is a divergence. Instruct the patient to relax, keep calm, reduce their tension in shoulders, neck, upper back, jaw, ask them to take a deep breath, ask them to help them to look easy. Now, this helps in pushing back the vergence system beyond the plane of regard. This in turn helps in improving the peripheral awareness. Now, when we ask children, when we ask the patients to spend more time outdoor, when we ask them to go outdoor, when they see the greeneries in the field, there is a relaxation in the entire body that's happening, and there is an extension of the peripheral awareness. The peripheral awareness improves rather than central focusing, or more to say, focusing or getting the convergence more closer to the eyes. There is divergence happening there. So this improves the peripheral awareness, which further improves the visual efficiency. The visual efficiency can be called as accommodation and vergence. The principle that we need to keep in our mind when it comes to vision therapy is when we change the direction of light that is projected onto our retina, when we change the way light is projected onto our retina, the body posture changes because our perception is changing here. Now, this change in the distribution of light onto the retina can be changed using lenses, prisms, or changing the visual efficiencies with respect to accommodation or convergence. When we change the vergence and the accommodation system, also the way the light is projected onto the retina, distributed onto the retina changes. Now, when this changes, the way a person perceives his visual space changes. When the way he perceives his visual space changes, there is a behavioral change that is happening to his body. In turn, there is a postural change that is happening to his body. Now, when we are, for example, when we say a person is uncorrected, when the patient is not corrected for his refractive error, then there is a, say if the patient is having an astigmatism, there is a skew in his body in order to adapt to the visual space that he's perceiving. When there is a myopia shift and it is not corrected, there is a lordosis shift, or the shift of the lower body or the abdomen pushed forward, and the patient has a more stiff back of the patient. When the patient is having a hyperopia, which is not corrected, the patient has the head moved more ahead, it is pushed forward. Now, all these postural changes are happening because there is a change in the way the light is shifted, distributed onto the retina. In the same manner, we can correct these body postures, we can correct the behavioral part using lenses, vision therapy, and prisms. Now, that was the main agenda or the main principle that we need to remember when we work on vision therapy, because in vision therapy, it is not about our the accommodation and vergence alone. It is not about the vision alone. As I discussed with you in the first slide, vision has more to do rather than what we are seeing. It is more about understanding about our body, where we are placed in our visual space, and where is another object placed away from us in our visual space. So vision therapy is a holistic approach where we are going to handle the patient in a holistic manner. Now, when it comes to the aspects of vision therapy, the first and the foremost thing that we need to work on is the eye movement. If a child has poor fixation and poor eye movements. Now, when I say eye movement, it is to do with the saccades and pursuits. Now, when a person has poor eye movement, poor saccades or poor pursuit, the child or that person is going to more rely on the head and the body movement rather than the eye movement, which is not good when it comes to your detailing, when it comes to understanding about your perception, the proprioception. We need to really improve the eye movement. Now, eye movement, when they are affected, it also gives us a clue that there is a problem with respect to the connection between the vestibular system and your eyes. Now, when it comes to the eye movement therapies, the therapies mostly is based on the gross motor therapies, anything to do with the gross motors, jumping, holding and rotating. All these gross motors will actually work on the vestibular system and in turn improves the eye movement skills. Once you have improved the saccades and pursuits, the next thing that we are going to work on is the eye focusing skill, that is the accommodation. That is the monocular part of vision. Even before we step into the binocular part, the monocular parts are corrected. So we have corrected the fixation, we have corrected the saccades and pursuits. The next thing that we are going to correct is monocular part, that is the accommodation. Now, when a person has poor accommodation, this is definitely going to have an impact on the vergence system of the eyes. That is a binocular aspect of the vision. Once the accommodation is corrected, we can correct accommodation using various techniques. We can give added lenses. We can give heart chart therapy, where the patient is expected to relax and stimulate accommodation, improving the automaticity of the accommodation. Now, this is going to be a slow process. We cannot expect the patient.
Sorry, 3 minutes to go.
Okay. And we cannot expect the patient to improve his have a good accommodation on the first day itself. It is going to be a slow process. After we improve the accommodation, the next thing that we are going to work on is vergence. The vergence is the most crucial part of binocular vision. Improving the vergence has to go hand in hand with accommodation. You cannot work on vergence separately, but it needs to go hand in hand with accommodation, because we know when accommodation is stimulated, vergence is stimulated, which is convergence. When accommodation is relaxed, vergence is relaxed, that is divergence. So it needs to go hand in hand, making sure both accommodation and vergence are balanced. After we have worked with the visual efficiency, we can go ahead with the advanced part of the vision, that is the eye-hand coordination and eye-leg coordination, which is to do with more sports vision, or even it need not be with regard to sports vision alone, but then there could be children who has poor eye-hand coordination, because of which they can have problems in writing from board, in organizing tasks where they need to observe something and then write down the same thing, observe something and then type. When they have to type on the laptop keyboard, it will be very difficult. So the last part of the vision therapy is eye-hand coordination, and side by side, simultaneously working on the visual perceptual skills as well. The aspects of the visual functions can be improved using vision training, as I told. And please remember, this is a top-down effect. This is not an eye muscle exercise, but this is a top-down effect where we are basically working on the brain. And from the brain, the process is going into the eye muscles, because of which every improvement that happens is an everlasting improvement. Now, this is where this is a table which shows us what are the primary treatment and the secondary treatment when it comes to vision therapy, where if you see for eye movement therapy like saccades, pursuits, basic esophoria, basic exophoria, your functional vision dysfunction, functional vergence dysfunction, for all these things, the primary treatment is vision therapy. Likewise, even for your accommodation excess and accommodative infacility, the only treatment that we have is vision therapy. no added lenses or prisms is going to help this condition, but only vision therapy is going to help this patient. Whereas if it comes to accommodative insufficiency and ill-sustained accommodation, added plus lenses can be given just as the condition convergence excess. Whereas if you see the divergence insufficiency and divergence excess, the primary treatment is prisms for divergence insufficiency and vision therapy for divergence excess. Secondary treatment can be considered if the patient is unable to perform the primary, is unable to come for the primary treatment, or the patient is not accepting to have an added lenses because maybe the patient is not comfortable in wearing the added lenses. Then in that case, always you can look for the secondary treatment. So this is the protocol as to how do we go ahead with vision therapy. Appropriate lens correction. First, the patient has to be corrected for the refractive error that the patient has. If you would like to give any therapeutic lenses or prisms, if it is the primary treatment for that particular condition of the patient, it has to be prescribed. And as it comes to the vision therapy, as I told you, we start with fixation, saccades, and pursuits. After improving that, move on to the monocular part, that is accommodation, and then the binocular part can be worked on, and simultaneously you can work on the perceptual therapies as well. How effective is vision therapy? Vision therapy works on 4 different categories, that is developmental, preventive, rehabilitative, and enhancement. Development is if certain visual functions have not developed in any young children, it can be developed.
I'm going to have to ask you to slowly wrap it up now, please.
Yeah, I'll finish it in 1 minute. And the preventive is where if there is a visual disorder that is happening because of any condition, like for example, amblyopia can lead to suppression, then that condition can be prevented using vision therapy. In case if the patient has gone into some visual disorders, we have rehabilitative procedures in order to handle this condition. And in the end, we have advanced therapies as well to improve the efficiency and stamina of visual abilities. These are the few vision therapies that I spoke about. We have heart chart, lens sorting. For eye-hand coordination, we have the Marston ball with balance board. We have the Brock string and binocular therapies we have. In the end, you can work on the perceptual therapies as well. If we do not have motivated optometrists or trained optometrists, if the patients are not motivated, or if we do not have good facilities in office or home therapies, then we cannot really improve the vision therapy, or the vision therapy does not really work in such patients. To conclude, please keep in your mind, vision therapy cannot be worked alone, but it has to go hand in hand with other care providers as well if needed according to the condition of the patient. These are my references. Enjoy practicing vision therapy. If you have any queries, you can always mail to me. Thank you, everyone. I would like to thank the OPTOVERSE team for giving me this opportunity.
Thank you very much for that, Nikita. Next, I would like to call upon Sridevi Gaurishankar. Sridevi has a Bachelor of Science in Optometry from the Elite School of Optometry in India, 2006. She has done a prospective study on development and evaluation of a clinical test battery for sportspersons, comparison of their visual skills with non-sports persons, and presented in case study in Dr. E.V. Memorial Scientific Session in 2006, India. Sridevi is currently working in NMC Multispecialty Hospital in Dubai as a senior optometrist. Over to you, Sridevi.
Hi, thank you, Fahima, for the introduction. Very good evening to one and all present here, and happy Optometry Day to all. Today, my topic is about sports vision. So Okay, the slides are seen, right?
Perfect, yes, and we can hear you well too. Well done.
Yeah, thank you. So in this, we'll be seeing about what is sports vision, what is sports vision assessment, roles of optometrists in sports vision assessment and training, and the scope of it. So before starting to the topic, do you know about 37% of global population practice sports at various levels, like be it school, college, state, national, or international? And do you think that they all get proper sports training? because according to International Sports Vision Association, the vision is the most variable of all senses that impact our sports performance. So like the other physical and mental sports training and sports aids they use, it is very important to get sports vision training and vision aids to be used to reach the peak performance in their sports. So what is sports vision? It is the science that helps the sports person to reach the peak level of the performance through the enhancement of the visual skills with the brain. In the sports vision, first we'll assess some basic tests. There are some basic steps. We'll start off with a basic questionnaire in the to see what is the current visual skills and what will be their demands. So start off with questionnaire. In that we can ask basic questions: what kind of sports they practice, whether it is an indoor or outdoor sports, whether it's a team or individual sports, what is the role of the person in the particular sports, whether they are right hand or left hand, and so on. And other tests will be your visual acuity, ocular movement, ocular alignment, depth perception, contrast sensitivity, which we do in our regular clinic. So we will move on to the comprehensive tests. Apart from these basic visual skills, the other visual skills which are more important for a sports person are reaction time, ocular dominance, peripheral visual awareness, dynamic visual acuity, saccades and perceived ocular movement, eye, hand, or leg coordination. We will be discussing each topic in detail. So first start off with ocular dominance. What is ocular dominance? If suppose if even the person has equal vision in both eye, like 6/6 in both eye, one eye relays more information more accurately to the brain than the other one. So some sports like aiming sports like shooting games or archeries, it will be better to find out the dominant eye and give in practice in that eye more focusedly. So mostly the right eye will be dominant, just like our right hand dominant, and there are few percentage of population who have left eye dominant as well, like left hand dominant, and there are few 17% of population who have a mixed ocular dominance, that is they don't prefer any dominant eye. So how to find out the dominant eye? It is very simple. Just make the person to sit straight and focus at a target and give an 2 centimeter aperture hole, place it in front of both the eye and ask them to close one eye. The eye through which the person is able to see the target through the hole will be your dominant eye, and the non-dominant eye, he will not be able to see the target through the hole. Or simply you can do with two hands finger, make it as aperture hole and focus at the target and ask them to close one eye and see. The eye through which you are able to see the target through the hole will be your dominant eye. Next week we'll talk about reaction time. Reaction time is nothing but how quickly a person perceives and react to a stimulus. It can be done with a simple ruler drop test. It is nothing but we need to take a long scale like 1/5 scale and hold one end of the scale by us, and the other end the person must place his 2 fingers at the 0 level marking. He should not grab the scale, he should just place the finger at 0 level marking, and then without informing the person we need to drop the ruler. As soon as the ruler is dropped, he need to grab the scale, and the level of marking that the person is holding the scale should be taken note. And with the formula D equal to UT plus half AT square, the reaction time is calculated. This is the score chart for that. Next, we'll see about peripheral visual awareness. Even though we know that our foveal vision is most optimized for sharp and clear details, whereas our peripheral vision is optimized for gross and coarser details. So without sufficient peripheral awareness, the context of visual space will be lost and it becomes very difficult to distinguish the image from the ground for a person. So how it is said, there is a vision disc available in the market with various degrees marking. and the person must fixate at the center 0-degree marking, and there will be a moving arm in that. In the end of the moving arm, there will be optotypes or numbers written. This moving arm should gradually move from peripheral to center, and the degree should be taken on where the person is able to recognize the target and where he is able to identify and read out the letters. It can be done for both right and left side. Next is our dynamic visual acuity. Dynamic visual acuity is the measure of target recognition during the relative state of motion between the target and the observer. It demands three elements like predicting the target, subjective resolution of the target, and the response time. There are two methods in measuring the dynamic visual acuity. One will be the stationary target with moving observer, and other will be the moving target with stationary observer. First, we will see with stationary target with moving observer. In that, due to the head movement, it will stimulate our vestibulo-ocular reflex. What is vestibulo-ocular reflex? Due to the movement of head, there will be a compensatory eye movement in the opposite direction to make the image to fall on the fovea. So if there is a rapid movement of the head, it will cause the retinal slip, which in turn decrease the dynamic visual acuity. So how it is done? First, our static visual acuity is recorded at 3 meters. The smaller slide the person is able to read. Then we will instruct the person that we are going to move his or her head from behind, and the person need to read the chart. We can do it vertically and horizontal movement also in the visual space. And the smallest line the person is able to read the chart will be recorded. If 2 lines below, if the dynamic visual acuity is 2 lines below the static visual acuity, we consider it as abnormal. Next is with moving target with the stationary observer. In this moving target, we request ocular movement like pursuit and saccades ocular movement. Pursuit ocular movement, as we know, it is a smooth, slow movement of tracking the target, moving target, to keep the image to fall on the fovea. And saccade is a fast refixatory movement of the eye to place the image to keep focus in the retina. So it is very important to have a good saccade and pursuit ocular movement in correlation with the dynamic visual acuity. So there are a few methods of testing with the moving target. One will be the Bernal's rotator. In this, the Bernal's rotator, it is a rotating disc which is connected to a motor where the speed of the rotation can be controlled. And in the disc, the various size of optotypes is written in them. The smallest line 3 meters apart the person needs to sit, and the smallest line the person is able to read is recorded. In this, we should record the vision with the rotation per moment. For example, the person reads 6/9. We should record it as 6/9 at 45 RMP, rotation per minute. One of the main disadvantage in the Bernal's rotator is the target cannot be moved in vertical and horizontal visual space. It gives only the torsional movement. It can be either clockwise or anti-clockwise rotation can be done. And there are other software available to test the dynamic visual acuity. In this, we can adjust the size of the target, speed of the target, and the direction of the target can be moved, and we can record the dynamic visual acuity. Next comes our eye, hand, or leg coordination. Why leg coordination also? Because in many sports like football and soccer, the leg and eye coordination is more important than our hand and eye coordination. So it is a complex cognitive ability to unite our visual and the motor skill. And it analyzes the motor response, speed, accuracy, and our coordination. It can be tested with simple Anderson wall toss test. So the person need to stand 2 meters away from the wall and he need to toss the ball with one hand and catch with the other hand. Alternately, he should repeat the same thing with both the hand, and the number of successful catches in per second is recorded, and this is the scoring chart for that. After finishing the assessment part, we'll move on to the training. In this, there are various modes of sports vision training. It can be optical aids, manual exercise, advanced technology, and combined therapy. Before starting the therapy, the person must have his best corrected visual acuity, either unaided or with aided or with contact lens or etc. We can add on with tints, filters, depending upon the person's visual needs and demands in his sport. And then the other manual exercise we usually practice in the vision therapy, like flippers, pencil push-ups, fusion cards, Hirschstroke, etc., etc. And but this alone will not be sufficient for training a sports person, because their demands will be more challenging and it will be morely the outdoor unit. So we have to make it more advanced and more challenging for the person to get it trained. So like a few of the training methods I like to discuss will be, instead of single broad string, we can take it as multiple broad string. So the person will find really challenging to focus on a single beat. And the other Marsden ball, in the same way, the Marsden ball will be having different optotypes or numbers or letters written on them. And once the ball is swing, the person is given with a stick with a different color labeled on them. They need to hit the bat at the particular color which we ask them to hit. And it can be more challenging for them if we ask them to read out the letters or numbers which is written on the ball as well. And other things like there will be different flashlight placed on the walls, and it will be glowing randomly, and the person has to hit the light immediately once the light is on, the particular light alone he need to hit it. And like this picture, you can see a net placed in front of the person, and ball is given, and he need to throw the ball at the particular region which we ask them to do. And other simple test, we can stand 2 meters away from a person, and we can have a random balls in which we have the numbers or letters written on them, and we randomly throw the ball, and the person need to catch the ball. While catching the ball, he need to read out the letters or font numbers written on the ball. It can be made further complicated and challenging to by making them to stand on the trampoline on or making them to place stand on the level balancer. It will be more challenging for them. And there are other stroboscopic training tool available, like flashlight or various goggles, like translucent goggles, or one side transparent, one side opaque. And the latest technology is synaptic probe goggles available in the market. It uses the liquid crystalline technology, and it can be connected to our device also. By that, we can adjust the it actually gives a flickering of clear and opaque region while doing the training. So the basic idea is to give an intermediate information to the brain, so that it enhances our visual perception, awareness, and our reaction time. So actually, there is no particular protocol to be followed in the sports vision training. It's in the training session should be customized according to the person's demands and needs in their sports. So there are further advanced technology like visual reality training. In this, it will be more realistic for them to train, and other software training available in the market, where in this software we can also do the assessment part. The manual exercise which I discussed earlier can be done in the same software, and then the training session can be held in the same software, so that we'll have a clear graph of the person progression and his skills. And these are my references. And as you know, the sports vision clinic and training is not very popular among the Indian and UAE countries like the other Western countries. So as an eye care professional and optometrist, it's our duty to create awareness about the sports vision clinic and training to get a outstanding performance from the sports person in this highly competitive sports world. Thank you for giving me this opportunity.
Thank you, Sridevi. That was very, very interesting talk indeed. So
Thank
now
you.
we'll move on to our poll questions. So if you could just take a look at the questions. In patients with a facial nerve paralysis, all of the following characteristics may be present except eyebrow ptosis, blepharoptosis, epiphora, lower eyelid extropion. The second question, which of the rectus muscles inserts the closest to the limbus? Lateral, medial, superior, or inferior rectus? Which of the following two statements about strabismus secondary to thyroid ophthalmology is false? It can be restrictive, it can be caused by extraocular muscle weakness, it usually is surgically corrected early after onset, or it is unrelated to the degree of thyroid function. Which of the following nerves does not enter the orbit through the superior orbital fissure? Cranial nerve 2, 3, 4, or 6? Which of the following is not an example of monocular cues? Looming, disparate retinal images, motion parallax, or aerial perspective? Which eye movement disorder is most commonly seen in patients with paraneoplastic syndromes? Downbeat nystagmus, upbeat nystagmus, superior oblique myokemia, and opsoclonus. Perfect. Now I would like to call upon Dr. Raman Mehta, Nikita Jacob, and Sridevi just to follow our panel discussion. Thank you guys for your insightful talks today. My first question would be for you, Dr. Raman. So, Dr. Raman, you touched upon the fusional exercises. My question to you is, in cases of convergence insufficiency, what is your go-to exercise?
Well, my goal is basically to make the patient symptom-free, but also basically to bring the exophoria less than 6 prism diopters actually. That's what my goal is there. But the other goal is also to make the patient symptom.
Sorry, no, my question was, what's your go-to exercise? What would you go to?
Okay, go to exercise. So we basically here are basically most of the times are going for pencil push-up exercises here or cat card exercises. But in my previous institution, we had a whole vision therapy unit, so we used to go for Brock string exercises, some for stereogram also sometimes.
Thank you. And Nikita, my question for you would be, with your vision therapy, so when you use it as a primary therapy, how long does it typically take until you're happy with the outcomes?
How long? Can you please repeat?
So when you use vision therapy as a primary treatment mode, how long is the treatment therapy typically until you're happy?
Okay. When it comes to the primary treatment, when we talk about the added lenses or the added prisms, they act as a relieving lenses or the relieving prisms rather than treating the condition. It's only relieving the symptoms. But then if the patient need to have a complete cure for the condition, the visual disorder that they're having, then vision therapy is the right option.
Thank you. And finally, so sports therapy, actually myself, I didn't know much about this. So is it something that you find, I mean, at what point are you happy with the results, and at what point do you feel like, it's successful?
Actually, now I don't practice this sports vision, just as a talk. But during my graduation, we had a prospective study, as you in the introduction also you told. We had a prospective study. We built our own test battery to test the patient, sportsperson and non-sportsperson, and we had a comparative study between the sportsperson and non-sportsperson. And we had a study result show that the sportsperson showed little better performance in few of the tests. Okay, but as I told, there is no standardized test or thing yet to develop in the field of sports vision therapy. So everything is a study-based analysis only.
Okay, thank you. And thank you all for your participation today. I'd like to hand it back to the host, please.
Thanks, Ms. Fahima, and all the speakers of the session. It was very engaging and informative discussion. I'd like to now let's move forward to the fourth session of today's evening, the ocular meniscus, the contact lenses. Do you know the ancient history of contact lenses? The famous Italian inventor Leonardo da Vinci was the first to come up with concept that resembled a contact lens. He only gave the idea of looking through the bottom of glass bowl filled with water. Now I'd like to call Mr. Sharath Raj from IonCare to moderate the next session, contact lenses. He is also a core committee member of UIOF team. I'd like to request all the speakers also to finish their talk in time because we are running late. Over to you, Mr. Sharath.
Thank you and good evening all. Happy World Optometry Day to all. Let us welcome Dr. Millicent Green. He is a South African specialist ophthalmologist, currently practicing in Gulf Eye Center in Dubai from 2002. Expert in specialty lenses, scleral, semiscleral, and orthokeratology for the myopia management in pediatric cases. She is going to share her experience on orthokeratology. Hand over to Dr. Green. उसको unmute करो यार.
Good. So good evening to all and optometrists, and congratulations on World Optometry Day. We trust that you all had a good day today, and of course that this means that what you each practice in optometry is going to be worthwhile, get more meaning, and also we trust that this whole meeting with Optoverse will contribute a lot to what we do day by day. Okay. So I will be sharing about orthokeratology and why we do that. This is a quote from Leonardo da Vinci, and just singing the praises of vision and what it can do for us. So the definition of orthokeratology, ortho really means that we correct.
Sorry, doctor, can you share your screen, please?
I have tried to share my screen, sir. See. Yes. Okay, share screen. Are you able to see my screen now?
Yes, yes, doctor. Thank you. Thank you.
There we go. Appreciate it. So, okay. Okay, so I need to share about orthokeratology and why do we do this. So this was a quote from Leonardo da Vinci that praises vision and what our eyes can really do for us. The definition of orthokeratology: to correct deformities, although Here we create a shape that is beneficial. It is in a similar vein as with orthodontics, orthopedics. We change the structure of what we work with for the benefit that we need to achieve. So we look at the history, advantages, disadvantages, alternatives, how, why, and myopia as such. So it's also known as corneal refractive therapy, a non-surgical treatment with rigid contact lenses to temporarily reshape the cornea. It's worn during sleep, and it provides clear vision for the day without the need of glasses and contact lenses. So when the lenses are worn overnight, the inner shape, which is relatively flat, will exert a force on the cornea to achieve a flattening for the vision change that we want to achieve. So how did this come about? There's talk about Chinese soldiers years and years ago who would sleep with sandbags over their eyes and find the next day that they see a lot sharper and are better at their target shooting as archers. There is also information from Da Vinci's manuscripts that indicate that he has also had thoughts about this change that we can bring about. Then a bit more recently, back in 1887, a German glassblower by the name of Müller also came up with the idea of contact lenses as a potential means of vision help. And there are several other instances in history where people contributed to this. So the more modern concept of corneal reshaping is more from the 40s, where ophthalmologists wanted to explore the use of contact lenses. Then these early efforts with rigid lenses to flatten the cornea was limited by poor fitting and discomfort, and of course the materials used at the time. So in the 50s and 60s, new materials became available, more comfortable and accurate. And the current credit for orthokeratology is given to George Jessen back in 60 years ago, where he specifically designed a lens with the idea of corneal reshaping. It didn't really take off much in the early years, and in the 80s started to get a better foothold. And then other early pioneers would be Robert Morrison. The refinement and the prescription techniques just got better and better over time. So development continues into the 90s, and in 2002, FDA approved ortho-K lenses as overnight wear lenses and validated the safety and efficacy. We know that any contact lens that we place can create irritation, but it is something that can be taken care of by simply stopping it and treating the particular reason for difficulties. So what would be the advantages of ortho-K? It provides good vision without spectacles during the day. It's not a surgical procedure. It's reversible, modifiable. It doesn't hurt when it is well chosen, and it may slow down the increase of myopia in children. And it is currently we use well-established contact lens fitting techniques that reduce the risks to the patient. Disadvantages, it is in a way labor intensive, so several visits are necessary to optimize what you need to achieve for the patient. And this retainer lens, which is used overnight, is essential to be used night by night to maintain the shape that you achieve. The degree of success is high, but we know we cannot always guarantee. It is really individually determined. So the speed of reduction of myopia does vary from person to person, among other reasons for how high is the myopia to start off with. And it's important to follow instructions for the best results. So the success rate, we know that not all patients will necessarily adapt to orthokeratology, but up to 80% and even 90% of patients well-fitted can benefit from the changes in orthokeratology. So how does this happen? Way back when RGP lenses were used, Some of the side effects was that the curvature changes on the cornea, and it was seen as a nuisance in a way, and it did need the eye care practitioner to make allowances if the patient needs to use the glasses when the lenses are not used, and to allow for whether it is before the contact lens use or after the contact lens use, due to these flattening effects of RGP lenses to the corneas. So in the 80s, lenses were then designed with reverse geometry to be beneficial and became used in cases post-keratoplasty, where glasses would not give adequate vision, but reverse geometry contact lenses were helpful even in pellucid cases. And many patients who were fitted in those days still, after many years, are benefiting from the reverse geometry lenses, among others. So orthokeratology lenses are made out of RGP materials. The curves designed in the back surface of the lens does create a layer of tears behind the lens, which cause a gentle hydraulic force, and this ends up molding the cornea to another shape during sleep time. So today we have custom designed options, digital systems to design the lenses to what we want to achieve, whether most commonly for myopia, but there are also practitioners who help with hypermetropia. Astigmatism is combined with the myopia treatments, and there's even presbyopia options available. It's a little more tricky to do, but there are practitioners that are quite proficient in assisting with that. So the designs are topography driven, and the topographies are drawn into the design programs to then design the shape of the lens that you need for the particular patient. So it is not surgery, and therefore it's not intended to be permanent. But patients, some patients don't even sleep every night. They have a very light correction, and they use the lenses for the times that it's important for them to use. But the lack of permanence is both a strength and a weakness for the system, and it gives you adjustability for future needs. And then, since we can understand that both laser vision correction and ortho-K can occasionally create unwanted night effects, but with ortho-K, you can simply stop using it and you will get your old shape back. Of course, with surgery, you have made a permanent change. So again, most myopia, hyperopia, astigmatism, presbyopia can be assisted by a very skilled orthokeratologist. It most commonly is used for myopia. So these lenses are worn overnight with and we say it is a temporary correcting myopia, and in teenagers, it is also a factor of slowing the progression. It is highly effective. The percentages of help varies from 50 to 60 or even 80%, depending on the practitioner and the style and the particular brand and so on of orthokeratology lenses that are used. If it is well planned and well executed, it is safe and effective. And it does, however, ask for a high level of compliance and maintenance. So it is important that the best myopia control option for individuals will still depend on factors such as their age, their lifestyle, and of course the severity of the myopia. So what are alternatives to orthokeratology? I'll share a bit about atropine, soft contact lenses, and then eyeglasses. So in atropine, drops are used. It is a much reduced concentration to 0.01%, 0.05%. That is, it works by minor dilatation of the pupil and relaxing of the ciliary body. But some patients can be sensitive to this, and even sensitive to the atropine molecule itself. And then other side effects is sensitivity to light and even blurry vision should the accommodation relaxation be more than the patient can handle. So long-term safety of atropine drops is under discussion. In controlled situation, it works very well, but the practitioner needs to really take good care. So it, like we said, it works by relaxing the ciliary body. It is shown to be effective in some systems, up to 60 or 70% in some studies. The side effects I've mentioned. Okay, so other options, soft contact lenses. Ordinary or conventional soft contact lenses are not seen as very helpful for myopia control, but because they do not do any reshaping and there is not really any influence on the myopia. It is a good option for people who do not want to wear glasses, but are not interested in myopia control. The multifocal contact lenses, however, can be helpful and depends on the type of multifocal contact lens. So the percentage of help is not nearly as good as what it is with orthokeratology or with atropine, but it does provide a measure of help. So prescription eyeglasses, ordinary or conventional eyeglasses are not really very helpful for myopia control. It's a fairly low percentage. It is better than nothing, yes. And we may be aware that there are companies now that are providing very specialized design of eyeglasses, where the it's like a concentric design of a change of the glasses that needs to be very precisely positioned within the frame as per the patient's pupil distance to be helpful. That is quite a newer development, and the availability is not yet very wide in the world. And we hope to have one of these options launched soon here in the UAE. So back to multifocal contact lenses, the type of multifocal contact lens is important. For us presbyopes, we would use a center near, but the type that is used for myopia control would be center distance. So the other options, I think I don't want to repeat here. See. Okay, so overall orthokeratology is seen as a safe and effective option for myopia control. It significantly slows down the progression of myopia and provides the added benefit of temporary clear vision without glasses or contact lenses. It does depend, the efficacy does depend on the patient's age, their lifestyle, and of course the severity of their myopia. So these lenses are worn overnight. Let me see. I don't want to repeat myself too much. Okay, so the lenses are, like I said, custom designed, and they, sorry, I think I have shifted back instead of front. Sorry about that. Okay, so here are some reasons why orthokeratology is chosen to be used as a therapy for myopia control. It is effective. It reduces the rate of myopia progression significantly. And the important thing is here, it helps reduce the risk of developing eye conditions associated with high myopia, such as retinal detachment and glaucoma, as well as macular degeneration. And of course, the four conditions in high myopia would be retinal detachment, glaucoma, macular degeneration, and cataracts. So unlike traditional contact lenses, which needs to be worn during the day and removed at night, these lenses are worn overnight and therefore allow for clear vision without help during the day. It's especially beneficial for people with active lifestyle or who work in environments where the traditional contact lenses may not be so practical. So as far as visual performance, orthokeratology lenses can provide really excellent visual performance, and many patients therefore report a sharper, clearer vision throughout the day. It can also be beneficial for patients in certain sport situations or even in certain career situations where contact lenses or glasses may just be in the way. It is non-surgical, so it is reversible. It is an alternative to a condition to treatments such as LASIK or other laser vision corrections, where patients may not be candidates for such procedures or would not want their any surgical procedures done to their eyes. So one can achieve for orthokeratology a customized fit. These lenses are designed individually for each patient, unlike conventional contact lenses off the shelf, where it's not individualized. So the patient's own corneal curvature is the base of the design, then combined with their prescription, and then other factors such as astigmatism taken into account as well. So a good design will then ensure a comfortable and a precise fit, and it can therefore improve visual performance and therefore overall comfort for the patient. It is important to know that it's not necessarily suitable for everyone. There are risks and potential side effects to take into account, and therefore an orthokeratology experienced practitioner will then help to determine if a patient will benefit from orthokeratology and will be a good option. So it can be explained to patients that it is a safe and effective and reversible alternative to traditional methods of vision correction, whether we are developing myopes or whether we are adults that just want something different than glasses or ordinary contact lenses. So the improved visual acuity, uncorrected acuity that is achievable, the reduced dependence is very attractive for patients, and there are, especially for developing myopes, the potential long-term visual benefits. So we need to, as with all contact lenses, there is no exception, we need to emphasize the importance of proper lens hygiene, regular follow-up exams so that the results can be optimal, and of course that complications can be prevented. So orthokeratology is recognized as a safe and effective option. It has and will and hopefully become more and more useful for developing myopes and also for patients who are not really ready or willing to undergo a permanent vision correction procedure. So ongoing research and development is continuing, and it with the years and the time lead to better outcomes and also obviously a wider acceptance of this vision correction method. So why do we do this? I think we all will hopefully be aware. Yeah, so it's most.
Sorry, Dr. Grim.
I don't hear you, sorry.
Another 2 minutes to go.
Thank you.
Another 2 minutes to go.
Okay, thank you very much. So the talk is about the myopia epidemic. The WHO statistic tells us that by 2050, 50% of the world will most likely be myopic. There are many factors that drive this myopia epidemic. We talk about genetics, we talk about environmental factors, urbanization all through the last 100 years, decades. There's been significant change with urbanization and the effects on vision, education levels, even ethnicity. So it is important to note that while these factors do contribute to the myopia epidemic, ongoing research needs to continue to understand the underlying causes, and then, of course, to figure out effective prevention and treatment strategies. So just another quote, Leonardo da Vinci believed there are three classes of people: those who see, who know this is happening; those who understand once they are shown what's happening; and those who just don't do it. And we know we have colleagues who feel that the contact lenses is just too much of an intervention. And yet on the other side of the spectrum, we need to intervene. And this is a means that can be done safely to help specifically with the myopia epidemic among our developing patients. So there is a pledge that the World Council of Optometry made a video about, and I'm sure we will find it on the web, and which explains again the whole concept of the myopia epidemic in the world, and then what we can do about it. And I think we should all really undertake that we will make our contribution in this. So thank you very much for your time and the privilege of sharing about orthokeratology. Thank you.
Thank you, Dr. Greem, for your wonderful session. Let us welcome our next speaker, Mr. Rahul Raghav, currently working as an head of the optometrist, contact lens and LVA specialist in Quran Medical Institute, Dubai. He is the medical director for Eye Care Medical Trading LLC. He is going to share his experience in myopia management with the soft lenses. Hand over to Mr. Rahul.
I think you're on mute, actually.
Yeah, sorry. Hello, good evening, everyone. Today I'm going to talk about soft contact lenses to control myopia progression. I would like to thank entire team of the Optoverse to organize such a beautiful platform to share and update our knowledge. And I'm pleased to be part of this great event today. Let me start my presentation, and this is my slide. Am I audible, Sarat? Myopia has been emerged the worldwide public health issue and one of the fifth ocular condition identified as immediate priorities by World Health Organization. Myopia has been predicted to affect approximately 50% of the world population based on trending myopia prevalence. One of the possible cause of myopia progression is increasing in the axial length of the eye, which is stimulated by the blurring generated in periphery due to hyperopic defocus found in the pupil myopia. In recent years, therapeutic modalities were designed to slow down the progression of myopia has globally increased, with numerous of studies evaluating the efficacy of various treatment of myopia control. In order to decreasing efficacy, these treatments are include atropine, orthokeratology, peripheral defocus, contact lens, and special design optical lenses. Peripheral defocus soft contact lenses are effective in slowing down the progression of myopia and provide typical benefit of soft contact lens, such as comfort, good tolerance, and good quality of vision. These are the contact lenses soft contact lenses are available in worldwide to control myopia progression. And today I'm going to talk about Essentia contact lenses. These are the Essentia contact lenses are available for the soft myopia control progression. And you can see here the Essentia and Essentia toric. Essentia is only for the spherical power and Essentia is toric for the astigmatism. This is the first lens in the world which is available for the astigmatism correction as well as for myopia control. These lenses are fully customized. You can customize according to your patient requirement, pupil size, optical zone. As per the requirement, they will customize lens for you. And how it works. Myopia control soft contact lenses are designed to slow this escalated eye growth based on how images are focused in different part of the retina. They work by directing a portion of incoming light rays to focus in front of the retina and stop the signal, the eye growth. Myopic optical blur constitute a negative stimulus or visual feedback, contrary to axial innervation of the eye, by slowing down the progression of the disease. These are the parameters of the contact lenses. And as I said before, this is a customized lens, so you can customize according to requirement, according to your requirement. If the parameters is not here, also you can customize. If we will talk about the base curve, it's available from 7.8 mm to 9.2 mm with the step of 0.1 mm. And diameter is available from 14 to 15 mm with a step of 0.5 mm. The power. This is the beauty of the lens actually. If you see, the power is a very wide range, which is quite surprising also, because power is available from 0 to -20. And astigmatism is 0.75 to -6 cylinder. And axis, as I said, customized, because you can customize from 0.5 to 180 any axis. How to fit the Essentia contact lenses? So Essentia is a very easy and fast to fit, because this is soft contact lenses. You have to fit as same as you are fitting soft contact lenses in your daily practice. You need only 3 things to fit the soft contact lens: base curve, power, and diameter. Here also you need same 3 things: base curve, power, and diameter. And here, how to choose the base curve? You have to add 0.4 mm in flat cornea, and the power you have to select as same as you are choosing for the soft contact lens while calculating vertex distance. And how to select the diameter? You have to, if your corneal radius is less than 7.8 mm, then you have to select 14 dia. If your corneal radius is more than 7.9 mm, you have to select 14.5 dia. Then you have to insert the lens in the eye, wait for a few minutes, almost 20 minutes, then you can review the fitting and movement. Patient can use the lens as they are using soft contact lens since morning to evening. And before the patient leave your clinic, make sure the power which you are going to check is you have to do the over refraction. It should be neutralized. There are so many studies about the soft contact, defocus soft contact lenses, so I put few here. This is the study which was published in American Academy of Ophthalmology. Efficacy comparison of 16 intervention of myopia control in children. It was the meta-analysis study. So many things are here. I'm not going to take all the time. The authors are here. I will go directly for the conclusion. In the conclusion, they found the most effective intervention were pharmaceutical. And they found the moderate effect of on the progression was by defocus soft contact lenses or orthokeratology contact lenses. In same time, they found the less effective intervention was special design optical lenses. This is another study which they published. This is the one more study was published in the Clinical and Experimental Optometry in 2020. These are the authors. So if I will go to conclusion, it was the double multi-central double-blind clinical trial. The sample size was 17 and time study duration was 12 months. And they found 51% reduction in the progression of myopia, cycloplegic or auto-refraction. And they found 41% reduction in axial length growth, the p-value less than 0.05. And same time, they found 58% reduction in the subjective refraction increase. 91.7% participant repeated lenses comfortable, and 100% participant reported good quality of the vision with the Essentia. So if you see about the quality and the comfort, this was quite good. We can trust on it, and even the progression control almost 50%. So thank you so much. Happy World Optometry Day. If you have any question, we do take it.
Thank you, Mr. Rahul, for your wonderful session. Let us welcome our next speaker, Mr. Ramkrishna Salunke, currently working as Senior Optometrist in American Hospital, Dubai, practicing ortho-K, scleral lenses, and the CL fitting for pediatric cases from many years. He's going to share his experience in CL fitting in pediatric patients. Hand over to Mr. Ram.
Hi, good evening, everybody. Am I audible?
Yes, yes, Ram.
All right, so let's begin here. So yeah, happy World Optometry to everybody, and thank you for giving me this opportunity to discuss this presentation here. So today's my topic of presentation is pediatric contact lens fitting. So I'll try to cover three areas where why or what is the importance of fitting contact lenses in children. We'll try to find out which are the indications for pediatric contact lenses, and we'll talk about various medical indicated pediatric contact lenses. So the pediatric contact lens is a vast area. We have multiple options to offer to the patients, but most importantly, we have to consider these options in the right time, where the critical time for visual development is very important. We all know that first 3 to 5 years of age is most crucial for vision development and binocular vision development. So we don't want any deprivation or any kind of obstacle or barrier in the vision development. Especially we have seen in patients with congenital cataracts, if the visual axis is blocked, the visual acuity outcome is very, very limited. It also improves the binocular vision function over the spectacles. In recent time, in few years, we have seen that contact lenses, they are now widely used in myopic slowdown, especially the multifocal soft contact lenses and the orthokeratology lenses, which previous speakers, they discussed about these lenses. And then, of course, the athletic competence, where the children's with the sports activities, they are mostly using these lenses, and social purpose. When we talk about the indications, of course, the refractive errors is the first primary reason for offering the contact lenses. Aphakia is the must condition where we should offer contact lenses. And then, of course, the rest, myopic and hyperopic prescriptions and irregular astigmatisms and anisometropias. The myopia management, which I just mentioned, binocular vision anomalies such as accommodative esotropias. We have seen the contact lens performance is much better over the glasses because the base out effect in glasses, gives more accommodative demand. And that's the reason contact lenses, they usually perform better because they sit on the eye, the brain and eye coordination is much better. The visual axis of the optical center of the glasses, the contact lens and the pupillary center is always in aligned position. So it is much better for such patients. And also we have seen that patching in amblyopia is something we usually consider. And the cosmetic, prosthetic and visual comfort is also is considered with the contact lenses such as scarred cornea, aniridia, iris coloboma, and albinism. Other uses can be considered as bandage, contact lenses, and patients with nystagmus. Now, when we talk about contact lens, we know that we have multiple options to offer to the patient, but we have to make sure that we have to choose the right lens for the patient's age, and would we complete or fulfill the requirements of the patients for the patient's age. We all know that in children, especially up to the age of 5, there are refractive components which they change up to the age of 5, which includes axial length, corneal curvature, corneal diameter, and the refractive power. You can see the table here, wherein which you can see the axial length from birth up to the age of 5, and the rest, which is corneal power and the refractive power changes. So usually by the age, by 5, between 3 to 5, we expect these components to stabilize. So we know that the parameters, they are going to change with every few months of time. So that is the reason these kids, they need regular checks to review the fitting parameters. Fitting considerations, we will talk about the anatomical considerations here. When we fit any contact lens in pediatric population, we need to consider these factors such as palpebral aperture height or size, pupillary size and the shape, and the ocular muscle tone, the changing, we discussed earlier that the shape, the corneal shape and the refractive error, the blink frequency and the tear volume. Apart from anatomical consideration, we also need to know whether the eye has completely healed following the surgery, such as if you have a patient with, let's say, a past planar lensectomy or extracapsular cataract extraction, we ideally should wait for at least 3 weeks. And if it is extra, then we should go for at least 5 weeks. And of course, the surgeon or the consultant who did the surgery, we need to get his approval before we fit any contact lenses. As a child, especially in preschool age group, make sure that the adults or the parents or the guardians, they are able to assist the child in their beginning time. And the other factors such as environmental factors and the hygiene and the availability of the solutions. When we talk about the lens type selection, as we all know that there are multiple lens options available. So we have to select the lens which should be easy for a practitioner to fit and for the patient to handle. At the same time, the lens should be comfortable on patient's eye in terms of visual comfort or the ocular comfort. The lens material should be deposit resistance. That's what we will aim. These days we have silicone hydrogel lens materials with a higher water content, so that which will fulfill the oxygen transmission for the patient. The ease of replacement as well as the manufacturing availability of the lens within the region in your region is very important. And of course, we have to consider the condition of the eye, which is like, let's say if it is a corneal irregularity condition, we should consider the GP material contact lenses. If it is albino eye, we have to think about therapeutic prosthetic or cosmetic contact lenses, and at the same thing in aniria, requiring the wearing schedule time and the cost at the end. Now we all know that there are multiple contact lens materials available in the market, and the contact lens materials traditionally they've been evolving. We have seen soft contact lens materials such as silicone elastomer in old time. I mean, we know all Silsoft from Bausch & Lomb, which was basically it's a silicone rubber. But then the issues with this material is that the wettability, because of the the lowest water content, the lens wasn't really going longer for the patient, and that is the reason it has gone unpopular. And then the other materials evolved in later times, such as hydrogel and silicone hydrogel. Again, the limitation with hydrogel material is that with the low water content, or even with the higher water content, the oxygen transmissibility is again limited. So that is the reason silicone hydrogel is now getting or is now more popular option when we talk about pediatric or even in adult contact lens fitting. The other materials such as rigid gas permeable, hybrid is again extinct, and the scleral lens option. A basic diagram here to explain you when we talk about the spherical or toric contact lens selection. We're talking here about regular, we're not talking about the irregular cornea. Any kind of regular cornea having more than 4 diopter of astigmatism, then we should consider back toric contact lenses, and then we do the over-refraction. If this over-refraction is still showing more than 0.75 diopter astigmatism, we should consider bitoric contact lenses. If it is spherical over-refraction, then it should be just a back toric. And the other side, if there is no astigmatism, it is simply spherical refraction, we do the fitting and we do the over-refraction. We see the spherical outcome, the over-refraction outcome. If it is just spherical, we don't have to consider any astigmatism. And we see if it is more than 0.75, we talk about front toric. Now, why I'm going to talk here about the aphakia, because that is where most the contact lens the penetration of contact lens fitting is less, and we all should take the responsibility of fitting contact lenses in aphakic patients, because we all know that visual prognosis is much better with contact lenses over glasses. It is also very much proven that they help in reducing the distortion and anisoconia, especially in unilateral aphakia. There's no choice than contact lenses, especially in unilateral aphakia, because glasses, they're not practical option to consider. The other benefits, yeah, it creates less image magnification, well tolerated than spectacles, and few cases wherein which the surgery, the implantation of IOL is, if it is not possible, if it is contraindicated, the contact lens is the only remaining option to offer for such patients, especially which I mentioned, unilateral cases. When we do the pre-fitting evaluation in aphakia, first important thing is the post-operative refraction. And again, we have to rely on the retinoscopy results here. The handheld keratometry is something we can use. We can try to use in kids. If it is not possible, that's totally fine. We can go empirical. Measuring HVID is very much possible using simple scale and torchlight. And again, most important, we should consider this pupil size and the shape observation. It is very important to decide the optic zone size based on the size of the pupil and the shape of the pupil. As we discussed in earlier slide, silicone hydrogel is the most popular lens choice these days. So I'm going to talk about this lens more than the other soft lenses. As we all know that the lens comfort is much better compared to the GP or RGP lenses, and it's easy to fit for practitioner. Extended wear is very much possible because of the silicone hydrogel, and these days we all know that silicone hydrogel is now possible to get it in high water content lenses. So yeah, extended wear is very much possible with these lenses in pediatric aphakic patients. We all know that the material itself has a little slippery surface than conventional hydrogel lenses. That is the reason when we fit these lenses, we should really consider getting a little bit tighter base curve compared to the standard lenses. Again, this is the general rule we should follow here, which is just 0.2 millimeter. So when we talk about initial lens parameters, the base curve, we add 0.2 millimeter in the mean K readings for the initial base curve. Diameter, we can add 1 millimeter to the visible iris diameter. And the power, we can simply convert based on the spectacular refraction, and we can choose the first trial lens. Again, like I said, this is the rule of thumb. We can always go with our own judgment. And also, if we're not able to get the data, the pre-assessment data, we can still also rely on the empirical ordering table. Now, these days, contact lens manufacturers, they are giving the guideline data. Let's say you can see here the empirical ordering table, wherein which based on the age, you can select the first trial lens. And I again encourage here, it is always better to keep the trial lenses in your clinic. These days, suppliers, they are able to arrange the trial lenses for you. You just have to keep them in your clinic so that every patient comes to you for contact lens fitting. You should try these lenses instead of going empirical. Try to fit the lenses and then see if the fitting outcome is satisfactory. Fitting assessment.
Ram,
yes.
Sorry for interruption. This one 5 minutes ago. Okay.
Fitting assessment. Post insertion, we should wait for 5 to 10 minutes. We all know that in peds, infants, especially the supine position, we do the assessment using any slit lamp, handheld slit lamp. We can observe for centration, movement, and coverage. The optic zone should cover the pupillary area, or refraction to follow with retinoscope. And we all know that, especially in aphakic children in their infancy, we have to add extra up to three diopters to improve their near vision sight. And then we order these lenses, always order these lenses under warranty, so that in case if there is any need to change any parameters, we can always do that. I just want to simply play one video here wherein which how you put the contact lens in the eye. This is a silicone hydrogel contact lens. You can fold the lens in your thumb and index finger and open the lids and gently apply the lens underneath the superior upper eyelid and then push the lens in. And for removal, again, you can use the thumb and index finger to push the lens out. The other material, yes, RGP. We all know it has a physiological advantages over the other materials because of the material property as well as the tear exchange, what we get it with it. Extended wear is not possible. It is pretty much ideal in cases where in which there is a high astigmatism and corneal irregularity patients. Initial lens parameters, we all know that same as adult, we go with the flat base, flat K reading diameter. We can go HUID -2, optic zone, you can go pupillary diameter plus 1.3. Again, we wait for 5 to 10 minutes post-insertion. Most of the time, you can, in pediatric population, you may consider using local anesthetic to avoid the reflex tearing and affecting the fitting performance. And watch the fluorescent pattern for ideal fitting characteristics. And then you can usually, in pediatric population, consider slide base score, especially to avoid any lens loss in these cases. And we follow over refraction and order the lenses under warranty. Scleral lenses, very small percentage. We don't offer these patients these lenses in very early age. We consider only in teenage group, where in which we see if there's any keratoconus conditions, we consider these lens option. Fitting assessment, pretty much we wait 30 to 60 minutes based on the type of the lens. We watch for central, mid, limbal, and landing zone. We follow the over refraction, and we may use compensation tool time to time. The important thing is that we have to watch the clearance. There shouldn't be any touch on the cornea, and make sure that the clearance shouldn't be excessive or minimal. Prosthetic lens, again, considered as a cosmetic or for functional visual improvement in corneal scars, inoperable cataracts, iris anomalies, and traumatic damage to the anterior of the eye, and other conditions such as patching or photophobia or albinism. These are the different types of lenses you can offer to the patients. I won't talk much about myopia management. Previous speakers, they discussed already. We all know that peripheral hyperopic defocus creates or causes myopic progression. And we all know that ortho-K or multifocal contact lenses can slow down, prevent myopic progression up to 50%, which is clinically significant. And these days we have FDA-approved designs. Contact lens education is important, which is pretty much same as adults. Education to the child and guardian is important. The guardian is something which will take care of the lenses in the beginning, but then the children then over a period of time will get to learn about the care. The frequent replacement of the solutions is also very important. We follow these patients time to time very frequently, especially in peds. We have to consider the patient's age, the reason of fitting, and the competency of the child or the parent in doing the insertion, removal, and taking care of the lenses. We should review the fit by using the fluorescein to check the corneal and limbal health to see if there's any mechanical abrasion on the surface. And we should time to time do the refractive alteration if needed, or do the lens fitting in these patients. Complications, again, pretty much similar to the adults. You know that microbial keratitis or is most common. So we need to, if there's any kind of redness, discharge, we should ask the patient to stop wearing lenses, visit to the clinic, and we should look for any kind of infection in the eye. Many times it's not self-reporting in children. We all know that. That's the reason parents, they have to be aware or cautious if there is any abnormality observed in the contact lenses. Mechanical or hypoxic changes can be observed in the contact lenses. I'll just quickly do this case, one case here. We got this 4-month-old male, unilateral aphakic, post-operative state 3 weeks. Slit lamp examination was within normal limit. Stereoscopic values were 24 with mild astigmatism. HUID was 9.5 millimeter. K readings were average was 7 millimeter. We had a trial lens in our clinic. We tried 7.1 base curve with 11.5 dia. 32 diopter lens, and it was ultra vision silicon hydrogel with 74%, which was a quite good water content lens with a clear tint. Physical fit observed after 5 to 10 minutes was very well coverage over the cornea, and the optic zone was very well covered, covering the pupillary area. The movement was fine. The push-up test was very much well. O refraction was +1, and we added extra 3 to improve his near vision acuity. And the final parameters you can see here. We usually order 2 pairs in case we can always exchange the first and the second, and we can go extended up to 3 nights, and then we can switch between these 2 pairs of lenses. Follow up with the dispensing parental education was given for insertion and removal and care and maintenance. The fitting characteristics were very well observed, and the child was reviewed every 3 months with a revision of parameters. In summary, we should offer contact lens management for all the patients. Don't hesitate. We have all the options available these days. Multiple CL choices available, like I mentioned. Successful contact lens wear can improve visual acuity and the quality of life for the child. Collaboration is very much important between the parents and the provider, and which is beneficial for the patient. And we all know that it's rewarding for every happy child and parent and contact lens patient, contact lens practitioner. These are my references, and thank you very much for giving me this opportunity. Over to you, Sharat.
Thank you, Mr. Ram, for your wonderful session.
Thank you.
The forum is open for the panel discussion. Stay tuned for the few seconds while you find the questions on the screen. Kindly select the answers meantime. We will move to the panel discussion now. Dr. Greem, there is an interesting question from the audience regarding the orthokeratology. Can a dry eye patient use orthocare lenses, and what is the most common infection resulting from use of orthocare lenses?
Dry eyes patients can struggle. So one needs to make sure that the ocular surface is healthy, knowing that the patient uses the lens overnight. We do use lubricants to assist. The contact lenses are inserted with a saline solution, and we often add lubricants to the saline solution to assist. So it is important to watch out for the ocular surface and make sure that no erosions would develop. I have, for instance, one patient who has MDF dystrophy with the loss of the basement membrane, and had to actually stop contact lens wear due to that loose epithelium right in the middle, and had to give up. So ocular surface care is really important. In terms of the infections, I would not be able to tell at the moment. We have fortunately not experienced any of these since we got involved with orthokeratology in 2012, so 10, 11 years, and are thankful for that, for the practices and all the patients cooperating. But yes, dry eyes have occasionally prevented patients from continuing. That's why we say it's not necessarily 100% everybody can do so, but fortunately majority do.
Thank you, Dr. Graham. It's very informative. Now I would like Mr. Rahul to have one question from the audience. Mr. Rahul, can we shift any patient using orthocare lenses to the soft lenses for myopia control? Will she or he achieve the same results?
See, both the lenses are a good option for the myopia control. Both the lenses are working for the same stopping the progression of the axial length. So the best option depends on the factors which we have to analyze, like level of the myopia, astigmatism, pupil size, activity, the lifestyle of the patient, and the most important thing, as my colleague Ram said, patient and parents should be motivated for which option they want to go. So replacing is not not the suggestion. The suggestion is depends to choose the best option. You have to choose the best option according to the patient requirement.
Thank you, Mr. Rahul. Mr. Ram, there is one more question for you. Which lens is the best for the pediatric care, RGP or the soft lenses? And how frequently we need to change the contact lenses in the pediatric cases for RFK?
Okay, so there's two options we can consider: soft contact lenses and RGP. These two potential contact lens options we can consider in pediatric contact lenses. But as my own experience is that it is pretty much ideal to go with the soft, which is silicone hydrogel with a higher water content material, which is quite practical, which is easy to fit in for the practitioner and also for the patients to wear soft lenses to begin. Once they are a bit older, we can switch them to GPs or if they have a high astigmatism or if they have irregular astigmatism wherein which soft contact lens fit is not really possible, we're not able to mask the refractive error of the child, then we should then switch to RGP. So yeah, my first preference would be the silicone hydrogel with the higher water content material, and if not, then of course we have the RGP lens material. If we talk about the replacement, the silicone hydrogel materials, we have quarterly system. Every 3 months, we should replace the lens for the patient. And like I said, I usually ask my patients for their parents to get at least 2 pairs of the soft lenses, not to just because with the kids there are high chances of losing the lenses. So it's better to have at least an extra pair with them. So in case if they lose one lens, they have the second backup lens with them, and they can always switch between and RGP. When we talk about, of course, it goes for 1 year, but we have to watch the quality of the lens, the deposits over the lenses. If it is a lot, then we have to change the lenses in right timely manner.
Thank you, Mr. Ram. Thank you for everyone. So just hand over to the host now.
Thank you so much.
Thank you.
Thank you, Mr. Sharath, and all the panelists for this wonderful discussion. Now, I'd like to request Mr. Sharath again to speak on behalf of Ion Care, our exclusive sponsor for this event. Over to you, Mr. Sharath.
Okay. Can you see my screen?
Yes, sir.
Okay. Hi, good evening all. You can see my screen?
Yeah.
Okay, sorry for the interrupt. Okay, so Eye Care, what is the company our team products and the service of ophthalmic equipment, contact lenses, implantable fake contact lenses, IPCL and vision therapy, low vision and the medical surgical instruments based in Dubai. UAE started in 2017. Heineken provides all kind of a specialty contact lenses, including implantable fake contact lenses, all orthoptic and the vision therapy instruments, including home therapy, prosthetic eye, and all kind of low vision aids, including the surgical equipment. So this is our team. Rahul Raghav is a managing director of the company. Sharat Raj, regional sales manager of ophthalmology. Pankaj Mishra is an optometrist and the product specialist. And Dr. Neha Nazir is an administration officer. So what is the products we are carrying with the specialty lenses, prosthetic eyes, vision therapy kits, IOL and IPCL and surgical instruments. So as a specialty lenses, we are covering keratoconus and myopia control contact lenses. So my first slide goes with the keratoconus and whatever we have. As usual, we have a air cone lenses, which is RGP corneal lenses. Then hybrid, is a silicon hydrogel lenses, and the AKS is the scleral lenses. So these are all the cases of how you choose and what in the case what type of lenses you choose depend on the topography or the op-scan reports. So you have an option with the soft or RGP options for the normal corneas, and we have a keratoconus patient for the RGP and hybrid options, then RGP, hybrid and the scleral options, and the hybrid and scleral options availability. So our first lens is air cone RGP lenses, where the parameters available and the material is optimum extreme from DK over to 211, and different colors available, blue, green, and gray tints you can make. And also you can order with the plasma or the hydro PEG treatments. Diameter linked to the base curve. So here the basic concept, when the diameter base curve of the lens will increase, the diameter of the lens also becomes more bigger, and when the lenses having a base curve is lesser, then the diameter of the lenses will be smaller. And base curve availability from the least is 4.8 up to 8.5 with the 0.05 steps. Even you can order with the 4.85 and 5.55 in the steps. And the power, we can with the RGP lenses we can reach up to plus 40 to minus 40 power with the toric and multifocal options also available. Even you can order with the D and N design lenses also. Specification, you can do the edge lift option, toric and asymmetric design, front toric and the back toric design as well. So modality, the lenses can wear up to 2 years on the daily wear, but usually the patients are changing the lenses between 18 to 20 months due to the vision clarity issues and all. Then the delivery and the warranty. So we deliver the lenses within 3 weeks, and the warranty period is 3 months for the lenses. So in the hybrid lenses, the parameters as below. We have a soft cut and the RGP center. In the soft cut, we have 2 diameters available. 14.9 is a normal in the trial sets, and you can customize the lenses diameter from varies from 14, 14.5, and 15.5. This is for the keratoconus patients. The material is silicon at 50% DK. And there is a 4 skirt available, so you can make the edge lift from 0 to 1 and +1 and 0 to -1 in the 0.5 steps. And in the RGP center, we have 2 options availability. For the keratoconus patient, we have the diameter of 8.5 in the center. For the non-keratoconic patient with the high metro, high estimation patient, we have a 10 diameter of the RGP zone. So material is DK 100. Then center thickness is 0.2, which is 200 microns, and base curve start from 4.4 up to 10 mm. And back toric surface you can order, and also power range cover from +40 to -40, all the cylinder and even the multifocal options available with the D and N design. Then our next option is air cone scleral. So lens parameter is high DK around 125 or even 211 with the hydra PEG coating. SAG start from 3,700 microns to the 600 microns, 5,600 microns. In the 100 microns availability, even you can customize up to 50 microns each. And we have a total 20 SAGs available. Even if the patient is crossing most deep corneas, even we are ordered around 5,800 microns also with the edge lift options. Diameter, we can customize the diameter from 14.5 to 17.5 with the 0.5 steps. Center thickness is 200 microns, which is 0.20 mm. Geometry spheric, toric, and asymmetric and microvolt options are available. Power range is +40 to -40 up to -6 cylinder. Model is 2 years vary. Delivery and the warranty 3 weeks is the delivery time and the 6 months warranty period for the scleral lenses. As a orthokeratology, we have in the special contact lenses is orthokeratology. The material is Optimextra with the DK/BF 211 color, and for the right and left, we order it like orange and blue. And diameter is 10.5. Even you can customize the diameter from 9.5 to 12 mm with the 0.5 steps. Base curve start from 6.5 to 10.5 with the 0.20 steps. Power range availability up to -750 spherical up to 175 cylinder. Model it is 2 years of wearing. Delivery and the warranty period 3 weeks delivery time and the 3 months warranty period. Then this is the latest lenses, specialty lenses for the myopia control, which is the soft lenses. This is the availability in the soft lenses. First time in UAE, we have a soft lenses for the myopia control here. Specification is radius, so 7.8 to 9.2. You can customize in 0.10 steps. Diameter start from 14 up to 14.5. So 14 is for the monofocal correction, and the toric correction is a 14.5 diameter. Straighten the compensative power myopia up to -20 power you can correct, and the cylinder you can go up to -6 cylinder. And astigmatism from the axis you can cover up to 0 to 180 degree in 5 degree steps. And the modality is these lenses are for 3 months only. So the next section is vision therapy kit. So we are also supplying vision therapy kit for the pediatric cases. So which is from the Bernal group. We are having all the vision therapy kits as you can see here. Then we are doing the customized prosthetic eye. So whenever the patient is there, we are going to the clinics and taking the measurement for the prosthetic eye. Then we are customizing the lenses. Then other products availability, prism kits and prism bars, Fresnel prisms, prosthetic contact lenses and therapeutic bandage contact lenses. Then the final one, we have ophthalmic surgical instruments like scissors, forceps, speculum, needles holders, and catheter surgery procedures, the instruments. And we have availability in the stainless steel and the titanium as well. And the other section we have is implantable phakic contact lenses. So we are the only lenses which is covering monofocal, toric monofocal, presbyopia and presbyopic toric availability. So the power range covers from -1 to -30 and +1 to +15. And the cylinder we are covering up to +10 diopter. And the addition we are covering up to +4. And overall length of the lens we can customize from 11 to 14 mm in 0.25 steps, and optic zone with the standard is 6.6, but you can customize up to 7.5. And the second is EDOF lenses, which is magnificent IOL, which is the high depth perception lens, which covers the distance and intermediate distance lenses. So magnificent lenses are precise cost model, hydrophobic MICL manufactured by the synthetic cast modeling procedure with the ultra high depth focus. So this is mainly customized for the patient who is aged or the young patient or housewives, where they need the correction for the distance and intermediate, not their preference not more into the near. So these lenses are high depth perception focus lenses, which can be used as IOL for the patients. So this is our details. So if you any inquiries, anything, you can contact below. This is my contact detail and the email ID. Thank you.
Thank you, Sharath, for moderating. Thanks to INCAP. Now we have come to our fifth session, intraocular lenses and implantable polymer lenses. The real beginning of usable IOL technology occurred during the World War II. Harold Ridley was the one who cared for the pilots who encountered the plane crashes. During that time, he observed that small pieces of PMMA material from the crashed planes that penetrated the eye during the crash did not cause any inflammatory reaction, which led to the invention of IOL materials. This session is supposed to be moderated by Mr. Muhammad Suhail. Unfortunately, he is not well. So our Tapashvi is going to moderate the session. She is our core committee member. Over to you, Ms. Tapashvi.
Good evening once again, and thank you. So let me introduce our next speaker is Dr. Miguel. Dr. Miguel is a senior consultant ophthalmologist and surgeon specialized in cornea, cataract, and refractive surgery. He is currently practicing as a chief of cornea and refractive surgery services at Moorfields Hospital, Dubai. His talk for the session will be diffractive and EDOF IOL indications. Please welcome Dr. Miguel. Over to you, Dr. Miguel.
Good evening, ladies and gentlemen, dear colleagues. It is a great pleasure and an honor to be invited by the organizing committee of this webinar, OPTOVERSE3 Universe of Vision, as we celebrate the World Optometry Day. The topic I am going to talk about is the presbyopia treatment approach through what we call premium IOLs. I know there are other options, but some patients with or without cataract want to consider a more definitive solution for his presbyopia. Cataract surgery can be just a restoring vision procedure, but with the availability of these special IOLs, can even be a more ambitious procedure with the objective of getting independence of the glasses. A recent survey from CRST magazine showed an increasing number of patients choosing premium IOLs after a lens replacement procedure, especially in early ages. And the trend is expected to continue in the next future. The first kind of multifocal IOL I'm going to speak about are the diffractive IOLs. They were launched around 2004-2005 with the bifocal technology, and a few years afterwards, the trifocal models were available in the market. These are currently the standard in this category. The diffractive lens have a thin structure of rings in the surface. These rings have a tooth-like profile, and depending on the height and the leaning of the ring, they can provide near image at some designed distances. There are many options of this kind of IOL available. It is difficult to compare all of them, so surgeons try to use those IOLs that are giving them acceptable results. I am pointing out in yellow arrows the models I have more experience. The great advantage of the diffractive IOLs is the glasses independence. They provide excellent vision in intermediate and near distances, and this is supported with the feedback received from the patients about the performance in different activities with very low level of difficulty reported. You can see here, very great or great difficulty. They score very low in the different activities asked. But the main con of these IOLs are the photic phenomena. Haloed glare or starbursts are frequent. Although a small percentage are severe, this is the main side effect to be exposed when we are doing the preparative assessment. These photic phenomena are usually mild, but they can be troublesome or even disabling in a small percentage that ranges from 5 to 20% in different studies presented. They can be seen in all models. Honestly, I cannot tell this lens is better, this lens is worse. All of them perform this, and the patients, most of them they see at the beginning of the postoperative, most of them remove these halos in a kind of neural adaptation, but in my experience, when they remain more than 6 months, are difficult to go. My advice then is to avoid these IOLs in patients that drive frequently at night or for long distances. One option to minimize the dysphotopsia is to implant the diffractive IOL in the non-dominant eye and the monofocal IOL in the dominant eye. This combination we did long time ago. But in the last years, a different kind of IOL has appeared that can also be helpful to provide acceptable near vision without having so much photic phenomena. These are the EDOF IOLs, that stands for extended depth of focus. In a similar way than the diffractive IOLs, the EDOF IOLs available are quite a lot. The market is really full of them. I am providing in yellow arrows the lenses which I have more experience and I am more satisfied. You can see the different near additions that any one of these lenses have. The EDOF IOL creates an extended area of focus due to a kind of small hump in the center of the optic area in the back part of the lens. This creates a single elongated focal area instead of a point to enhance the range of vision or depth of focus. We can compare the EDOF IOL with a monofocal IOL, and we can see that the monofocal IOL decreases the vision performance as we measure it in the progressive near distance, while the EDOF IOL keeps an acceptable near vision around 1.5, 2 or 2.5 diopters of near vision. These are graphics coming from two different models. The pupil is also important in EDOF IOLs with decreased performance in less than 2 mm diameter. The different models of EDOF IOLs provide different near addition from 1.5 to 2.5 in the most implanted models. With EDOF IOLs, we are giving up the excellent near performance of the diffractive IOLs in also intermediate and near vision, but the condition of these lenses is to keep an acceptable near and intermediate, mainly intermediate. This vision without having the photic phenomena at night and without requiring also monovision to keep the best possible far vision. In a study that we perform in our center with one of the models of EDOF IOL that we are implanting, we can see that around 80% of the eyes performed reached N5 or N6 in near vision. And from 31 patients assessed, we found that only 5 were required to prescribe glasses. It means 84% of glasses independence, which is quite promising. The patients that require glasses, all of them were previously cataract patients, maybe because of they are older patients. And one case of refractive lens exchange that required glasses because he reads small printings books occasionally. Once I have introduced the kind of pseudophakic IOLs that we use to treat presbyopia, I would like to point out some tips for success with these patients. Number one is to perform a perfect surgery. Then we have to treat or manage the astigmatism if present. Astigmatism decreases the performance of these IOLs quite a lot, and it's surprising how much can a patient improve when even 0.75 diopters of residual astigmatism is removed. Unfortunately, these patients may require more frequently laser enhancements after the implantation. It is also key to have a very good biometer in order to have the most accurate IOL power calculations. And finally, the patient must be very conscious of the real result we can provide. These patients allow very narrow margin of error and are a frequent source of dissatisfaction. We have to learn to manage these cases, even if the first results are not satisfactory, trying to improve all the optical conditions in order that improve the performance of the lenses. This is due to the perception of the result, because it depends on the patient's subjectivity. Different lifestyles, expectations, preoperative performance, or motivation lead to different levels of satisfaction after the surgery. Night drivers are bad candidates for diffractive IOLs. At the same time, strong readers or precision activities perform better with diffractive IOLs. Computer work is good with both of them. Usually the intermediate distances is good and they don't require glasses. Patients with occasional use of glasses before the surgery are bad candidates and they are frequently disappointed. Let's say that the thicker the glass or the more dependence of the glass they had before, the better the result. perfectionist patients are bad candidates for everything, I think, even for implanting progressive glasses, as they are difficult to satisfy. We have to point out that the main goal is to avoid or at least reduce the use of glasses, because in some cases, glasses can be possible to be required. It is important to assess a proper binocularity, avoid amblyoptic patients, or at least warn them about the possible lower performance. Check the pupil size. Better if we do these implants in cataract patients with good retinal and corneal conditions. And also, in my experience, hypermetropic patients perform better than myopic patients, especially those myopic patients that are in the range of -2 to -4, as they have a fantastic near vision, and any lens that we can provide will give so great near vision. They should be conscious of this. We must avoid low motivated patients. My first questions to all of them is, are you happy with your glasses or contact lenses? And I expect to hear a clear, no, I'm not happy. Doubtful patients are not worthwhile to convince. It is also important avoid patients with psychological or psychiatric problems. We can do surgery on them, but in this case, only if they are well controlled, and I would like to have a positive report from his therapist. Engineers are definitely bad candidates. In general, they are quite perfectionist, and they think in the side effects, and we know all that surgery is not like maths. We have to expect refractive errors or surprise. The ideal patient is an easygoing patient with advanced cataract and significant preoperative refractive error. So in front of a cataract patient or a refractive lens exchange patient, and in order to advise the best IOL for him, I should advise to start with one question. Would you mind to use reading glasses after the surgery? And if he says no, I would recommend a monofocal IOL. If he says yes, he minds, he would like not to use glasses, then we have to think about which kind of lens is better of the premium IOL is better for him. If he's a frequent night driver, is my second question, then I will, if it's a frequent night driver, I would advise to use an EDOF IOL, advising this lens, but warning that it's possible to require certain glasses in certain activities, as the near performance is not as good as the diffractive. If the patient doesn't drive at night, or he doesn't mind about night driving, then we can advise a diffractive IOL. Thank you very much to all the audience for your kind attention. I wish my speech have helped many of you in increase the knowledge about this kind of intraocular lenses, and I thank once more the organizers of the webinar for the invitation to participate. And I will be very happy to reply the questions that you would like to send. Thank you very much.
Thank you so much, Dr. Miguel, for the insights. Let's move on to our next speaker, Dr. Martha. Dr. Martha is a senior consultant ophthalmologist and surgeon from Quirin Salud Hospital, Dubai. Before moving to Dubai, she was a senior cornea and ocular surface consultant at Quirin Salud Hospital, Barcelona. She is one of the senior surgeons in the region. She would be talking on the topic IPCL phakic lenses after keratoplasty. Please join me to welcome Dr. Martha. Over to you.
Okay, do you see me?
Yes, we do.
Okay, I knew we will have problems with the sound, so I sent a video. Can you please run my video? Good evening. I'm Dr. Marta Calatayud. I work at Quirin Salud Spanish Medical Care as a cornea consultant, and I want to thank you for your invitation tonight to share with you my experience with IPCL phakic lenses for the treatment of refractive error after keratoplasty. You know, after keratoplasty, the refractive results can be really disappointing for the patient. The main problem is astigmatism, which can come from the donor, the host, or the surgical technique. But if it produces a bad visual outcome, it can be perceived as a failure by the patient, even if the graft is clear. So we should use as much tools as we have to correct this astigmatism, starting from spectacles or contact lenses, suture adjustment. Astigmatic keratotomy and compression sutures reduce the astigmatism, but the predictability is not very good in these patients. Laser refractive techniques demonstrated good results, but an increase in complications, especially related to the corneal endothelium. So it's not recommended, and repeat keratoplasty is not an option for me. For me, the best option to correct astigmatism after keratoplasty or high sphere, myopia or hyperopia, is implanting a phakic toric IOL. And this doesn't mean the other options are not good, but I think the ophthalmologist does not finish the job until the patient achieves the best corrected visual acuity. And if this visual acuity can be achieved without glasses, it would be perfect. So phakic means the crystalline lens remains at its physiological place, and then accommodation is preserved, which is an advantage. But there are important concerns regarding safety. Corneal endothelium, lens, and angle can be damaged during the implantation procedure. So we have to take into account that we may have complications, same as when we are implanting these lenses in normal eyes to correct myopia, hyperopia, or astigmatism. We can have a cataract, we can have endothelial cell damage, we can have glaucoma or high pressure, we can have halos at night, reverse orientation, which is a complication that usually happens during the learning curve, and other rare complications. But for me, the most important complication a surgeon can find when you already pass the learning curve is oversizing or high bolts. This happens when the calculation is not good or when the patient has extreme measurements in wide to wide or anterior chamber. So what do we know? We know the phakic IOL are safe and effective for refractive defects in normal corneas, but after keratoplasty, there is not too much information. After DALK, there are only 47 relevant papers published with no conclusions at all, small sample series, and retrospective or reviews, and many of them with ICL or artiflex. After penetrating keratoplasty, there is no series published. The only thing I found was complications. They are 8% more frequent related to the endothelium, and we are manipulating the lens inside the anterior chamber. So every surgery means that we are going to lose some endothelial cells with the procedure. If the cells are diminished, then we can have a problem. The difference between DALK and penetrating keratoplasty is the status of the endothelium after 6 months. You know, when you perform a penetrating keratoplasty, after 1 year, you check the endothelial cell count and it's decreasing. The cells become bigger and the polymagnetism is high. But in DALK, after 6 months, you check the endothelium and it's resembling a normal endothelium. So it means we can use an IOL in an eye after DALK with the same dangers as we use in a normal eye. We have an example here. You can see this patient before keratoplasty had counting fingers vision. After keratoplasty, the vision was 0.2, but with minus 650 astigmatism. And this astigmatism is regular, and we tried contact lenses, and the vision was very good, but the patient was not tolerant to contact lenses. He was very uncomfortable. So the only option would be implanted phakic IOL. Why did I implant my first IPCL after keratoplasty? Well, I was in Barcelona. I had a 30-year-old woman with keratoconus and left eye lamellar keratoplasty 5 years ago. His vision in right eye was 1.0, left eye 0.05, but with correction 0.9. The only problem is astigmatism, minus 10. endothelial cells are normal, anterior chamber is wide enough, and contact lens intolerant as well. So as she had good visual acuity, we decided to implant phakic IOL. I have no experience at all with Artiflex or iCryl. There are 4 models in the market right now, but I have a wide experience in implanting ICL in people with myopia, hyperopia, or astigmatism with normal corneas. So we have 2 options, ICL or IPCL. The problem here is that ICL only corrects up to -6 diopters of astigmatism, and IPCL is the perfect solution because it can correct up to -10, even customizable for higher cylinder. Another advantage of IPCL is the optic profile. It's called spring optic because it's flexible and it can contract in several conditions. One of these conditions is the process of meiosis, mydriasis, that happens into the anterior chamber in patients wearing this kind of lenses. And the second one, which is more important for me, is that in cases of oversizing, IPCL can compensate up to 0.5 millimeters error in the measurement of the white to white. So if there is difference in 0.5 millimeters measurement of white to white, it can increase the bolt 500 microns. In that cases, this spring optic would protect the patient to a certain extent and would avoid for us to remove the lens to implant another one. Because implanting this type of lenses is a risky surgery in these patients with low endothelial cell count, even if you are an experienced surgeon. So the less surgeries we perform, the better for the patient. Then if we have oversizing, which is relatively frequent in these patients, there would be no need to remove the lens because as the bolt increases, the angles close and there is higher risk of glaucoma for the patient or high pressure. And removing these lenses is also a difficult procedure, even if you are used to that. We have our first patient. It's a male, 35 years old. He came with intacs in the right eye, as per him, and penetrating keratoplasty left eye. So according to him, there was no ICL implantation in the right eye, but we saw a really huge iridectomy in the upper iris, and we could even see the limit of the ICL implanted there. But there was no central port in this lens. So probably this lens was implanted before 2012. And the first toric ICLs were implanted after 2018. So it means they corrected only the sphere but not the astigmatism. Vision was very good in both eyes with correction, but he did not tolerate contact lenses, even glasses, and he wanted another solution for him. So we decided to remove ICL in right eye, implant a new one, IPCL toric, in the right eye, and then implant in the left eye. So in the right eye we remove ICL, but our implantation procedure showed us that IPCL was upside down. And you can see it because the angles are closed and the bolt is very, very small, 100 something microns. So in this case, you have to remove the lens. But this is a tricky procedure because these lenses have many holes to avoid glaucoma, but when you cover the holes with viscoelastic to remove the lens, then the pressure suddenly increases, and as the angles are closed, we have a problem. So as you can see here, this is the situation of the angles before explantation. Down is after, and we had to wait 24 hours because we had high pressure during the surgery. Final uncorrected vision was right eye 0.8, left eye 0.72, and both eyes vision 0.94. The patient was very happy with his vision, and there was no endothelial cell damage and no cataract and no high pressure, which is more important. I'm going to show you my numbers. I treated 13 keratoconus eyes, 6 of them after keratoplasty, either bulk or penetrating, 3 of them after intact implantation, and 4 in stable keratoconus that could be treated perfectly with only phakic implantable contact lens. In these cases, the main problem you will find, as you will see in the video, is visualization of the toric mark of the lens. Because if you have a scar in your cornea, the same you can have after keratoplasty, or you have intact, it's difficult to focus in the marks and get the lens correctly aligned. Apart from that, there is no other problem or difference between these eyes and the normal eyes. As a complication, we only face this upside down lens, which we replace the next day, and we have a persistent epithelial erosion in a patient with map dot fingerprint corneal dystrophy. So the results are post-PK or dark patients, all with a cylinder more than 6 diopters, improvement in 2 lines compared with previous best-corrected visual acuity with spectacles. We reach same best-corrected visual acuity with contact lenses. We also compare contact lenses vision before the surgery and unaided vision after the surgery, and we reached the same vision in all the patients, and the ball was 0.75 to 1.0 central corneal thickness, which is good. In patients after intact, we found an improvement in 3 lines compared with previous best-corrected visual acuity with spectacles. We reached the same vision as before with contact lenses, and bold was 1.0 corneal thickness. And in people with stable keratoconus, we reached 20/20 vision in both eyes. So can we draw any conclusion from this series? No. No, because there is limited information about results in post-keratoplasty patients. We cannot compare. And my series is very small. So, as you know, IPCL was designed as an affordable alternative to ICL, especially in developing countries. But at this moment, there are many studies comparing both phakic IOLs, and the results say in terms of safety and efficacy, they are equivalent. The quality-price ratio is very good. So for me, it's an effective solution in cases of extreme myopia and or astigmatism. But if you are going to start using these lenses, switch from ICL, why not, to IPCL in patients with myopia, hyperopia, or astigmatism, because the cases I presented to you today require an experienced surgeon to avoid harming the eye during implantation. I think that's all my presentation. If you have any question, you can send me an email. Thanks again for your kind invitation and congratulations.
Thank you so much, Dr. Martha, for your wonderful insights and having patience. We will move on to our next speaker, optometrist Alex Julian. He's currently heading the Department of Optometry at Barraquer Eye Hospital, Dubai. Prior moving to Dubai, he was practicing as a senior optometrist in Barraquer Eye Hospital, Spain. He has a special interest in IOL calculations and biometry. His talk of the session will be on biometric surprises. Please join me to welcome optometrist Alex Julian. Over to you, Mr. Alex.
Okay, can you see my slides?
Yes.
Okay, perfect. So good evening, everyone. First of all, I want to thank Raúl and Juncker for the invitation and OPTOVERSE for organizing this event. Today I'm going to talk about how to avoid biometric surprises and post-refractive IOL calculation. Okay. Well, this is the simple index I'm going to follow. I will start talking about how important is an accurate biometry and keratometry and how to achieve this high accuracy. And finally, I will explain which is the most appropriate IOL calculation formula for virgin and difficult eyes. Okay, first of all, For an accurate biometry, we have to use an optical biometer. Nowadays, if we want to achieve high accuracy in our IOL calculations, I think it's a must. It has been proved that in terms of resolution, accuracy, and repeatability, optical biometry is much better than ultrasound. However, of course, we cannot completely delete a scan from our lives, but in my opinion, it will only be necessary when optical biometry is not reliable or it's not possible to get the measurement for any reason. For example, the most common one, because we are in front of a very dense cataract. Penetration of ultrasound is higher than any kind of optical biometer. Then in cases, in these cases, we have to use a scan, but I would recommend you to introduce the axial length, anterior chamber depth, and lens thickness obtained with the ultrasound in the optical biometer. Why? Because usually they have more advanced softwares for IOL calculation with more formulas available. And if it's the device that we are using by default, it means that we will have the IOLs we want with the constants optimized, etc. So when we are doing this, if we are using contact technique for ultrasound, we have to add 0.2 millimeters to the axial length and anterior chamber depth when we introduce these parameters in the optical biometer, as Dr. Shamas mentioned in this study that I am putting here. Of course, if we are using immersion technique, we don't have to add anything when introducing these values in the optical biometer, because the 0.2 millimeters difference is only due to the compression applied in the contact technique, not related to the fact that ultrasound is measuring antilinear limiting membrane and optical antilretinal pigment epithelium. This difference is compensated by the software in the optical biometer, so theoretically, optical biometry and immersion scan should be exactly the same. Okay, so having an accurate measurement of axial length is always important, but as we can see in this table, it's more crucial when we have short eyes. For a 0.1 millimeter of error in the measurement of axial length, this will result in an error of 0.14 diopters in the spectacle plane if the axial length is around 30 millimeters. But the more we decrease the axial length, the higher the error will be. And for example, for a 21 millimeters eye, this will result in an error of 0.35 diopters. Therefore, in conclusion, pay special attention when you are dealing with short eyes. More tips. If biometer is using OCT technology, we have to check the OCT image, especially in cases where we can expect that the measurement could not be reliable. And when we see this image, we have to check that these green lines are in the correct position. Here, anterior surface of the cornea, posterior surface of the cornea, anterior surface of the crystalline, posterior surface of the crystalline, and retina. It's more difficult to see the retina here, but the other structures are very clear. And a very common example is when we have to perform a phakic IOL removal plus cataract surgery. It's very common to get this error. As you can see in this image, biometer is wrongly taking as anterior surface of the crystalline, the anterior surface of the phakic IOL. The correct position would be this one. But the software is taking the wrong anterior surface of the cornea. Therefore, this anterior chamber depth and lens thickness will be also wrong. In fact, ACD should be longer and lens thickness should be shorter. So what we'll do in these cases, we have three options. Introduce these parameters from another device. This is the best one if we have the possibility. For example, with any anterior segment OCT, you can measure manually the anterior chamber depth. A second option is use values of contralateral eye if we know that both eyes are similar. And for example, in the contralateral eye, there is no ICL or IPCL. Or last option, if we don't have any other device to measure it and we cannot use anterior chamber depth or contralateral eye, we can simply use formulas that do not take in account these parameters to predict ELP. ELP means effective lens position, and it's the distance from the anterior surface of the cornea to the center of the IOL. Formulas that doesn't take in account these parameters are, for example, SRKT, Hofer Q, and Holaday 1. Take in account that if we have to measure the anterior chamber depth manually, For IOL calculation, this is from anterior surface of the cornea until anterior surface of the crystalline, not from the endothelium of the cornea. And this is because the principal plane of the cornea is in the epithelium plane. It's here. And finally, last parameter we should check before going into the keratometry is the white to white. If we are using formulas that take in account white to white to calculate the effective lens position of the IOL, of course, we have to check that it's not happening something like what we see in this picture. Clearly, the detection of the limbus is not correct. It should be like that. Then here we have the same options that I mentioned before. Introduce this parameter from another device, use value of contralateral eye, or use formulas that don't take in account this parameter to predict effective lens position. Well, now we have finished with biometry, let's approach the keratometry. For having an accurate keratometry, it's recommended to do 3 measurements to check the repeatability, and then take the median of these 3 measurements. The median, I mean the value in the middle. Then, apart from the keratometry of the optical biometer, it's also recommended to do 1 topography to compare. And finally, if we are using IOL Master, it's slightly better to use total keratometry instead of simulated keratometry, as they have demonstrated in these studies that I am mentioning here. And here, as I did with the biometry, I want to show you the importance of an accurate keratometry measurement. Here, for 1 diopter of error in the keratometry, the error will be more or less the same regardless the axial length of the eye. So 1 diopter of error measuring the keratometry will result in approximately 1 diopter of error in the spectacle plane after implanting the IOL. And to finish with the keratometry, regarding the astigmatism, it has been demonstrated in several studies that it's better to consider the total astigmatism instead of the anterior one, because the effect of posterior surface of the cornea is significant. It has been seen that the magnitude of posterior corneal astigmatism is on average minus 0.3 diopters, and in the 87% of the cases, it is against the rule. This will mean that if we are not considering it and we are only measuring anterior astigmatism, if this one is with the rule, we will overestimate the total astigmatism, and if this one is against the rule, we will underestimate the total one, because we need to add the posterior astigmatism that is also against the rule. Okay, and finally, I will focus on the selection of the IOL calculation formula in some of the most common situations. In virgin eyes, I mean eyes with no previous surgery or no disease that can affect the calculation of the IOL. So based on this recent review published last year, where 51 studies were analyzed, they concluded that for eyes with a normal axial length, we will consider normal from 22 to 26 millimeters. Barrett Universal 2 is the formula with the lowest prediction error and the best one for this kind of cases. All of you know Barrett formula. It's a formula based on modern theoretical optics that performs very well for all range of axial length. And it's why probably it's the most used formula nowadays. Then for eyes shorter than 22 millimeters, formulas Kane and EVO 2.0 were the ones that performed better. And for eyes longer than 26, Kane was again the best one. These two are last generation formulas. Kane is combining theoretical optics plus artificial intelligence, and EVO means emmetropic verifying opticals, and it's a thick lens formula based on the theory of emmetropization. My recommendation is to use 2 formulas to compare. One of them can always be Barrett for any axial length, plus Kane or EVO if the eye is shorter than 22, and plus Kane if it's longer than 26. Okay, then which formula we should use in difficult eyes? In post-refractive surgery IOL calculation, we have different options depending on the surgery performed. For example, in patients with previous radial keratectomy, Barrett through K history and Barrett through K no history in that order are the best. History or no history means if we are using data previous of the refractive surgery or not. And then for PRK or LASIK, Best formulas are Barrett Truquet no history and ray tracing MS39 with adjusted axial length. This last one is a ray tracing formula included in the software of MS39 OCT topographer that seems to perform very, very well if we select the option of adjusting axial length. Apart from post-refractive surgery, there are other conditions that we can consider difficult.
Sorry to interrupt. 5 minutes more to go.
Okay.
Mr.
Perfect.
Alex, yeah, thank you.
Apart from refractive surgery, there are other conditions that we can say that are difficulties like keratoconus. Cane keratoconus seems to be the best one for this kind of cases, and it's a variant of the cane formula mentioned before. Depending on the keratometry, here we have to choose one target or another. If the keratometry is between 48 and 53 diopters, the target should be minus 0.5. If keratometry is between 53 and 59, target minus 1, and more keratometry higher than 59 diopters, target should be between minus 1.5 to minus 2.5. Obviously, this is to avoid ending up with an hyperopia. And then finally, the last and very common case is if we have a phakic subluxated IOL or IOL exchange. In that cases, we don't have crystalline. Therefore, we don't have anterior chamber depth and lens thickness. So very careful using formulas that depend exclusively on that parameters like Higgs. We cannot use Higgs in that kind of cases at all. I would recommend you to use Barrett Universal 2 plus SRKT or Hofer Q depending on the axial length, SRKT for long eyes, Hofer Q short eyes. And then for Barrett, it's recommended to delete anterior chamber depth and lens thickness or to use the previous ones if existing. Well, apart from Barrett, Cane, and EVO mentioned before, there are many other last generation formulas that also perform very well. And then in complicated cases where we are not sure about which power to choose, this is a very useful tool, the tool that I am showing you in this slide. This is a multi-formula IOL calculator from ESCRS. You put the parameters one single time and it makes the IOL calculation with all these formulas mentioned above at the same time. Barrett, Cook K6, EVO, Hill RBF, Hofer QST, Cane, and Pell DGS. If you want to compare the calculations of some of the most important last generation formulas, this really saves a lot of time. And then finally, to finish with the presentation, I would like to say that although we are doing a very accurate biometry, a very accurate keratometry, and choosing the best formula in the world, all of this is useless if the constant of the IOL is not correct. Therefore, we have to use optimized constants, and the best place to find them is this website, iolcon.org. So let me repeat this again. It's very, very important to review the constants of the IOLs we are using from time to time, because we cannot forget that if this is wrong, all our previous work will be useless. Thank you.
Thank you so much, Mr. Alex, for the wonderful session. Before moving to the next session, there will be some of the questions which will be seen on the screen, requesting you all to kindly put up the answers there. Okay, thank you, everyone. Over to you, Mr. Host.
That was very informative discussion, Mr. Tapushi. Thanks to all the panelists for your gracious contributions. Let's move forward to the sixth session of today's evening, handling the special cases. We all know several new diseases are popping out each day, which can lead to ocular complications secondary to systemic issues. COVID is very famous among them. We should also not forget the necessity for investigation in neurological cases and postpartum eye health. Let's hear from our experts how to handle the special cases. Now we call upon Ms. Shahida Shamsuddin, working as senior optometrist in Sheikh Khalifa Medical City, Abu Dhabi, to moderate this session. Handling the special ophthalmic cases, she is also a core committee member of UIOF. Over to Ms. Shahida.
Thank you. Now,
Good evening and a very happy World Optometry Day to all. Now I would like to invite Dr. Madhav Rao, Senior Consultant and Vitreoretinal Surgeon from Burjil Hospital, Abu Dhabi. He had his fellowship in retina from India's prestigious eye hospital and research foundation in Shankara Netralaya in India. He is also a member of American Academy of Ophthalmology and has received numerous awards. He will be talking about COVID-related eye complications. Over to you, Dr. Madhav Rao.
Good evening. Ramadan Kareem to all. At the outset, I would like to thank Swarna Kamal Naya and yourself, Ms. Shaida, for giving me an opportunity to speak. Well, I was asked to speak on COVID-related eye complications. You know that I'm a retinal surgeon. So I would probably touch upon more on the retinal complications. So let's move on to the COVID-related complications. As we all know, the coronavirus caused COVID, which started in probably 2019 and the beginning of 2020. And ophthalmologists worldwide started reporting many symptoms, visual symptoms during their illnesses. One of the first whistleblower of COVID disease was Li Liang. He's an ophthalmologist, glaucoma surgeon working in Wuhan, who actually, the first time he gave a tweet on the coronavirus epidemic and its origination. Unfortunately, we lost him during the first year itself on February 7th, after seriously conflicting, with pneumonia. Well, is it possible to have a vision-related changes triggered by COVID-19? Yes, we do see a lot of problems with the COVID-related, COVID patients. Many vision problems don't affect the visual acuity, but patients' eyes may not converge or diverge correctly. They might even struggle with certain types of eye movements, experience reduced peripheral visions, and not see clearly when they are moving. The list of the possible problems with the eyes is quite long. So more likely to experience the symptoms, those eye problems results in a headache, dizziness, nausea, difficulty concentrating, fatigue, and more. Some patients are not aware of how the visual system can cause these symptoms, and they never think to seek help from the vision specialist or the ophthalmologist. A second misconception is that the vision problems caused by COVID-19 are rare. It's not the case, and it's all supported by the clinical studies. And in the past 2 years, the ocular manifestation in patients with COVID shows that there could be a range of 2 to 32% affection, with the most results hovering around 10%. So it can, affect, probably they can come with conjunctivitis, the red eyes, eye soreness, blurring of vision, tunnel vision, diplopia, vision loss. The list is pretty much long. Yeah, it can affect anything, especially the posterior segment. It can come with arterial occlusions, vein occlusions, hemorrhages, and blood clots. And these could be affected in COVID-19 because of the disruption of autonomic nervous system or a neurovascular coupling dysfunction, direct impact on the brain function related to vision or a vestibular issues, or there could be some pre-existing visual dysfunctions. There could be a side effects of medications, blood clots, as we have seen in many cases. I'm going to present some of them, or a direct viral attack on the eyes, and also in patients on ventilators. So what are the tips? These are the general tips recommended for the visual symptoms at home. You follow all these for the visual display unit syndromes as well. So follow the 20-20-20 rule. I will not go into the detail. Palming to relax your eyes. Make a conscious effort to blink more during the day. Be strategic with the light. Reduce the tripping hazards. Use contrasting colors. Use probably audio devices whenever it's possible. Learn some breathing exercises, yoga, and get a second opinion if need arises. And as I said in the beginning, the symptoms could be from anywhere from conjunctiva to the retina based on, so it can affect the conjunctiva, sclera, episcleras, anterior chamber. Likewise, it can affect till the retina, and it can affect adults, children, and the newborns alike. So what are the management options we have? We do a very basic investigations or a minimal investigations. Basically, you have a suspicion, you do a PCR in suspected cases. You send them either to emergency or the designated places where you do a PCR. And you treat them symptomatically with antibiotic eye drops or an ointment, non-steroidal anti-inflammatory agents, artificial tear drops and an ointment. This should suffice if it is just an anterior segment. Based on whether it is uveitis or any other, you would again treat accordingly. Now, what better to teach or to learn is to know from the cases themselves. So I have some 3 or 4 cases to show. Most of them will be related to posterior segment or the retina related. So the case number 1 is a 43-year-old gentleman came with a history of sudden decrease in vision in the left eye for 1 week. He was diabetic for 4 to 5 years, hypertensive for 3 years. He gives a history of ischemic heart disease in the last 3 years. He was COVID positive 20 days back, and his visual acuity was 20 or 1 in the right eye, counting fingers in the left eye, that too with the eccentric view. The pupils were showing a relative afferent pupillary defect in the left eye. Slit lamp showed some lenticular changes. The pressures were normal. So as we do any of the, we do a comprehensive eye evaluation, you do a dilated retinal evaluation. And if you find any of the features, probably we take them to ancillary tests. So we do a routinely, color pictures of the retina. You do IVFA if indicated. Then you do OCTs. So let's see the color pictures of the retina. This is the optos image on the upper panel. You see a optos image of the right eye showing some hemorrhages in the superior and the inferior. Whereas in the left eye, you see a large portion of the retina covered with the blood. Now, this is a subhyaloid or a pre-retinal hemorrhage, which is quite dense. That's the reason why the vision has dropped down to counting fingers and also has caused the RAPD. Now, please remember, we did the intravenous fluorescein angiogram, which typically shows a hyperfluorescein or a leakage from the neovascularization. You could see probably in the right eye, it's all in the upper quadrant, nasal and the inferior quadrant. Whereas in the left eye, it is hidden or it is masked or blocked by the pre-retinal hemorrhages, but you could still see some hemorrhages, leakages beneath the hemorrhage. Now, the question is it related to diabetes or is it related to COVID? The answer is yes, he was diabetic for 4 to 5 years, but the worsening probably would have been because of the COVID in the recent times. As he gave the history of COVID for the last 15, 20 days, this would have triggered by his COVID. Now, this is the OVCT image, which shows the right eye to be a normal foveal contour, whether the left eye you see a dense pre-retinal or a subhyaloid hemorrhage covering the macula. You don't see the macular contour itself. The OCT on the right side was pretty good superficial layers. The deep layer shows loss of capillaries, dropout of capillary network. The diagnosis, as I said, it's a dense subhyaloid pre-retinal hemorrhage and advanced PDR in both eyes. Probably it is COVID related, looking at the history. And in that period, for the last 2 years, we have seen many of the COVID patients presenting with exaggeration or absolute worsening of a diabetic retinopathy. If they had 2 years of diabetes, we generally don't see a proliferative diabetic retinopathy in 2 years. But during the COVID times, we could see those kind of changes. So how did we plan? We planned for a pan-retinal photocoagulation immediately, and followed by, we wanted to do a vitreous surgery in the left eye. So we, prior to the vitreous surgery, we planned to give them an intravitreal injection of anti-VEGF to reduce the intraocular angiogenesis, vascularity, so that it becomes easy for a vitreous surgeon to operate. So he received the first, PRP on the same day, followed by the intravitreal injection. And we went ahead and did the vitrectomy. I don't want to show the videos here. This is the post-op result with a small gas you can see. It's a gas tamponade. So nicely, the membranes are removed. You could see a fresh pan-retinal endolaser marks. The macula is stable. On a OCT, the right eye, as usual, it was good from the beginning. The left eye shows still a submacular fluid at a macular thickening and a central macular thickness of 420 microns. Now, what do you do in such cases? You proceed or continue with the anti-VEGF, still the macula comes down or becomes good. So this is the follow-up visits after the vitrectomy. He did pretty good. His vision improved to 0.7. And we also did the third injection of anti-VEGF in October of the same year. So this goes to show probably you need to be aggressive, and if you take them on, I mean, they do respond very well. The second case is about the 35-year-old gentleman. We came with a history of blurring of vision in the right eye for the last 1 week. His vision was 0.3 improving to 1. Left eye was 0.4 improving to 1. Slit lamp was unremarkable. Pressures were normal. Again, the basic investigations like the color picture, the autofluorescein. The color pictures of the right eye shows the superficial retinal hemorrhages and the dot plot hemorrhages in all the quadrant, which is again, you can see better on autofluorescein in the right eye. Now, these are spectralis images of the right eye. We did the angiogram and the OCT, and the diagnosis was straightforward. It was a CR vivo, a macular edema in the right eye. Though there was a history of COVID, we just wanted to rule out, is there any other systemic factors which are probably contributing to the retinal vein blockage? We put him on to an internist to know about all these systemic associations. Unfortunately, the gentleman came back after a couple of weeks with a drop in vision further. His vision had dropped down. Remember, his vision was 0.31 in the right eye, and now it has dropped down to counting fingers close to face. And this is how the OCT B scan looks like. There was significant loss of foveal contour with the intraretinal cyst, significant spongy macular thickening at 697 microns. So what is the diagnosis? It's a worsening of, and these are the color pictures, which definitely shows there is a worsening or a conversion of non-ischemic probably towards the ischemia. You can see accentuated retinal hemorrhages in all the quadrants. So what do you say this? Probably a conversion of non-ischemic to a ischemic central retinal vein occlusion. How do you manage them? You have to give them anti-VEGF, and it would be multiple monthly consecutive injections. So we started in the month of March, and then the results was pretty good. You could see the vision improvement to 0.2, 0.7 in the right eye. And we continued. Please remember, it might look good on a OCT, but you might have to continue with the anti-VEGF. I keep saying it to our retinal surgeons also, especially with the retinal vein occlusions. Don't stop at first injection, even when they have a good result. So this was the third injection. You can see the retinal hemorrhages are completely absorbed, whereas you could still see a cotton wool patches at the posterior pole. This was the fourth injection. Probably he skipped coming back. Couple of months later, he comes back again with a further worsening. The point was, I think he took one more vaccination also. So these were all overlapping. In fact, one COVID and the second one is the COVID vaccination. So we did an angiogram to know whether he has got a capillary dropouts further in the periphery. So this was the angiogram reports which showed that there is a significant loss of capillaries in the periphery and in the center. So we went ahead and did the PRP and continued with the injection. Now, my third case is 51-year-old, presented in May of 2021 with blurring of vision in the right eye. His pressures were, blood pressure was quite high, 165, 110. He had received first and the second dose of COVID vaccination in March and April of 2021. And then he had a COVID. So we have seen all these combinations. And his visual acuity was 0.3, 0.5 in the right eye, and the left eye was 1. The pressures were normal. As usual, we did the complete workup. You could see superficial retinal hemorrhages in the upper temporal quadrant, stretching up to the upper superior and the upper temporal. So it is a clear case of upper temporal or a superior temporal branch retinal vein occlusion in the right eye with a macular edema. Now, what could be the cause? Now, generally, when we see a STPRVO, we know that it is the second order venules which get pressed because of the hypertension. It's a straightforward diagnosis, and we put them to internist for the evaluation and the management of hypertension, whereas we go ahead and treat them with anti-VEGF. So this gentleman also had a COVID, so possibly it would have triggered. So this is how we managed him. He did pretty good. One injection, again, the foveal contour is back, but we continued injecting him. The second and the third injection, the foveal contour is maintained. The fourth injection, it is maintained very well, right? Though on our OCTA, you can see there is a dropout of, capillary, especially the deeper plexus. In the middle panel, you see a loss of capillary network in the deep plexus of fovea. This was an angiogram. And then probably we did a sectoral laser for those capillary non-perfusion areas. He developed a recurrence for which again continued with the anti-VEGF. The final answer is he did very well with the anti-VEGF. Right. And the last case is a 43-year-old female. She is a teacher by profession, visited in February of 2021. And she was complaining of blurring of vision in both eyes. She was diabetic for 14 years, hypertensive for 6 years. She had recently received second dose of COVID vaccination in February 17, and visual acuity had dropped on in both the eyes, and the rest of the anterior segment, they were showing some cells, but the pressures were normal. This is how the posterior segment was looking like. You could see a multiple pockets of subretinal fluid at the posterior pole, little hyperemic disc, both on a color pictures on a autofluorescein. This of the left eye, you could see multiple pockets of subretinal fluid at the posterior pole. So we did an angiogram and an OCT to complete the ancillary testings, which showed undulating choroid with a large subretinal fluid, with a choroidal thickening, with a significant macular thickening. This typically, I'm not sure whether you have seen such kind of OCTs. When you have a septate connecting, these are very typical of a condition called Oak-Koyanagi-Harada syndrome. Now, the question was whether this was related to our recent COVID vaccination. And we did a lot of investigations to rule out whether it is HLA related, because leakage could also be seen in the HLA related. So we did a lot of investigations, uveitis workup, and then started with the methylprednisolone, 1 gram twice daily for 3 days. And we thought there was no other incidental factors. So we said it is probably because of the COVID vaccination. So leakage because of the COVID vaccination. She responded very well initially with the IV methylprednisolone. You can see the resolution of the submacular fluid and even the submacular fluid at other places. I mean, the generalized feature was much better after the prednisolone. She was tapered on with the oral steroids. And then we put her on mycophenolate mofetil for a long-term management, because you cannot keep the oral steroids beyond, say, we didn't want to keep it. She being a diabetic for many years. So we changed it to immunosuppressives for a period of time, and she was managed very well. Her vision was maintained at 2020. So these are my cases. So please remember, COVID can affect any of these eye, from the conjunctiva to the retina, many vascular occlusions, optic nerve changes, optic neuritis, muscle paralysis. We have seen it all. Yeah. Thank you for giving me time. Thank you. If you have any questions, I'll be happy to answer.
Thank you so much, Dr. Madhav Rao, for having such a wonderful session. And it's been a great privilege for us to have you on this platform.
Okay.
Now, I would like to invite our next speaker, Ms. Jabin Jafar, Senior Optometrist from Medcare Eye Center, Dubai. She had her bachelor's degree from Allied School of Optometry in India, and she has a vast experience in neuro-ophthalmology today. Over to you, Ms. Jabin.
Can you able to see my screen? Am I audible?
Yes.
Am I audible?
Yes, please. Go on.
And my screen is visible?
Yeah. You can put the slideshow, please.
Yeah. Thank you. Thank you, Shahida. Thank you for the wonderful introduction. Thank you, Optoverse, for giving me this opportunity. My name is Jabin Mohammed Jafar. I work as an optometrist at Medcare Eye Center. I pursued my optometry at Shankar Nethralaya and vast experience in medical retina. Today, I'm going to present a topic on neurooptometry. So neurooptometry, as the name suggests, is a connection between the eye and the brain diseases. Most of the neuroophthalmological can be diagnosed with precise examinations by which we can able to detect the brain disease at the very early stage. This can save the patient life and the eyes.
So ocular symptoms can be due to ocular problem, visual problems or problems with the eye movements. So vision loss may result from problems within the optic nerve or its connection to the vision portion of the brain. So here we understand visual pathway. It's very important to understand visual pathway to identify the site of the lesion and correlation with the defect in the visual field. So vision pathway starts from the retina of each eye, separately. So temporal portion of the vision falls on the nasal retina, whereas the nasal portion of the vision falls on the temporal retina. Both the nerves passes through the optic nerve and crosses over the optic chiasm, whereas the temporal nerves only passes through the ipsilateral side of the optic tract and goes towards the same side of the lateral geniculate body, where it synapses and passes through the primary visual cortex. Whereas the nasal fiber will goes towards the optic nerve, but in optic chiasma, it crosses over and goes to the contralateral side of the LGB, optic tract and LGB, and goes synapses there to the primary visual cortex area. History is very important in case of neuro-ophthalmology because neuro-ophthalmology goes with the clinical evaluation. So, sorry. First complaint of the patient will be decrease in vision. Is very important to differential diagnose by questioning the patients properly about the vision problems, because optic neuritis, one of the most common neuro-ophthalmological condition in which inflammation of the optic nerve, vision may be gradual and painful. Whereas in ischemic optic neuropathy, it is sudden onset of vision loss, and arteritic neuropathy, it can have both bilateral involvement with a painful vision loss, whereas non-arteritic is unilateral and painless. In case of toxic optic neuropathy or compressive optic neuropathy, it goes very gradually and insidious. The patient loses his vision in several months' time. There will be visual field defect. Patient will be complaining of missing certain portion of the field of vision. Sometimes patient will have a very good visual acuity in spite of having constricted vision loss. Transient vision loss and anomalogus fugus. It's a temporary vision loss for over a period of time. So in transient vision loss, we must notice patient age and systemic illness like diabetes, hypertension, and duration of the transient vision loss is very important, because in if it is more than 60 minutes, it should be considered as emergency and patient is sent for evaluation of the brain diseases or any neurological conditions. Then we have to ask for drooping of eyelids or ptosis. It's related to neurological problem or it could be due to muscular problem. Double vision, diplopia can be binocular or monocular. Monocular is mainly due to corneal problem. It's not a neurological problem basically. So it's mainly due to corneal problems, cataracts, or any dryness problem. Binocular, it is neurological problem. So it can be due to supranuclear or neuromuscular junction problem, extraocular muscle problems. So extraocular muscles restriction can cause horizontal vertical gaze paresis or horizontal gaze paresis or vertical gaze paresis. Facial expression changes can be seen in Bell's palsy, Marcus-Guns, Parkinson's diseases. Apart from the main history, we have to check for the relevant complaints, because neurological neuro-ophthalmological cases mainly focus on brain tumors, optic neuropathies, myasthenia gravis, multiple sclerosis, and like diseases, neurological diseases like Parkinson's disease, Alzheimer's disease, etc. Brain tumors will be presenting with the hearing problem, tinnitus, tendency to walk and tiredness, difficulty in balancing, personality changes. In myasthenia, in multiple sclerosis, patients will be presenting with a fatigueness, gait problem, tingling of the muscles, vertigos. In Parkinson's disease, patients will have instability and unsteady body movements, and lack of sense of smells can be seen in meningioma, olfactory nerves, and tumors which is causing parachiasmal region disease. Trauma history is very important because traumatic optic neuropathy can be due to any brain injuries, head traumas resulting from hematoma in subdural or extradural hematomas, which can result in compression of the optic nerve. And the third nerve compression can also happen. Convulsions history should be mentioned because any type of memory loss along with the convulsions or including meningitis, encephalitis, which is causing convulsions. Babies born during the labor can have brain injuries due to and can cause convulsions in future. Headache history. Headaches can be migrainous or non-migrainous. Migrainous can associated with visual auras, vomiting, and nausea symptoms. There are worst case of headaches which can be due to aneurysms. Aneurysms or non-aneurysms. Aneurysms can be due to subarachnoid hemorrhages, and non-aneurysms can be isolated with the third nerve palsies. Patients, elderly patients who is telling about headaches, severe headaches can also have giant arteric ischemic arteries. Medical history should be noted. Diabetes patient can have diabetic papillitis, and hypertension patient, grade 4 hypertension patients can have disc edemas, and brain tumor patients, malignancy patients can have disc edemas. Tuberculosis is noted because tuberculosis medicines which is used like ethambutol for prolonged time can cause toxic optic neuropathy. Syphilis can be, syphilis patients can have optic neuritis. Viral infections can again also cause optic neuritis. Any medications history, as I said, ethambutol, which is used for tuberculosis, should be asked. Any insect bites or animal bite can lead to Lyme diseases, cat scratch fever. Optic neuritis can be caused due to over intake of alcohol or smoking or tobacco. After the clinical history, examination is very important in neurological cases. When the patient walks into the clinic, we have to notice their asymmetrical face or skull and face shapes, or any hypoplasia in the children, CNS malformations, or any facial malformations. A patient is looking very anxiety or exhausted due to stroke. Anemic patients, post-anemic patients, acute anemic patients, or hypotension patient can also cause shock-induced optic neuritis. Examination visual acuity should be recorded in both the eyes, unaided or aided, best corrected visual acuity to ensure the patient is having refractive error problem or patient is having a neurological problem. Even sometimes patient having a very good visual acuity can also have a neurological problem. So then comes our color vision test because it goes first compared to visual acuity. So check the color vision separately in each eye using pseudochromatic Ishihara test. How we'll test? We'll close one eye and ask the patient to identify the numbers written on the dots over the background with the different numbers. Proptosis examination and prominent eyeball displacements and lid displacements. Ptosis is recorded with their severity, like mild ptosis or moderate ptosis or severity of severe ptosis should be recorded. Ptosis is very crucial evaluation because it tells us whether the patient is having pure neurological problems like third nerve palsies or Horner syndrome, or is a mixture of neurological and muscular problems, like in case of myasthenia, or only muscular problems like in case of LPS function. And here comes our hero, pupillary evaluation. All we know, like pupillary evaluation is very, very crucial in case of neuro-ophthalmology, checking for RAPD in the daily clinical examination for every patient can lead to a proper diagnosis of a neuro patient. So how we'll do it? We'll shine the light in one eye. So pupil should constrict in direct and consensual eye. as the response of direct and consensual. If the patient, if the pupil fail to constrict, instead of that, it dilates while swinging the light, the patient is having RAPD. RAPD, if there is no RAPD, means there is something happening before the pupillary pathway, like in case of drug-induced or cataract, or due to mydriasis, or it is happening something behind the lateral geniculate body, or something happening with the efferent pathway. Then we have to check for cover test. Cover test is done by cover and uncover test, covering one eye and checking for the fellow eye for the movement of the eye. There are some occluders which has translucently seen by the examiner, so we can see both the eyes movement. So inward movement of the eye is suggestive of exodeviations, outward movement of the eyes suggestive of esodeviation, upward movement will be suggesting of the hypodeviation, and downward movements will be suggesting of the hyperdeviations. Then we have to check EOM, extraocular muscle checkup, in all 9 gazes. This will give us the suggestion. This will give us a suggestion of which muscles is affected, and based on that, whichever nerves is involved, we can able to find out. Diplopia charting, if the patient is complaining of diplopia charting, where we can't do HES charting, which is not practically do HES charting every time, we can do in the clinical setup itself diplopia charting. Recording the diplopia in all 9 gazes will be very, very useful. Patient will be asked to wear a goggle with a red and green filter, and the streak of light is shown in 1 meter distance, and ask the patient to see whether they see fused light of red and green, or it is separated. Mostly if they have fusion, they will see either the fused light of red and green, or either one of the light they will see. If they feel separation, they will see the distance, and they will see any torsional displacement of the lights. We can ask them to approximately quantify the distance and the torsion of the light, red and green lights. Visual field assessment is very important in evaluation lesion involving the visual pathway. So visual field defects, we know it's where, as the visual field constriction happens, our daily life starts to interrupt. We'll have difficulty in walking, even going around, reading, everything. Our daily activities will be affected. So visual field must be tested in the lesion, every patient with the lesion of the visual pathway, either the first baseline and in every follow-up. Here are some example of visual field pathway and its visual defects. I'll be going a little faster on this. If the defects happening in the optic nerve, we can see both the temporal and nasal fiber of those eye is affected. So patient will be having a monocular blindness. If the defects happening in the chiasma, in the middle of the chiasma, here we can see only the nasal fiber are crossing and getting affected. So we'll have a field defect, opposite field defect. So if the nasal fiber is affected, patient will have a temporal field vision in both the eyes. But here we can see patient is having a defect in the chiasma, but the temporal fiber of the left eye is affected. So patient will be encountering nasal field defect of the same eye. If the lesion happening anywhere in the optic tract, both the one eye temporal vision and one eye nasal fiber is affected. So they will have the one eye nasal field vision defect and one eye temporal field vision defect. If there is a defect happening in the optic radiation, either if it is involving both superior and inferior, patient will have an homonymous hemianopia with a macular sparing defect. I've jotted down some common cases and their field defects, like papillitis will have central scotoma, central cecal scotoma, paracentral scotoma, blind spot enlargement. And retrobulbar neuritis will have a sectoral scotoma, ring scotomas. The neuroretinitis cases will be seen with the central scotoma and central cecal scotomas. Papilledema, which is a very common optic nerve disease, where we can see swelling of the nerve. So there will be correlated with the blind spot enlargement and peripheral constriction. Sometimes if it is severe papilledema, we'll see a total loss of vision. In NAION, patient will have an altitudinal vision defect. There are some other ancillary investigation I'll be suggesting for the neurooptometry cases like OCT. OCT is very a very important and very useful tool, because it will give us a site of the lesion and which layer is affected, and OCTA will be showing us as peripapillary perfusions of the nerves, blood vessels. Fundus photos, we can see which type of lesion we have, cotton wool spots or any drusens, and site of the lesions. FFA will show us any venous thinning or ischemias or any leakage happening within the optic nerve. VEP test is an electrophysiology test that is designed to measure the function of the optic nerves. VEP measures the electrical signal generated from the visual cortex in response to the visual stimulus. Thank you for the opportunity. Thank you once again.
Thanks, Ms. Jabin Jafar, for this wonderful talk on neurooptometry, which I believe it's a little complicated topic, but you made it very simple and understanding as well.
Thank you.
Now, I call Ms. Shahida Shamsuddin to speak on unique topic, gravid and postpartum patients eye care. And this is the last topic of this session. She graduated from Sam Higginbotham University. She is pursuing MBA in Healthcare Management. She is ex-lecturer in LF MRC Kerala. Currently working is Senior Optometrist in Sheikh Khalifa Medical City, Abu Dhabi. She has special interest in pediatric vision care, orthoptics, contact lenses. She is a member of Emirates Medical Association and Indian Optometrist Association, and she is also a core committee member of UIOF. Over to Ms. Shahida.
Thank you, SQ, for the warm introduction. Now I will move on to my slide. Can you see my slides?
Sharing mode. Yeah,
are you able to see?
Yes, carry on, please.
Okay, a very happy World Optometry Day to all. Optometry is an art, not only an art of prescribing glass, but understanding the pathology and to do the proper diagnosis and do the proper referrals for excellent patient care. Today I will be depicting on the gravid and postpartum patients' eye care. Abnormal stress is placed on the body during pregnancy, creating potential for eye and related conditions and complications. I will be depicting on some common ocular changes during gravid and postpartum period. So my main aim is to give an awareness to those optometrists working in as an independent practice and in retails, not to skip any detailed history, and to do the proper evaluation and to do a proper referral to avoid any fatal conditions in pregnant patients. So stages overview. This is the just the overview of the all trimesters. Postpartum period is considered after delivery from 6 to 8 weeks, and sometimes it may be more as per the recovery time. Ocular manifestations can be divided into 3 groups. That is the physiological changes, pre-existing ocular pathology, and pregnancy-specific changes. Physiological changes. The main things we will see over here are cloasma and melasma, that is the extra pigmentation on the skin surface, which will be fading after the postpartum period. The main reason for this is due to the overproduction of the estrogen, progesterone, and melanocyte stimulating hormones. So in some cases, you will see some unilateral ptosis. Proper ptosis evaluation is needed in these cases. Ms. Jabin has given insight on all these tests, proper tests for the optometrist to be done. So I'm not going in detail on those things. Now, the ptosis usually, the dryness, it is mainly due to the destruction of acinar cells of the lacrimal gland by prolactin. Reduction in the IOP is normally seen in some cases, mainly due to the increased aqueous outflow, decreased scleral rigidity, increased tissue elasticity, and general acidosis in pregnancy time. Decreased corneal sensitivity is more evident due to the water retention in the cornea and alterations in the corneal curvature, and refractive index changes may occur, which in turn causes changes in refractive error, increasing in late pregnancy and resolves after childbirth. Increase in lens curvature may cause a myopic shift and a temporary loss of accommodation and insufficiency during pregnancy. Therefore, new eyeglass prescription and contact lens prescriptions should be avoided. But in very needed cases, very high prescriptions, same as the case we treat with the diabetic retinopathy patients, by giving full awareness, we can prescribe the glasses. Refractive surgery is contraindicated during this period. Visual field changes are noticed in some cases. Normally, pituitary gland grows physiologically, but in some cases, it can lead to bitemporal field defects, mainly in those cases of an abnormal anatomical relationship between the pituitary gland and the optic chiasma. Gestational diabetes carries small risk of developing diabetic retinopathy. Let's go to the pre-existing ocular pathology. So diabetic retinopathy, it is classified into two types, that is the non-proliferative as well as the proliferative. In non-proliferative, it is the early stage of the disease in which symptoms will be mild and non-existent. In NPDR, the blood vessels in the retina are weakened, and tiny bulges in the blood vessels called microaneurysms appears. It may leak fluid into the retina, and this leakage may lead slowly to the swelling of the macula. Proliferative diabetic retinopathy, this is the more advanced stage of diabetic eye disease. It happens when the retina starts growing new blood vessels, which will be too fragile, and this condition is known as the neovascularization. If they only bleed a little, it might be seen as a little floaters, but in worst case scenario, it might be affecting the vision a lot. Macular edema usually resolves postpartum, but may remain in some cases and cause long visual loss. These are the images of proliferative retinopathy. You can see the diffuse intraretinal hemorrhages in all the four quadrants. The other image, you could see this patient had a previous laser done, and you could see notice all the changes of the diabetic retinopathy. This is a case study of a pregnant lady in 15 weeks of gestation. Visual acuity was 6/18. You could see small little changes in the fundus photo and small cystic changes in the OCT image, but in the 20 weeks of gestation, it got worsened, and the visual acuity dropped to 6/36 with a large macular edema. So recommendations are baseline exam in first trimester. Patients with background retinopathy should visit ophthalmologist at least once per trimester. Pan-retinal photocoagulation may safely be administered. Anti-VEGF is not that indicated during this time. Laser treatment before pregnancy in patients with proliferative diabetic retinopathy could reduce the risk of progression. Pituitary adenomas, mainly it may grow during pregnancy. The visual symptoms are low visual acuity, headaches, visual field changes, mostly by temporal defect. Rarely diplopia may occur. In those cases, proper orthoptic evaluation is necessary. Monthly ophthalmologic examination and visual monitoring is recommended to monitor the tumor growth. Meningioma may vascularize and grow in the second trimester. Uveal melanoma, higher incidence and reactivation rates has been reported in pregnant women. Graves' disease it is the most common cause of the hyperthyroidism. It exacerbates during the first trimester and postpartum period. It requires multidisciplinary monitoring, including the oculoplastic, orthoptist, orthoptic evaluation, optometric evaluation, everything, and to do a proper referral. Toxoplasmosis, pregnant women who are infected with Toxoplasma gondii parasite can pass the infection on to the unborn child. Fetus is severely affected in first trimester. However, transmission rate is more frequently seen in the third trimester. Latent infections in mother may occur, may become active in later stages. Early infection in the first trimester can cause serious outcomes, including seizure, jaundice, and ocular toxoplasmosis. So this is the picture of the toxoplasmosis. The parasite causes inflammation at the back of the eye, causing posterior uveitis, and it will be seen as a fluffy, creamy white lesions on the retina. After the lesion resolves, gives a characteristic scar-like appearance. Idiopathic intracranial hypertension progress with weight gain. Common symptoms are headache, nausea, vomiting, and ocular findings are blurred vision, scotoma, photopsia, diplopia, and retrobulbar pain. Papilledema is apparent during the fundus examination. Recommendations are to do the proper fundus evaluation, visual field test. We could notice a small enlargement of the blind spot area as per the degree of affection. And the orthoptic evaluation is necessary in case of diplopia. The picture you could see the tortuous blood vessels and non-defined margins of the optic nerve. Moving on to Koyanagi-Harada syndrome, Dr. Madhav Rao has already explained about it. It is characterized by bilateral granulomatous uveitis, exudative retinal detachment, meningeal symptoms, hearing loss, and pigment loss in the skin. Usually, it is reported to regress, but it may vary according to the cases. This is a case scenario. Uveitis, increased endogenic steroids, along with the multifactorial and complex mechanism, cause both ocular and systemic signs of the non-infectious uveitis to subside, and attack frequency decreases. Again, it will vary depending from patient to patient. However, recurrence occurs after some months of the delivery. Posterior scleritis usually worsens and recurrence increase during pregnancy. Standard treatment is oral steroids. Subtenon transnelone is recommended for pregnant ladies. Pregnancy specific changes, these are the most important and fatal things which we should carry on our mind. Preeclampsia, that is typically develops after the 20th week of pregnancy. It is a condition in which the patient experiences high blood pressure, more than 140 systolic and 90 diastolic pressure. Protein in urine, swelling, headaches, and blood visions are seen in these cases. Preeclampsia puts stress on your heart and other organs and can cause serious complications. It can also affect the blood supply to the placenta, impairing the liver and kidney function, or cause fluid to build up in the lungs. Eclampsia, it is a severe complication of the preeclampsia associated with some seizures during pregnancy. This is the picture of, you could see the swelling on the leg and you could see the impingement of the fingertips. This is the case of papilledema. You could see it is obvious in this case. Now, blurred vision or decreased vision for photopsia, scotoma, diplopia, visual field defect, cortical blindness, all these are the symptoms. The appearance of signs of acute hypertensive retinopathy, such as arteriolar constriction, retinal hemorrhages, cotton wool spots, retinal edema, and lipid exudates in fundus photography necessitates the immediate referral to for the evaluation of the preeclampsia and eclampsia patients. Central serous retinopathy, that is the fluid field detachment of the neurosensory retina due to the focal leakage in the retinal pigment epithelium level. Symptoms can vary from halos to blurred vision to severe central vision metamorphopsia. We could do the Amsler's grid test in these cases. Recent studies has shown an increased risk for CSCR during pregnancy due to the increased cortisol levels and other hormonal variations in pregnancy women. CSCR can occur in all trimester of pregnancy and usually resolves postpartum without any treatment. But in some cases, proper treatment is necessary too. It can recur in subsequent pregnancies too. This is the image. You could see the pigment epithelial detachment and the subretinal fluid in this case, and it got resolved in the later stage. HELP syndrome, hemolysis, it is as if the name indicates syndrome. It consists of hemolysis, elevated liver enzymes and low platelets. It is a severe variant of preeclampsia and eclampsia. Patients with HELP syndrome can experience visual symptoms ranging from minor visual disturbance to acute visual loss. Contributing factors include retinal artery and vein occlusions, serous detachment, and other cases. The superimposing of HELP on preeclampsia and eclampsia can lead to the neurological damage in the form of occipital lobe infarction, finally causing the cortical blindness. So cortical blindness, it is defined as the loss of vision without any ophthalmological causes and with normal pupillary light reflexes due to the bilateral lesions of the striate cortex in the occipital lobe. It is a part of the cerebral blindness defined as loss of vision secondary to damage to the visual pathways posterior to the lateral geniculate body. Most women with cortical blindness recover full sight postpartum, usually after 48 to 72 hours, but it can vary too. Residual retinal signs like Elschnick spots, pigment epithelium changes, and optic atrophy may occur. So my conclusion is physiological ophthalmic manifestations are common in pregnancy. Proper evaluation is necessary, and just refer to the proper multidisciplinary teams to avoid the fatal conditions. That's it. Thank you. These are my references. Now, we will just skip the panel discussion. Just all the participants just answer the poll questions. Over to you, host. Am I audible?
Yeah. Thanks, Shaida, for moderating. We have come to the end of this OPTOVERSE 3. This session is going to be something unique and interesting. Our last session of the day is New Era of Eye Care. Welcome to Future. Technological advances have inspired numerous multidisciplinary groups worldwide to develop visual neuroprosthetic devices that could potentially provide functional vision and improve the quality of life for blind people. Visual processors, including artificial retinal implants, are a novel and revolutionary approach to profound visual loss. Let's learn something new today from the experts in this field. I welcome our esteemed speaker, Dr. Omnia, Senior Consultant from Zayed Military Hospital. She'll be talking on iWatch implant device. Over to you, Dr. Omnia.
Hi, good evening. So I'll share my screen.
Good evening, Doctor.
See my screen?
Yes, Doctor. Yes, we can see your screen. Please continue.
So I'll talk today about something really interesting about the iWatch implant. I have no finance and device. The iWatch implant, it's a new glaucoma implant. It has the CE approval, but not yet FDA approved. And it's the first implant adjustable where we can adjust the ocular pressure. Invented by Rion Medical, it's a company from Switzerland, and the first implant being used by Professor Andre Mermoud in the 15th of September 2005. So we have it like now 7 or 8. What's the difference in the iWatch? It's a a glaucoma implant, but with the pen, magnetic pen, which can control the ocular pressure. Here, this is the system. We have magnetic part, the tube, and the plate, and we can adjust the tube by this magnetic. The magnetic is here, so this is the watch, and we close it and we open the tube. And control it. We control it from outside, post-surgical. So when we have the arrow on 0, it's open. It's fully open. We turn the magnetic, and now it's totally closed. So this device contains two parts: the eye watch pen, which controls the watch itself, or the magnetic part in the implant. Watch implant, as I said, which is 3 parts: the watch and the plate, the tube and the plate. There's 2 more of this implant. Plate has the size 200 and micron, and the other plate was 300. We are using now plate 200, and both of them, they are exactly the same. The only difference is the size. Here's a small comparison between the Ahmed valve, the most common, and this is the valve tube, but we don't have any control on this valve tube. We have the Bervelt, which is non-valve tube, the pole, and here on the right we have the eye watch. So the eye watch, it's a valve tube, but we have control on the flow, and this which make it like combination of pole, Bervelt, and Ahmed tube. Here I have small one of my first tubes. It's exactly the same. We do for the conjunctiva. Deep dissection, because we have it's a little bit bigger than the other tubes, as it has 2 parts. We separate the muscles. We insert the plate. So this is the white part, the plate part, and we fix it as any other tube. So this part is exactly the same as any as all the drainage devices. And we have to fix it well as any other device as well. And this is actually the part which is unique about the iWatch. We have to create another place for the watch. So what we put it is the plate, and now we have to create. We have to do dissection, deep dissection, to implant the watch itself. This dissection has to be deep enough. And this actually the part which is extra in the iWatch, and it's make it a little bit longer procedure than any other. The nozzle or the anterior chamber part of the tube, and here there is flow. This means that the watch is open. This pen during the surgery, that watch is open. The arrow on 0, so we need to close it during the surgery. One of the challenges that we have to use, now it's closed. Instrument which is not magnetic, so it will not affect the direction. It will not affect the direction. Then we have to connect. We cut the tube. We have to connect the plate with the watch itself. So this is the full surgery. Now we are sure that it's closed. Normally we keep it closed and we open it next. So this is the tube itself. As we it's open again. Here in this video, just I'm showing the stamp. We stamp we have in the box stamp, so we stamp the place where we'll put the watch itself. So what's the data in UAE? We are the 7th country worldwide to use the iWatch, and the surgeon number 12 from UAE. So we have 4 surgeons already from UAE use the implant. So far we implanted 8. I did 5 of them, and this is the adjustment of the iWatch next day. So here we check his pressure 27, 29. This is next day put up. So to open the watch, we will use our pen. We turn the magnetic part to open it a little bit. We check pressure again. The pressure is 3. So still we close it. This was my first patient, so I open, I close, I open, I close several times until I get the pressure I want. So what's the nice about it, that you can adjust and you can choose your target IOP for your patient using this device. What's the unique about it, that there's no hypotony, because you can control the flow, which is much more common in certain tubes. It's non-invasive adjustment. You adjust the pressure in the clinic with the iWatch pen, and you can choose your target IOP. No corneal touch, and this part I'll explain it in the next slide. Here we can see the nozzle. The nozzle is the part which is in the anterior chamber. What's unique about it, that it's rigid, it's not mobile. So we have less chance to have corneal touch, as well less chance to have endothelial cell loss, and has been studied already. And here, just I'm sharing with you the most surgeon who use the iWatch worldwide, and they conducted already clinical study for more than 200 patients over 5 years. And here they compared mainly the iWatch with the they compared the iWatch with the Ahmed valve. So we had 0 hypotony with the iWatch, and they have more success rate after 5 years compared to Ahmed valve and this complication. This is what's unique again about the endothelial cell count. The Ahmed valve and the Burwell, they have a bigger tube, flexible, and the chance of the corneal endothelial cell loss is more. It's around 12% with the Ahmed valve, 13% with the Burwell valve, as the Burwell tube is bigger than Ahmed tube. While with the iWatch, we have less than 5% of endothelial cell loss. This is our data. Here, the 5 patients, the first 5 patients, the pressure pre-op around 30, 45, or 30. And for the first month, the pressure was great. For the 3rd month, it started to increase for my first patient and my second patient as well. I had one patient who had exposure, plate, not the plate, the watch itself. The fibrosis happened in patients, but it was controlled finally. I needed to add some more medication with the first patient, and I did diode with the second patient. When I had those complications or the challenge to adjust the tube for the first two patients, I decided to go to see Professor André Marmoud, and he's the first one who used this implant. He implanted more than 100 so far of iWatch. I did one of the surgery with him just to learn and to more about my mistakes and to learn how to adjust the tube post-op. What I learned, AC maintainer is must with the tube, deep scleral flap, so the watch will be much more stable. And for our patient, they have in our region actually very fibrotic conjunctiva. So we need maybe to open the iWatch earlier than what's happening actually in Europe. It was a nice experience. Everyone was talking about the iWatch when I implanted first time. I wasn't expecting that. It's a device, I heard about it many years ago, and I was really interested to use it. But I was really surprised when I knew that I received from the company itself that I'm the surgeon number 12 worldwide. And this is the photo we took with the first patient. So we implanted the first patient in the Middle East. And I was honored really to do it. So the conclusion, it's a very elegant device, unique. I will not say that I will do it to every one patient. Still, I think we cannot use it for patient with the silicone oil because it can be blocked. I don't think it for patient who will travel. It's give good results with the uveitic glaucoma patients. Still, we are learning how to choose our patients for the iWatch. Yeah. Thank you.
Thanks, Dr. Omnia, for enlightening us with this new advancement in field of ophthalmology. And thank you, ma'am, for your precious time in your busy schedule.
Thank you so much.
Now we'd like to call Dr. Satya Kakre for his talk on retinal prosthesis. This is the last talk of this session and today's evening also. He is specialist ophthalmologist and vitreoretinal surgeon based on Abu Dhabi with more than 7 years of experience in UAE and 16 years of experience in retinal surgery. Over to you, sir.
Thank you. Good evening, my dear friends, and a very happy World Optometry Day to all of you. And I would thank the team OPTOVERSE for giving me an opportunity. Am I audible and is the screen visible?
Yes, sir.
Yeah. So I don't want to really come in between your sleep. I'm sure it is pretty late. So having said that, I would definitely try to quickly run through the presentation. So today, this evening, I would be talking on retinal prosthesis, which happens to be a real vast subject. So I will try my best to make it as condensed and as short as I can, and at the same time, make it more understandable. So why should we actually be optimistic about retinal prosthesis? The success of cardiac pacemaker as neural prosthesis, the cochlear implant for hearing loss has certainly given more interest to biomedical engineers to ponder about the hope of having an retinal prosthesis in order to overcome blindness. At the same time, the rapid development in VLSI, that is very large scale integration designs, the microfabrication technology has made way for retinal prosthesis. So when we talk about retinal prosthesis, most of the time they say that, yes, well, is it bionic eye? So what is actually a bionic eye? Bionic eye is nothing but a bioelectronic eye. It is an electronic device which replaces functionality of a part or whole of the eye. So it is basically used for replacing functionality or adding function to the eye. So the most important thing when we talk about retinal prosthesis is you should understand the anatomy of the retina. To oversimplify it, as you know, this is the vitreous cavity and this is the sclera. So when you go in outwards, you have the light rays which enters, and the first part of the cycle is the light entering the eye triggers a photochemical reaction in the photoreceptors at the back of the retina. That is the outer aspect of the retina. This in turn causes chemical reaction in turn to activate the bipolar cells, which is in the middle layer of the retina. And this information is sent to the visual cortex via thalamus through the inner retinal layers. So essentially, in most of the disease like retinitis pigmentosa, as well as in age-related macular degeneration, there is a loss of photoreceptors. But at the same time, the inner layers of the retina is being preserved. So as you can see in this particular photograph, in retinitis pigmentosa, the photoreceptors, as you can see normally, is being preserved in a normal eye, but in retinitis pigmentosa, the photoreceptors are totally devoid. But however, the inner retinal layers happen to be quite intact. So in congenital retinal dystrophies like RP, that is retinitis pigmentosa, the outer layers of the retina where photoreceptors resides are gradually lost and thereby causing progressive visual loss. But at the same time, when you see the histopathology of these patients, 93% of the retinal ganglion cells, they survive. So there is definitely a hope for restoration of vision can be achieved by creating devices and retinal processors that receives and process the incoming light and then transfer the information in the form of electrical impulses. So basically the retinal prosthesis can be of two types. They can be either an epiretinal implant or it can be a subretinal implant. Okay, so what is the difference is when we are talking about subretinal implants, you will have to put the implant in the subretinal space between the neurosensory retina and the retina pigment epithelium. So this is more or less in a physiological position. So with subretinal implants and epiretinal processes, the inner retinal cells are stimulated with controlled electrical currents. So this in turn causes phosphenes or patterned electrical stimulations, which the brain senses and makes it into something which is more meaningful. So when we talk about subretinal implants, these are the implants which are more or less in a physiological position. So hence, that is between the retinal pigment epithelium and the degenerated photoreceptors, and they are made of a microphotodiode array. So when we are talking about this microphotodiode array, this in turn stimulates the photoreceptors and bipolar cells and generates an action potential, which is then carried further upwards along the visual pathway to cause a visual stimulation and visual perception. Here, one thing which you need to understand is when we are talking about subretinal implants, they have to be given power from an external source. So this is an example of a subretinal implant, which doesn't need an external camera or external image processing unit, which has not been required. And the existing eye movements and gaze is sufficient to cause the perception of image. So basically, this is the chip which gets inside the subretinal space, and it carries the function which is more or less physiological. However, when we talk about epiretinal implants, which is more widely being used, this has to be placed over the retina, that is over the internal limiting membrane. But unfortunately, when we are using this epiretinal implant, you need to have an external micro camera, and also it needs a complex image processing technology. So these are this slide shows the available retinal processors which are available in the market, but among them, the most widely used is the Argus 2 retinal prosthesis, which has been manufactured by the Second Sight Medical Products. And this is the second version of the Argus, which is much more advanced. So it has two components, that is the external component and the internal component. And the external component has a video camera, a video processing unit, and a coil. And the internal component has an internal coil, an application-specific integration circuit, and as well as a ribbon of cables. So basically, what is that which is there in the external part of the instrument is you have the goggles, as you can see here, which has a video camera, and over the side of the temple of the goggles, you have the external coil and the video processing unit. So whatever image has been captured by the video camera is then subsequently sent to the video processing units, which in turn is a portable computer the patient can mount on the belly or carry in its pocket. And the patient puts on the glasses and switches on the system, and the video micro camera receives the image as the patient makes scanning head movements. Unfortunately, here you have to put on the goggles and make searching or scanning head movements. The image processor reduces the image resolution and converts them into electrical signals, and ultimately the visual images are converted into a template of electrical stimulation. So when you talk about the internal components of the retinal prosthesis, this is the one which has been inserted in the eye. Here you have three things, that is the receiver coil, the electronic case, as well as the microelectrode array. So basically the receiver coil receives the information which has been sent from the external coil. So this receives, and then this also provides the power source for this whole gadget. So the electronic deciphers the information which has been received by the receiver coil, and then ultimately sends it to the microelectrode array, which in turn stimulates the ganglion cells, and then subsequently the electrical impulses being carried to the visual pathway. So when we are selecting who are the people who are suitable for the retinal prosthesis, the patient should be of a fair medical and psychological condition, and they should be well motivated. The patient's expectation shouldn't be something like he's going to start seeing things perfectly well, as though it is after a cataract surgery or something of that kind. No, certainly he is going to just see something which is very, very basic, wherein which he can carry on his day-to-day activities. Both the patient and the family members should be ready and capable of carrying out the long and challenging process of visual rehabilitation, and special preoperative training of the surgeon, medical personnel, and the technical staff is essential. So after the particular procedure has been conducted, 15 days later, we have to do the calibration of the instrument, and then the individualized stimulation programs are created and uploaded to the visual processing unit. And after that, the rehabilitation process starts, wherein which the patient is able to find out the direction of the movement, orientation, and to some extent, it will also augment the mobility of the patient. So coming to the optimal candidates for Argus 2 is that there should be a significant amount of viable retinal ganglion cells, and the patient should have a vision at least of light perception. So this could be determined by the positive camera flashlight test, and also the patient should have had a past experience of seeing shapes. And the patient should be at least 25 years of age, because the chip and the whole implant itself is suitable only for adults. So there should be a globe length of at least of 20.5 to 26 millimeters. And there should not be any strabismus or nystagmus, and there should not be any macular staphylomas. So this is a photograph which is showing how the ocular part of the prosthesis has been implanted. And after implant on the macula, you can see the photo array which has been placed. So this is what it looks like. So what is that which you can see after having a retinal prosthesis? Is that the patient going to have 6/6 vision? Certainly not. The patient is going to have a very, very basic level of vision. And most of the times, it is of the order of something of 20 to 1260. So it is also seen that when you on the prosthesis, the patient is able to carry on most of the day-to-day activities like finding the door and also walking in a line tracking. So to conclude, the studies of the Argus 2 epiretinal prosthesis performed to date have demonstrated that it is safe for long-term purpose and also has potential benefits. It is also seen that, whatever little bit of missing information which has been there, the brain compensates in order to see. And also, the Argus 2 seems to be showing promising results. And for those individuals who have advanced glaucoma or patients who have progressive ganglion cell loss, they can be overcome by having cortical implants to overcome this. So these are my references. If there are any questions, I have tried to simplify the whole thing. If there are any questions, I'm ready to take.
Thanks, Dr. Chatya, for such an informative and unique topic. It was a wonderful talk. Thank you everyone for joining today's evening. Thanks to all our speakers, moderators, and all the team members to make this happen. In this occasion, we would like to announce for our next event, OPTOVERSE 4, the first ever International Optometry Conference in this country, UAE. Save the date, 14th October 2023, Dubai, on the occasion of World Sight Day. Please follow our website for more updates. That is www.optoverse.site. A special thanks to Dr. Omnia Hammam for your never-ending support towards our community. Now I call Ms. Devkani to share vote of thanks. Over to you, Devkani. You are muted, Kani.
Just. Okay, sorry. Thanks, SK. On behalf of OPTOVERSE, I'm happy to express our great thanks to each and everyone who supported this journey. A very special thanks to our prestigious Emirates Society of Ophthalmology for their continuous support in making this event happen for the third time, marking special events. Great thanks to IONCARE for your contribution, which was vital to continue our important works. We cannot have succeeded without such a generosity of supporting people like you. A sincere gratitude goes to our distinguished speakers for sharing their valuable inputs and their expertise. Thanks again for accepting our invitation and for being here with us today. Its attendees and participants like you make presentation awesome. Thank you so much for your unwavering attention throughout the presentation. A big round of applause to UIOF and OPTOVERSE organizing team for their hard work and working round the clock to make this event successful. Meet you all in our OPTOVERSE 4 event, which is scheduled in October 2023 to mark World Sight Day, and this will be an on-site event. For CME certificates, kindly visit OPTOVERSE website and fill out the feedback form. This should take around 10 working days. Meet you all soon in OPTOVERSE 4. Thanks again.